I just would like to start with a kind of just a very short presentation about the history of the IBD Retreat, which started in 2014, maybe 2013, because when I arrived at Sinai, I was thinking people are really working in silo, and the goal was to bring everybody working on IBD all together, and it has worked amazingly. But this was the first IBD retreat, and this is the only thing that people remember, which was a French cake that I brought to the meeting. Then we got organized, and we had 15, 16, 17, and in 2019, we had our first external speaker, Ted, with here, and in 2020, we had an uninvited speaker. And then the meeting was canceled. Then in 2021, we had Tine and Bram, Scott and Raya in 2022. We had Ari and Vip in 2023. And then we had Ken and Salome 2024, Brita and I'm blanking on his name now. Mike in 2025. And this year, we are so happy to have Marcus who is coming especially from Germany to attend this IBD retreat. Thanks a lot, Marcus. This is amazing. And Rafa from Augusta, so in Georgia. So I want to really thank all our corporates. You can see the name here, Takeda V, Johnson, Genentech, Pfizer, Lilly, Merck, and Sanofi. And I really want to thank Erika because she has been instrumental to organizing everything. And now, Toram, the floor is yours.
So I think very briefly, just another vote of thanks to Erica. Thank you all for being here. Good morning. We've all, it's a honor and a privilege that both Marcus and Rafa are here. Many of us already know well about Marcus, but in brief, he is highly accomplished. He studied medicine at the University of Marburg. He was a resident at the University of Mainz, and then he came to the US to NIH, where he worked with Warden Strober as a postdoctoral fellow. He eventually did a guest professorship at Harvard Medical School. And in 2007, he was appointed as head of the Department of Institute of Molecular Medicine in Mainz. And then from there, in 2009, he was nominated as the chair of internal medicine and head of Department of Medicine at the University Hospital of Erlangen, where he stays until now. Marcus has made numerous seminal observations and studies in the field of immunology as well as inflammatory bowel disease. He's consistently published in top-tier journals, focusing initially on the role of T cells and cytokines. And more recently, he's taken an interest in targeting B cells and has really revolutionized the field. So it's a true pleasure. Marcus, thank you for coming, and over to you. Yes.
So good morning. First of all, I would like to thank Jean-Fred Sauerab for the kind invitation here to New York. It's always a pleasure to be here. I was asked to talk about immunotherapy, cellular immunotherapy for IBD. And before I start, I want to briefly remind you of the key clinical problem that we are all facing in the clinic. We see many patients failing biological therapy. So here you see using endocytoscopy, dense cellular infiltrate, a crypt abscess in a patient with ulcerative colitis failing vedolizumab therapy. So I think it's clear, because many patients fail established therapy right now, that we have to understand more about the pathogenesis of IBD. And what our current concept tells us is that we have key environmental factors. And if the wrong environmental factor hits a susceptible genotype, we have initiating triggers affecting the barrier function. And we believe that both disorders are characterized by altered barrier function, allowing translocation of bacteria and bacterial products, leading to immune cell activation. Then you have pro-inflammatory immune response based on innate cells, but also adaptive immune cells. And this is counteracted by regulatory response. And depending on the outcome of this trial, you have chronic inflammation or resolution of inflammation. And chronic inflammation is clearly the driver of the complications of the disease, such as colitis-associated colon cancer, fibrosis, stenosis, fistula formation, and so on. The barrier alteration is also key for systemic inflammation in IBD. We have translocation and migration not only of immune cells, but we have also trafficking of cytokines through our body, contributing to systemic inflammation. And we have trafficking of outer membrane vesicles from bacteria. And all these mechanisms contribute to the systemic inflammation that we see in our patients with IBD. Based on this concept, we usually treat IBD by targeting the immune system by neutralizing cytokines or cytokine signaling. And the other possibility is that we target the trafficking of immune cells, for instance, by integrin antibodies or S1P modulators. So my work in recent years has been focused on understanding the drivers of resistance in the tissue. And if you try to focus on the single cell papers that have been published in the field, you see that they have all highlighted the presence of immune cells as a key contributor to resistance in the tissue. There's a stroma signature from fibroblasts, but also macrophages and neutrophils, and they instruct the adaptive immune system, for instance, by producing chemokines or cytokines. And the question is now, how can we tackle this concept that we have angry, activated cells in the tissue that cross-react with each other by numerous mediators. So one option is obviously now to develop new biological agents or small molecules, or to pursue advanced combination therapies. And I think Bruce will talk about that later. So in my talk today, I will focus on another approach, namely cellular immunotherapies, where we could try to modulate the pro-inflammatory immune response in IBD patients, for instance, by administering regulatory T cells or anti-inflammatory TR1 cells, or by administration of CAR T cells. So first I will show you some of our data on Tregs. Fiona Powry studied many years ago the role of Tregs in IBD, and has become very clear that Tregs are anti-inflammatory in the context of experimental colitis models. These Tregs can suppress effector T cell activation, but they can also suppress the activation of antigen-presenting cells such as dendritic cells, macrophages, or B cells. In our concept, we were interested in expanding autologous or syngeneic regulatory T cells, and that's what we did in this study. We expanded these cells ex vivo in the presence of TGF-beta, and then used these expanded regulatory T cells to treat experimental colitis activity. And as you can see here, this worked quite nicely. So how can these Tregs work? Well, they migrate to the inflamed tissue. We have shown this using in vivo migration assays, where we labeled these Tregs, injected them into the ileocholic artery from mice with experimental colitis. And you can nicely see that these Tregs then leave the vessels and they migrate into the tissue. And obviously, this led then a growing interest in human studies. And the first human Treg trial in Crohn's disease was in fact conducted by Jean Fred's group, as you can see here. So they pursued another idea. They used off-albumin-specific Tregs. They isolated these cells. They expanded them after exposure to off-albumin, and then gave them intravenously to patients with refractory Crohn's disease. The safety profile was actually good. So the cells were well tolerated, and they observed response, clinical response in patients, a clinical response in patients as shown here in a subgroup of patients. So they concluded that the administration of antigen-specific Tregs is well tolerated and had dose-related efficacy. So we pursued another concept. We expanded autologous regulatory T cells under GMP criteria, as shown here. So we did a leukapheresis, we isolated the Tregs, we expanded them in vivo, and then adoptively transferred them to patients with a timeline from vein to vein of about 7 to 8 weeks. We did a single dose escalation study using 0.5 times 10 to the 6 up to 10 times 10 to the 6 Tregs per kilogram of body weight. This was a very severe patient population, as can be seen here. So you see that all of them had been treated with thiopurines before. More than 90% had received anti-TNF, vedolizumab, more than 70% ustekinumab, and many of them also had failed JAK inhibitors. So we treated overall in this phase 1 study 11 patients. Here you see the clinical response. You see a subgroup of patients responds quite well with a reduction in full Mayo score at week 4, which was significant, and this response was maintained until week 12. So we saw some quite interesting single cases. So one of them is shown here. So this was a young woman with active ulcerative colitis and ulcer formation. She received Tregs, and the endoscopic score went down. Also, the NORC score went down, and the fecal calprotectin levels went down. Interestingly, she also suffered from concomitant primary sclerosing cholangitis, and here we saw that at least for 4 weeks, her liver enzymes fell quite significantly, but then came back to normal or previous levels. We also did single cell sequencing. I will not show you all these analysis in detail due to time constraints, but we found that in responders, we saw Treg activity markers in the tissue. We saw signatures of tissue repair and barrier restoration. And in the non-responder, we found 2 dominant signatures. One was an NF-kappa B pathway, and the second pathway was plasma cell markers. So obviously, there's a strong B cell response in the non-responders in this scenario. So I've shown you data from the phase 1 trial. We have already got approval for a phase 2 study where we will have larger patient populations, where we will be able to repetitively treat patients with Tregs, and where we will label Tregs to understand what happens with them in the tissue. We have also ideas how to improve this approach. So one approach is to engineer these Tregs and to express homing markers, allowing these Tregs to migrate rapidly into the inflamed tissue. This is shown here. So what we have done is to design GPR15 expressing Tregs by, for instance, lentiviral gene transfer. And what you can see here is that these Tregs are active and they migrate better into the tissue than control transfected cells, and they adhere much better to capillaries, as shown here in this adhesion assay. Another issue is that we could potentially change the tissue residency of these Tregs. So here we have shown recently that cytokines such as IL-3 determine the tissue residence of Tregs. IL-3, in fact, controls the deformability of Tregs. That's actually shown here, where we have IL-3 deficient Tregs versus IL-3 receptor competent Tregs. And you see that the deformability of these cells changes dramatically if the IL-3 receptor is inactivated. So the IL-3 signal is really a signal for the cells to be stiff, to stay in the tissue, and they can no longer leave the tissue through the lymphatic system. So what are the other concepts in the field? So one obviously concept is to use low-level IL-2 to expand the Tregs in vivo. Another approach is TR1 cell therapy. I cannot show you the data because this is data from a company called TR1X. And if you look at the homepage of this company, they have ongoing trials using TR1 cells in chronic inflammatory diseases such as GVHD and Crohn's disease. So what is the difference between TR1 cells and the Tregs? So this paper here in Gastro look at this difference, and they found that TR1 cells can also suppress T cells like Tregs, but they can also suppress myeloid cells, and they suppress secretions of IL-1 and TNF from these cells, and they can also promote IL-22 production, which may contribute to improved barrier function. So it remains to be seen what the outcome of this trial will be. The interesting point about this trial is it's an allogenic product. So the idea is that these cells are so tolerogenic that they will not be attacked by the body's immune system. So in the last part of my talk, I will talk about CAR T cell therapy. So there are several studies in the field suggesting that CAR T cell therapy may be relevant for treatment of autoimmune and chronic inflammatory diseases. And several papers among those lines have shown that in patients failing biological therapies as a signature of B cells, that has been shown by Saurabh, for instance. It has also been shown here in this Cell paper, where there's a module of IgG producing plasma cells, which strongly correlates with resistance against anti-TNF therapy. So why should you think about CD19-directed CAR T cell therapy? What are the pros and what are the cons? So the negative parts is that rituximab was not effective in ulcerative colitis at all. There are also theoretical concerns. If you suppress B cells in mouse models of colitis, usually you have activation of the disease due to inactivation of regulatory B cells and suppression of secretory IgA, leading to altered barrier function. Furthermore, we know that there are cases of CAR T cell associated enterocolitis occurring after CAR T cell therapy. So it's a known complication of CAR T cell therapy. And so there are potential reasons to think that CAR T cell therapy targeting B cells is not a good idea. On the other hand, I think there are good reasons to suggest that CAR T cell therapy might work in IBD. We know that basal plasmacytosis is a histologic hallmark of ulcerative colitis. You see here this plasma cell infiltration in a patient with a refractory disease. We know from Saurabh work that B cell expansion, autoantibody production, and plasmablast accumulation occurs in refractory disease and correlates to non-response to several biological agents. And we know that rituximab does not target the B cells in the tissue. It effectively depletes the B cells in the periphery, but not in the tissue. And perhaps you need CAR T cells to induce deep depletion of B cells in the tissue, and this may lead to suppression of autoantibody production, suppression of T cell activation, and suppression of antigen-presenting cells. So what are CD19 positive CAR T cells targeting? So you target, in essence, the entire B cell lineage, with the exception of long-lived plasma cells, which are usually CD19 negative. So you really severely compromise B cell immunity by doing this. And the first patient we treated was a young woman, 21 years old, with refractory ulcerative colitis. So she failed 8 lines of therapy. You see here that she received almost everything which was on the market: TNF antagonists, P40 blockers, oxanimod, vedolizumab, 2 JAK inhibitors, IL-23 inhibitors, cyclosporin. So it was quite an impressive list, and she was never, ever in remission. And she was recommended to undergo colectomy 3 times, and she refused to do so. So we offered her B cell depletion, and we were not sure that CAR T cells would be safe. So we decided to start with a T cell engager first. So we gave her the T cell engager blinatumomab, which is a T cell engager eliminating CD19 positive cells. So it's not a perfect depletion, but it depletes B cells clearly much more than rituximab. So we gave her this engager to see what will happen with disease activity, because here you can be sure that it's a transient effect. You can potentially stop this treatment. It's not like CAR T cells where you cannot stop treatment once you have established the CAR T cell treatment approach. So we gave her blinatumomab 3 times, as you can see here. And in all 3 occasions, the inflammatory disease went down, as shown here by fecal calprotectin levels and here by CRP levels. So we were sure that this was not harmful to the patient. but disease activity always came back. So we decided that we would offer her CAR T-cell therapy, and the result is shown here. So you see that the B cells go down after blinatumomab therapy, but they come back. If you give CAR T-cells, you massively suppress B cells for a prolonged period of times, in her case, for more than 100 days. CAR T-cells expand within a few days after treatment, and then they go down. In her case, it took more than 80 days before we could no longer detect CAR T cells. The clinical effect was extremely striking. So you see here the clinical activity score. She started at the level of 7, and she went into remission quite rapidly and maintained remission. And also the fecal calprotectin levels went down. The CRP levels went down. It was quite impressive. And the same holds true at the level of endoscopy. So here you see the endoscopic images and the endoscopic activity score prior to therapy, and then at indicated time points after CAR T-cell treatment. And you clearly see that the endoscopic activity score went down. And the same was true for the histologic activity index. So here you see the histologic activity index, in this case, the NOC score, also clearly went down after treatment. Next, we look at the level of endoscopy and duplex sonography, and also here you can nicely see that the hypervascularization went down, the bowel wall thickness went down. And if you look at validated ultrasound score, you see that ultrasound-based activity was also clearly reduced. What happens to the immunoglobulin levels? Well, you see that after CAR T-cell treatment, immunoglobulin levels go down quite significantly, but they do recover over time. So patients do know. So this patient did not develop massive deficiency in immunoglobulins. How about secretory IgA? So we were concerned that you would have massive suppression of secretory IgA with potentially impaired barrier function. So here you see the secretory IgA during blinatumomab treatment, and here after CAR T-cell treatment, you see you have indeed a massive reduction of secretory IgA early on. But in spite of that, we did not see an altered barrier function in our patient. Quite impressively, the autoantibodies vanished. So she had high titers of anti-alpha V beta 6 antibodies, and these antibodies were nicely suppressed and could no longer be detected after CAR T-cell treatment. How about mucosal B cells? I told you that blinatumomab does induce some depletion, but is not very effective, and that's also shown here. If you look at the percentage of B cells among lymphocytes in the tissue, you see that it's not extremely effective in depleting B cells in the tissue, and that's the key difference to the CAR T cells, where you really abrogate the B cell response in the tissue. So the next question is this a durable response, and is it a drug-free response? And in fact, this is true. So here you see some additional endoscopic controls of this particular patient. You see the endoscopic score is showing inactive disease. You see the histologic score is inactive. And this patient is now in clinical biochemical endoscopic remission for more than 1 year without any drugs. And I think that's quite remarkable and underscores the potential relevance of this approach. The question is, can we now repeat this? So I can demonstrate you a second patient with ulcerative colitis. So also in this case, was a young patient with multi-refractory ulcerative colitis, multiple previous lines of therapy with cytokine blockers and JAK inhibitors. And this patient was different because she was clearly steroid dependent, so she needed 15 to 20 milligrams prednisolone per day. She had a lot of weight gain, and she had adrenal insufficiencies. She was about to be diabetic. So we decided to offer CAR T-cell therapy. You see this patient had only mild to moderate disease activity, but she had this disease activity in spite of high treatment with steroids. She went into clinical remission quite rapidly, and the fecal calprotectin levels also went down. And also at the level of endoscopy, she showed quickly improvement of endoscopic signs of the disease activity and has now a negative activity score 2 months after CAR T-cell therapy. The interesting point with this case is that the steroids could be quickly reduced We had to replace this with hydrocortisone due to adrenal insufficiency, but now after 4 months, the patient is fully steroid-free, so no prednisolone, no hydrocortisone. She has no drugs at all. She had a lot of weight loss and has resumed full professional activity. So I'm now at the end of my presentation. I would like to summarize how I could convince you that in spite of the limited data that we have right now, that T-cell engagers and CAR T-cells are possible new treatment option in IBD patients. We have used CD19-directed CAR T-cells successfully in 2 cases with multi-refractory ulcerative colitis. The first patient is now in remission for more than 12 months, and the second patient also showed drug-free remission over 4 months now. And I think what we desperately need now is a prospective study on CAR T-cells in ulcerative colitis. Thank you very much for your attention.
Really stunning data on this, very exciting. Mark's patient remarkable. What brings forward? How do you choose patients, 2 patients that what should we be thinking about? How would select patients or response?
Yeah, I think at this point we can only guess, right? So my preference would be to treat multi-refractory patients who have failed conventional therapy. So I think it's way too early to think about something like first-line therapy. We have many good options, so why would we start early on? And we have really treated desperate cases where colectomy was declined by the patients, and where we had always recommended to do colectomy. And yeah, so we have chosen patients with a strong B-cell signature in the tissue and which were autoantibody positive. Whether this is necessary or not, we do not know, but I think it's in the beginning, it might be reasonable to start with this patient population.
Thank you for this excellent talk. My question is sort of related to what Bruce said. Considering the very severe complications and potentially life-threatening complications that can be associated with CAR-T, what are your thoughts on positioning of this treatment modality against colectomy in UC?
Well, with n equal 2, I think it's difficult to answer that. I can only refer to our colleagues in rheumatology, who have treated quite a large number of patients right now. So they see a response rate of about 90%, which is extremely impressive in systemic lupus. They compared the safety profile of CAR-Ts in SLE with leukemia and lymphoma, and they found that this treatment is much safer in SLE, probably because we have much lower numbers of target cell. So the CRS is possible, but it's not as active or as strong as in leukemia patients. And they have never seen a patient with ICANS and neurotoxicity. But neurotoxicity seems to depend on the CAR construct. So there are companies who have that have made CD19 CAR T cells where you can also see neurotoxicity. So there seem to be differences among the CAR T cell constructs.
Marcus, this is transformative, super interesting. I have a question for you and maybe for Ram as well, because we have big interest, of course, in colonic Crohn's disease. Also, as Adi will show that later, and Matthias, alpha V beta 6, because then, you know, the treating patients with refractory colonic Crohn's disease, because in those patients, the only alternative is definitive ileostomy. This will be very attractive as well. So what do we need to extend this approach to refractory colonic Crohn's disease, alpha V beta 6 positive?
Yeah, I think it's a very valid question. So we all know that there's a strong overlap between colonic Crohn's disease and ulcerative colitis. So I think that there are good chances that this approach might also work in colonic Crohn's disease. And also in this patient population, I would start with patients who who are positive for autoantibodies.
Excellent presentation. Thank you very much. I'm indeed following up on the alpha V beta 6 part. So I might have misread it, but the autoantibody levels went down completely. But most of the immunoglobulins maintained a normal level. So what would be your explanation, or how do you see this?
Yeah, so I mean, that was one of our concerns, that you would induce severe immunodeficiency, which fortunately did not hold true. So we saw that immunoglobulin levels go down for a couple of days or weeks, and then they go back to normal levels. So patients are not severely immunocompromised. The reason is probably that this treatment spares long-lived plasma cells in the tissue, which are still capable to make a lot of antibodies. If you look at our colleagues in rheumatology, who also do BCMA targeting, so in this scenario, it's clearly more severe. So it depends really on the target of the CAR T cell. So if you stay with CD19, the advantage, at least in my view, is that you maintain the immune response, immune competence by long-lived plasma cells.
So can we draw conclusions on the origin of some of these autoantibodies then? That these are not coming from the long-lived plasma cells then? Or might that be?
Well, it's a guess. I cannot prove that right now.
Very interesting.
One last question.
No.
Second question. Oh, the second question is just, do you think this is a tenable or potential therapy for Crohn's outside of chronic Crohn's? And if it was, what would be the target?
That's a very good question. I mean, first of all, we did not treat the second patient with a T-cell engager before. And with regard to Crohn's disease, I mean, if you look at the data, it's the literature, the B-cell data is clearly very strong in ulcerative colitis. It's not so strong in Crohn's disease. And within the Crohn's disease population, it's much stronger for colonic Crohn's disease than for ileal Crohn's disease. We do not know what would happen in colonic or ileal Crohn's disease. This remains to be seen. But I mean, the amazing thing about CAR T cells is that you can design very different targets. Maybe you find a better target. I think this introduces really the possibility for our fields to really selectively eliminate certain immune cell populations and to show what they are doing. And that's quite different from our current treatment algorithms.
Thank you very much.
After this excellent talk, we will get started with our first session, which is on preclinical IBD and prediction. We have 4 crisp talks within 10 minutes, followed by a discussion. So please save your questions for the discussion period, and then we will discuss the DUET trials with Dr. Sands. So our first speaker today will talk about metabolomic signatures predicting future risk of Crohn's disease through distinct molecular pathways, and this will be presented by Palak Rajoria.
Good morning, everyone. I hope you had enough caffeine to get started. From this very moment, we are going to be bombarded with all of the IBD research that the department has been doing under John Fred's supervision. So my name is Palak Rajoria, and I'll be walking you through the metabolomic signatures in Crohn's disease. Let's establish a clear baseline of what metabolomics is and why it serves as such a powerful tool into complex human diseases. Metabolomics is a comprehensive study of small molecules known as metabolites within a biological system. When we look at the omics hierarchy, we traditionally begin with the genomics, which defines an organism's basic genetic potential, essentially what can happen. Metabolomics sits at the very frontier of this continuum, beginning with the transcriptomics and proteomics, which tells us what the cells are doing and what is being transcribed. In the context of chronic inflammatory conditions like Crohn's disease, analyzing the metabolites reveals chemical signatures of preclinical and active disease and not just static genetic risk. This is the exact analytical framework we apply to evaluate the longitudinal samples from our cohort. Today, we are discussing a major paradigm shift in how we approach Crohn's disease from a reactive post-diagnosis management to a proactive preclinical management. The serum metabolome contains a plethora of endogenously produced and environmentally absorbed biomarkers, and we aim to assess the serum metabolites alterations in the preclinical phase of Crohn's disease and correlate them with other known risk factors. By studying the serum metabolome, we can catch the molecular footprints of the disease years before the first clinical symptoms. Most of the metabolomic studies use post-diagnosis samples reflecting disease activity and not prediction. This study is structured around three specific intercorrelated aims. And first is to identify serum metabolites and pathways associated with the preclinical phase of Crohn's disease. Secondly, to develop and evaluate a machine learning-based risk assessment model to predict Crohn's disease, incorporating consistently identified biological and environmental features. And third is to integrate the metabolomics, proteomics, and serology to derive molecular clusters and validate its reproducibility in the external validation cohort of Nurses' Health Study. If we look at the PREDICTS cohort, this is a US military personnel cohort linked to the Department of Defense repository, and we have 200 Crohn's disease and 100 healthy controls. Not sure how the zero is missing. We have 200 Crohn's disease matched to 100 healthy controls by age, sex, and race. There are 4 longitudinal time points. A represents at diagnosis or 1 year prior to diagnosis. B is 2 years prior to diagnosis. C is 4 years, and D is 6 years prior to diagnosis. The initial metabolome dataset included 1,649 metabolites, and we excluded metabolites with greater than 20% missing values. We are now left with 1,075 metabolites. The metabolites missing with the missing value of less than 20% were imputed with LOD, defined as a minimum non-missing value. The cohort demographics is predominantly white and male population with a median age of 33. If we look at the association of metabolites or pathways and the risk of Crohn's disease in PREDICTS and our external validation cohort, which is the Nurses' Health Study, we see that there are common metabolic and metabolic pathways and metabolites that are perturbed. This plot shows the metabolic pathway significantly associated with the risk of developing Crohn's disease in the Nurses' Health Study, and those replicated in the PREDICTS are highlighted in red. Here is the association analysis that we conducted on the PREDICTS cohort, and each of these volcano plots represent a distinct time point with the coefficients on the x-axis reflecting the direction and magnitude of the metabolite dysregulation and minus log 10 FDR on the y-axis. The metabolites to the right are elevated in Crohn's disease, and those on the left are depleted. At diagnosis, a striking number of metabolites reach statistical significance, including environmental contaminants such as PFOA and PFOS, as well as steroid-related metabolites, suggesting that metabolite landscape is most profoundly disrupted at the time of clinical presentation. Notably, even at 6 years prior to diagnosis, the last time point, a distinct set of metabolites begin to emerge above the significance threshold, indicating subtle but detectable metabolic signatures. Now, to isolate core preclinical signature, we are showing here the metabolites that were consistently dysregulated in at least 3 of our 4 time points. The resulting heat map reveals a strikingly stable molecular signature. What this shows is that the metabolic shift in Crohn's disease is not a sudden event triggered by acute clinical symptoms. Instead, we are looking at a persistent chronic biochemical divergence that remains active and visible in the bloodstream half a decade before clinical diagnosis. Next, we wanted to see if these early metabolic shifts could accurately predict Crohn's disease, for which we trained the machine learning model, and this slide shows the workflow of the model development. We split our cohort dataset into equal size training and test split, and we performed a per time point modeling, training our XGBoost binary classifier and evaluating on the held out test set. We calculated the AUC with 95% bootstrap confidence intervals and extracted the XGBoost feature importance scores for all markers at each time point. This model will be validated externally in the Nurses' Health Study. The model that you see here achieved strong discriminative performance across all time points with an AUC of 0.85 at diagnosis, which is the time point A, with 0.83 at 2 years prior to diagnosis, and a sustained performance of 0.75 at 4 to 6 years prior to clinical presentation. When we look at the features the model selected consistently across all time points, we see a fascinating mix of endogenous biology and environmental exposure, alongside known metabolic pathways and unannotated molecules. The model heavily relied on environmental perfluoroalkyl substances, specifically PFOS and PFHS. This heavily underscores the role of persistent environmental chemical exposures as stable early stage risk factors or triggers embedded in the preclinical serum profile. Finally, we performed pathway enrichment analysis on a differentially expressed sets to understand the functional biology at play, and we discovered distinct temporal dynamics. We used an overrepresentation analysis framework implemented by the cluster profiler, mapping the metabolites to the annotated metabolome subpathways. Interestingly, tryptophan metabolism was significantly upregulated at the earliest stages, and conversely, when we look at our downregulated features, we see a mix of unknown metabolites, environmental chemicals, and androgenic steroids. The upregulation of tryptophan that you see on this slide suggests that the alterations in the tryptophan kynurenine axis are an incredible early systemic event. Active Crohn's disease highly correlates with the depletion of serum tryptophan, and the gut microbiota normally metabolizes tryptophan into indole derivatives. When the dysbiosis occurs, the mucosal barrier, the tryptophan is shunted away toward the inflammatory kynurenine pathway, accelerating the epithelial damage. You also see that the drop in lysophospholipids is particularly critical here, as these lipids are essential for cell membrane integrity and mucosal barrier signaling. While our previous analysis identified individual metabolites and pathways, we wanted to know how metabolites and protein markers interact with one another and how does the network look like. To do this, we applied joint random forest method from Francesca Petralia, a method that jointly estimates the multiple related networks across different disease stages. And this approach reveals Crohn's disease-specific co-expression network linking 2 bile acids with EGFR. To conclude, serum metabolites effectively predicts Crohn's disease years in advance with the highest AUC of 0.85 at diagnosis, and tryptophan metabolism and lipid dysregulation are stable early stage drivers. Environmental toxicants are embedded within the preclinical risk profile, but looking forward, our next immediate step is to transition from single layer metabolomics to a fully integrated multi-omics framework. Our goal in this validation phase is first to build a multi-omic cluster model, and second, to validate it on our external NHS cohort to see its replicability. Thank you so much.
After that excellent talk, we invite our next speaker, Suzanne Ibbing, who will talk to us about deep learning models for pre-diagnostic CT scan classification, her pilot work in Crohn's disease.
Good morning, and thank you, everyone. Thanks for the opportunity to present our work here on pre-diagnostic Crohn's disease classification based on CT scans. And before I'm getting started, I want to highlight that I'm presenting this pilot study also on behalf of Dr. Anna Silverman and Anis Hashmi. So this figure, which I'm sure you're all familiar with, highlights the different levels of IBD prevention. And the work I'm presenting sits in the secondary tier of disease prevention. So we're interested in whether we can accelerate the diagnosis of Crohn's disease. And unlike the other talks this morning that are more focused on biomarkers or risk factor identification, we're approaching this goal from an imaging perspective. So this figure, borrowed from multiple sclerosis, highlights our underlying hypothesis. In MS, we can visualize the full pre-diagnostic continuum on MRIs, and we see distinct disease signatures, such as the radiologically isolated syndrome, already years before clinical diagnosis. And we're asking whether we can see an analogous pre-diagnostic imaging signature also in Crohn's disease, in specific, if we can predict Crohn's disease from pre-diagnostic CT scans. And to answer this question, we designed a two-cohort study using data from the Mount Sinai Health System, as well as the Galdacao Hospital in Spain. And both cohorts contributed to model training and testing. At Mount Sinai, we applied a computational phenotyping pipeline combining structured electronic health records, so diagnosis or procedure codes, medications, with information derived from free text clinical notes or procedure reports using natural language processing. And for the cases, we started off with patients including at least 2 Crohn's disease ICD codes, and subsequently filtered down the cohort using several steps, amongst others, extracting the diagnosis here from the free text clinical notes to exclude referral cases from our cohort. We reduced the cohort requiring abdominal CT before the first Crohn's disease diagnosis, and GI symptoms mentioned or coded shortly or at encounter of the imaging. And for the controls, we started off with all patients with an abdominal CT scan with contrast, and then filtered for absence of IBD diagnosis or medication, sufficient follow-up time, and also GI symptoms at the encounter of the imaging study. We matched the patients in a 1:20 ratio using propensity score matching, and this table shows that the groups are well matched on age, sex, and the Charlson Comorbidity Index. There's one imbalance worth noting regarding race documentation, as you can see here with a differing percentage of the unknown category. And there's also an imbalance in terms of the year of the imaging study, as well as follow-up time, but we have substantial follow-up time for both cases and control groups. From Spain, we received access to a smaller cohort provided by Iago Rodriguez and his colleagues. In total 12 cases and 59 controls. And these patients were drawn from a population undergoing colon cancer screening. So a very different clinical context than our cohort that we extracted from the Mount Sinai Health System. And this cohort is older and has a longer follow-up time, around 11 years. So let me quickly walk you through the modeling pipeline. It has 5 stages. First, the pre-processing of the images. We standardized all CT scans from both sides in terms of the size and orientation of the images. And then we applied a data split of 17, 15, 15% for training, validation, and testing. For modeling training, we focused on 3D resonant architectures. So importantly, these models take the whole CT volume and so see the bowl in all 3 dimensions, and don't look at individual slices. Third, we applied threshold tuning, so we optimized the classification cutoff on the validation data set to best separate cases from controls. And this derived threshold was then used when evaluating the models on the held out 15% test sets using accuracy, F1 score, and the area under the receiving operating characteristic curve. And then as a last step, we focused on model explainability using 2 different methods to visualize where in the CT scan the model was looking when making its prediction. So here I'm showing the results of the best performing model, a ResNet 50 architecture, which is a relatively deep model architecture. So as mentioned, we use F1 score, accuracy, and AUC for evaluation. I added the formulas below and tested on the data set from Spain. The model performance was very good with an AUC of 0.889. It was a relatively small cohort, as mentioned, and the performance on Mount Sinai data was more modest with an AUC of 0.67. But importantly, adding this data from Spain to both training of the models, but also evaluation, really improved our model performance, even though the cohort was small, suggesting that this cross-site diversity helps also at small numbers. And here you can see some of the results from the saliency analysis or the explainability analysis. The brighter the color, or like yellow or white on the image, it indicates where the model was taking or like putting most emphasis on when making its prediction. And admittedly, I'm sure that all of you are better at reading these scans than I am. But I was told that the models look at, amongst other things, also the bowel on these images. Or, for example, in the middle part, a case of perirectal fistula, it also puts emphasis on the perirectal region. So to summarize, our pilot study supports the concept that algorithmic pre-diagnostic CT scan classification is feasible in Crohn's disease, and the model learned anatomically plausible features. We could improve the prediction by adding a second data set and also putting a strong focus on data pre-processing. I would like to acknowledge that we really have to still improve our model performances, and two plans to do so is incorporating a larger data set, the Mayo Clinic data, and also focusing on multimodal architectures. So, for instance, a vision language model that also incorporate the radiology reports, but also models that can include measurements, for example, coming from the electronic health records data. And with this, I'd like to thank you for your attention, and of course, a lot of thanks to the whole team, in particular, Dr. Silverman, Anis Hashmi, and Dr. Colombel.
Thank you, Suzanne, for that excellent talk. Our next speaker will be joining us all the way from Denmark, virtually. Jonas Rudbeck will talk to us about mapping preclinical IBD in Denmark from register-based insights to integrated multiomic discovery. Erica?
I hope you are able to hear me. Yes, good. All right. So thank you very much for having me. I'm extremely honored to be here, even though I couldn't be here in person, unfortunately. But I'm extremely honored to be here and to speak to you all today about our ongoing efforts at the Center for Molecular Prediction of Inflammatory Bowel Disease, PREDICT, in Denmark, where we try to investigate the pre-diagnostic phase of disease development in IBD using the unique data resources available in Denmark. So because I couldn't be here in person, I'm just going to have a little introduction slide of who I am, just to give you an idea. So I have a master's in molecular biomedicine with a focus on immunology and microbiology from the University of Copenhagen. I have a PhD in laboratory and translational medicine with a focus on pre-diagnostic development of IBD. And currently I am working as a postdoctoral fellow at PREDICT, and I am continuing my work on elucidating the pre-diagnostic disease phase in IBD. So now moving to an overview of what I'm going to talk to you about today. So my presentation today will have four main sections. Firstly, I will briefly introduce the pre-diagnostic phase of IBD and the questions that still surround this phase. Then I will introduce our new pre-diagnostic study funded by the Helmsley Charitable Trust and explain how this major project we aim to conduct multi-omics profiling of around 10,000 individuals. And finally, I will recap some of the main points of the presentation. Now, as all of you probably already know, it is well established that IBD is preceded by a relatively long pre-diagnostic phase, during which molecular changes driven by a combination of inherent genetic and external environmental risk factors begin to accumulate many years prior to the clinical diagnosis of disease. Now, at this point, even with the amazing work by many brilliant researchers in the field, many of whom are also present here today, we still lack a complete understanding of the complexities surrounding this disease phase. And as such, even though we have good evidence implicating changes in the proteome, the immune system, and the metabolism, and the effects of certain genetic risk loci in the risk of developing IBD, we still lack an understanding of the intricate interplay amongst these observed pathological events. And besides this, many questions still linger about why certain individuals have specific disease causes, which medications will be the most effective, and if they will develop any specific disease complications. And in addition to this, importantly, if the observed early pathological changes in these individuals can explain the very disease course observed in patients with IBD. So these unanswered questions now lead me to introduce our ongoing efforts to elucidate the complexities of pre-diagnostic disease development in IBD in our new PREDICT pre-omics study, generously funded by the Helmsley Charitable Trust, where we hope to significantly advance our understanding of the pre-diagnostic disease phase. So for this study, we will take advantage of the unique data availability in Denmark, where we have a trinity of resources, namely a large set of nationwide registries and a large repository of biobank samples in the Danish National Biobank, and a linkable personal identification number that binds them all together for a population of around 6 million people, including more than 50,000 patients with IBD. Using these data sources together, we can link biological information from various omics-based analysis on biological samples to relevant health-related information from registers to gain novel insights into disease development and progression in IBD. So going back to the figure illustrating some of the unanswered questions, and to answer these questions, we will of course need information spanning the course of IBD, with samples collected both before and after diagnosis, linked to relevant clinical and general health information. And for this particular project, we have used the nationwide registries and our linkable personal identification numbers to identify IBD patients with serum samples collected up to 20 years before their diagnosis in the Danish National Biobank. And this has resulted in a cohort of around 5,000 future IBD patients and an equal number of matched controls. This massive effort is led by Professor and Center Director Tine Jess, with assistance from Alexis Sarsenovs and Philip Ottersen, who are the co-PIs of the project, and with me acting as the project coordinator for the project. Now, using these approximately 10,000 serum samples, we plan to measure several omics layers, including genomics, epigenetics, NMR metabolomics, and proteomics. And subsequently, we want to perform mass spectrometry based on targeted metabolomics on a subset of the cohort, as well as serological measurements on the full cohort. But for this talk, I wanted to go a little bit more into detail about these individual omics layers. So for genetics, we are going to run genotyping using the Illumina Infinium Global Screening Array version 4 on around 8,000 samples, measuring around 10 million genetic variants. Then we are going to do epigenetic profiling using the methylation EPIC Next platform on 6,000 samples, measuring more than a million CpG sites. And we are going to run NMR-based metabolomics quantification of around 250 metabolites on the full cohorts of 10,000 samples. Then we are going to run Olink-based proteomics analysis, measuring more than 5,000 serum proteins in 6,000 samples. We are going to conduct LC-MS-based on-targeted metabolomics on 1,500 samples, measuring both polar metabolites and lipids. And lastly, we are going to run a custom Luminex-based multiplex immunoassay to measure approximately 20 relevant antibodies in the full cohort. So from these efforts, we will end up with a cohort of 6,000 individuals, 3,000 of which are future IBD patients, which will have full profiling of 5 different omics modalities, including proteomics, genomics, metabolomics, epigenetics, and serology. The plan is then that by integrating these biological informations with the clinical and health relevant data from the nationwide registries, we hope to answer questions about the molecular characteristics in pre-diagnostic phase of IBD, how these early changes affect the later disease course, and possibly disease complications, and importantly, attempt to identify causal pathways and mechanisms in the disease development of IBD. We also further hope to leverage this data together with results from other major contributors to the pre-diagnostic development in IBD space, as well as available resources from the UK Biobank to strengthen our understanding of the pre-diagnostic phase of IBD. So, in summary, IBD contains an extended pre-diagnostic phase, but the complexity of this phase is not well understood. To better understand disease development, integration of multiple omics layers with detailed clinical data is essential, and the PREDICT pre-omics study will create the largest pre-diagnostic multi-omics cohort in the world today. And we hope that the results from this, together with validation in other pre-diagnostic cohorts, will ensure robustness of the findings and hopefully open the door to better understanding of the pre-diagnostic phase in IBD. So I will end my talk by, of course, saying thank you for your attention and thanks to my colleagues as well as the funders.
Thank you, Jonas, for that excellent talk. Our next speaker is Eric Wilson, who will present some of the work in Diego Chowell's lab. And his talk is Clip Binding Defines Antigen Presentation Regimes Across HLA class 2 Molecules That Structure Autoimmune Disease Risk. Very short title. Which one's your talk? Oh, okay.
Okay. Hello, everyone. So my name is Eric Wilson. I am a postdoc, and today we'll be talking about how clip binding to MHC class 2 can modulate autoimmunity risk across a set of different diseases. So we know that MHC class 2 alleles are some of the strongest genetic factors for immune-mediated inflammatory diseases, or IMIDs. And one thing that's always been striking about these associations is that the same MHC class 2 alleles impact a wide array of different diseases. So, for example, DRB1501 is implicated in both ulcerative colitis and MS. And this kind of pleiotropy has always been, kind of confusing as to like what the actual driving association is for HLA and disease risk. So when we were trying to look for a more unifying mechanism, we started looking at the MHC class 2 presentation pathway, more specifically where peptide exchange happens. So this occurs in the M2C compartment, and here newly synthesized MHC class 2 molecules will be exchanged with exogenous peptides for presentation to CD4 positive T cells. But before this process can take place, there needs to be an exchange of a peptide called CLIP from the newly synthesized MHC binding cleft. This CLIP peptide is called the class 2 invariant chain peptide, and it serves as a placeholder keeping the MHC class 2 molecule stable before this exchange can happen. And we became really interested in this kind of paradoxical nature of the CLIP peptide. So as the name suggests, it's largely invariant across all human populations, yet it has to bind and stabilize one of the most polymorphic genes in the human genome, the MHC class 2 genes. So this led us to suspect that MHC class 2 will have differential affinity to the CLIP peptide. And there's been some preliminary work in this by Kai Witcherfinig's group. And what they found is in NOD mice, which develop type 1 diabetes, if you were able to modify the CLIP peptide in these mice, you were able to bind to the risk allele a little bit stronger. You're able to actually slow the progression of disease. So then we looked at 8,000 human alleles and we predicted the binding affinity for each allele to CLIP. And how we measured this binding affinity was this relative binding strength called binding percentile. And how this is interpreted, it's the percentage of random human peptides that are likely to outcompete CLIP for that given allele. And so we'll commonly use this 1% threshold, meaning that at 1%, only 1% of random peptides will beat CLIP as our threshold for a strong or a weak binder. And what we found is there's a wide variation across different alleles for these predicted affinities. So to get more experimental validation of this aspect, we then performed some flow cytometry experiments where we looked at how much CLIP was being exported to the surface when we compared it to what the predicted binding affinities for the MHC class 2 alleles on those cells. So in the first set of experiments, we looked at EBV transformed B cells, and so you can see that on the bottom there. And what we found is as the average binding percentile got higher, which means it was binding CLIP weaker, you saw a lot less CLIP on the cell surface. So it meant that people with weak binding CLIP, there's much less CLIP being exported. We then repeated these experiments with our collaborator at Virginia Commonwealth, Lisa Denzin, and we found that we were able to replicate the same kind of correlation between weak CLIP producing less CLIP on the surface in primary human PBMCs. So this led us to our general hypothesis in that CLIP is a kinetic barrier to antigen presentation, and we think this would be the most important in situations when the chaperone protein HLA-DM would be inhibited. So that would be in like immature B cells and then in medullary thymic epithelial cells. And what happens here without DM to catalyze the removal of CLIP, we think that when you have weak CLIP binding, you'll have a more exchange permissive peptide loading regime in which you'll have a lot more peptide diversity, versus when you have strong CLIP and there's not as much exchange because CLIP itself is already binding so strongly. So to look at these effects across populations, we use 3 different biobanks, the UK Biobank, FinGen, and the Million Veterans Project, or MVP, and this covered about 1.5 million different people. And so we studied 33 different autoimmune disorders across all of these different cohorts. To assess how CLIP was impacting these different patients, we calculated something that we called the CLIP binding configuration, which was the count of how many weak CLIP binding alleles that an individual patient would have. So you can see an example of that on the left. We would take the patient's genotype, we would construct all possible heterodimers for HLA-DR and DQ, and then we would simply score them based on their predicted binding affinity. So for this patient, the CLIP configuration would be 2 weak DR, 1 weak DQ. We could then extrapolate this to a population by just repeating this process for everyone in each biobank. And what you can see there, it's quite pixelated, is the heat map showing the frequencies of different CLIP binding configurations. And so we can see for these are in healthy controls in the UK Biobank, we can see that there's an enrichment for intermediate CLIP phenotypes, so 1 or 2 weak DR, 1 or 2 weak DQ. To get a preliminary idea of whether or not this was impacting autoimmunity, we then took these frequencies that we calculated and projected into a PCA space for different autoimmunity cohorts compared to controls. And what we could see already at just the CLIP configuration standpoint, that certain diseases showed significant deviation from healthy controls. So you can see that kind of in celiacs or chronic hepatitis, which is a form here of autoimmune hepatitis. And so to show how specific CLIP configurations are being enriched, we performed a Fisher exact test. And so you can see that in the right column there. And for example, in celiac disease, you can see that there's a significant enrichment for CLIP binding configurations, which would be 1 or 2 weak DR, and then 0 or 1 weak DQ, showing a very specific enrichment, where with psoriasis, you'd see kind of the opposite. However, there's other factors that will impact autoimmunity, IMID risk. And so what we then did is instead of just kind of looking at the CLIP configurations, we then did logistic regressions that would allow us to correct for other factors like age, sex, genomic PCs, and BMI. And so we did this for all 33 cohorts where we would just combine all of our case cohorts with our controls. And in this case, controls would be mutually exclusive of any of the IMIDs that we were looking at. And here we would get an output of a log odds ratio. So greater than 0 would mean that it would increase autoimmunity risk. Less than 0 would mean that it would decrease it. And what we found is out of the 33 we looked at, 25 with ulcerative colitis being one of them, had a significant risk or a significant association with CLIP binding. And on the left-hand side, that's a forest plot from the UK Biobank. On the right-hand side, you see the validation across the other biobanks. And what was also kind of interesting, we saw that there's a pretty specific pattern in which you would, get, in certain diseases, weak CLIP would increase disease risk, while in other diseases, weak CLIP would actually decrease it. But one pattern that was consistent is that DR and DQ tend to oppose each other. However, as we mentioned before, we know MHC class 2 itself is a strong risk factor. So what we did is we actually went back through each biobank and then calculated all of the individual MHC allele risks to each of the diseases that we were looking at to create a map of all HLA associations in our cohorts. And what was kind of reassuring is we found that if we calculated against all of the HLA-DR alleles, an overwhelming percentage of them were weak CLIP binders, kind of reinforcing what we had initially seen. Now, to be extra conservative, we actually redid all of our logistic regressions. This time we accounted for all of the HLA associations that we recovered from our mapping. And out of the 25 that we had initially found to have a significant association without the HLA alleles, we found that 24 of them remained having at least one significant CLIP association, with 17 out of 25 validating at least one biobank, or one other biobank. To get a sense of what could be happening or mechanisms, mechanisms that could be kind of driving this, we then performed an O-link analysis of the O-link data in the UKB. And what we did is we looked at how the weak binding CLIP across these populations would change the expression of these circulating proteins. What we found, so you have DR on the top and DQ on the bottom, that CLIP would significantly impact a wide range of proteins that spanned well outside of the MHC region. And what we found that was really, kind of made sense is that a lot of the proteins that were being impacted by this were immune-related proteins. So MHC genes, immunoregulatory genes, and cytokine genes all tied to weak CLIP expression. Another thing that was really interesting is we found that DR and DQ, as we had saw in the logistic regressions, tend to have opposing interactions. So if DR would increase the expression of a protein, DQ would tend to decrease the expression of that protein if we're, calculating the CLIP. So in summary, we found that MHC class 2 heterodimers display wide variations in their ability to bind the CLIP peptide. We found that weak CLIP binding is significantly associated with over 70% of the IMiDs that we were testing and were robust to allele correction. Finally, we found that weak CLIP modulated the serum protein expression of a wide range of immunologically related proteins. And so I'd just like to thank our team for this.
Eric, you can stay on here. I'll now invite all four of our speakers to please come up for our discussion. And if anyone has questions, then you can please go ahead. Maybe I can get started with the first question. And I think this would be for all of our speakers, but perhaps more so for Palak, Eric, and Jonas. So in incorporating different omics and different data types from across different kinds of cohorts, the omic technology and the coding that's used for collection of that data can be very variable, and the quality can be quite distinct across cohorts. So how do you account for that variability? Is there like a score that you use, or how do you validate across different cohorts, and how much does that play into developing and the quality of these prediction models?
Yeah, that's a very nice question. So we usually see that different omic types are derived with different units, with different companies and strategies, but we usually check what it looks like after batch correction and what is before that. And then we try to plot data using PCA and check how different are two omic types, and we correct for the other one based on the batch correction. So that's the coding that we utilize. But yes, most of the omic types are very different, and it's difficult to consolidate them into one category and derive the molecules.
Yeah, so I would say using the UK Biobank O-Link data was really nice because it was like pretty well QC to begin with, but we did follow some of the standard procedures, including residualization against age, sex, batch effects, things like that. But it was pretty straightforward, actually.
I think if I can add a little bit to the conversation here, so for our efforts, a lot of our planning has also gone into making sure before we actually get the data that the pipelines for the quality control and of the data when we get it for each of the omics platform are streamlined in a way that we do similar steps in the quality control pipelines for each of the omics so that the output becomes more similar.
Thank you. Saurabh?
So thanks to all the speakers, great talks. My question is to Eric. Two thoughts or questions. Are you able to first comment on the structural similarities between CLIP and some of the autoantigens? And then a second question, if I may, so your work will suggest that the concept of central tolerance, meaning that the T cell clones or potentially other immune subsets are deleted against autoantigens. So you would challenge that then based on your data.
Yeah, so I think to answer your first question, we haven't looked specifically to see if there's any overlap between the CLIP peptide itself and autoantigens. So I don't think I would expect to see there to be that much to be the actual driving mechanism. What we really think is happening is with the CLIP peptide, we have that differential affinity. It's just changing what peptides are being presented. And we don't think it's a coincidence that the MTECs, which are the main drivers of negative T cell selection, are those that would be the most impacted by the inhibition of DM. So there you would have only CLIP dynamics kind of driving the presentation of different peptides because you wouldn't have the catalyst there to actually remove the CLIP. Now, it's a question of like, is it interesting that you would initially expect people who would have strong CLIP to have less, presentation, so they would have maybe more autoreactive T cells? That's kind of what we expected to see. But the data just kind of pointed in the opposite direction. And what we kind of found, which was unfortunate because I don't know how the image got so compressed, but we found is with weak DR specifically, there was a very kind of general systemic increase in inflammatory proteins and cytokines that just seemed consistent. And the data that we showed for the O-Link wasn't actually just in autoimmune patients. This was across all people. And so we saw even in healthy individuals without IMiDs, they were increased in immune checkpoint genes and HLA gene expression and a bunch of other things that were kind of unrelated. So we think that CLIP itself kind of presents a general kind of inflammatory environment, and then the actual autoimmunity, whether or not that's going to be antigen specific, we still know there's a huge HLA component. So you still need the specificity, but you think CLIP just kind of modulate and creates a more pro-inflammatory environment.
Fascinating data. Thank you.
Jean-Fred?
I have a question for you, Jonas. Hello. Nice to see you.
Nice to see
Jonas,
you.
can you remind me in the Danish cohort for each patient you have one point in time or multiple points?
So we have mainly 1 point in time. But for few patients, there will be repeated points, but it's a much smaller proportion of the individuals who will have repeated samples. The majority of the cohort is 1 time point.
And one platform that is missing, and I'm speaking on behalf of Mansi, will be the exposome, because it will be very interesting to compare your data with our data with different environments, of course, right?
Definitely. I think there is a possibility here, even might not be a full overlap, but with the mass spec based on-target metabolomics that we might capture some of the exposures. Mansi have already made some work with Philip on this, I know. So I think there might be some grounds there for where we can kind of validate some of the things that you guys also see.
Yes, absolutely. Thank you, Jonas. And I think that with using those mass spec data, that's an example of how one type of omic can be used for many different data types. We can potentially get pilot data and then use that to understand what would be the most high yield omic technologies that we could then apply. Thank you. I have two more questions quickly. One for Suzanne. So, Suzanne, you noted that in the Spanish cohort, which was a very small cohort and rather homogeneous in terms of the demographics and the disease location, there was a very high prediction value, whereas in the New York cohort, in the Sinai cohort, it was much less so. Do you think that different, because Crohn's disease is so heterogeneous, do you think that different subgroups of Crohn's disease based on the disease phenotype, based on disease location, may be better predicted using CT scans or other imaging modality than others?
That's a very good question, actually. I think our cohort is too small to answer this question at this point. I couldn't imagine that that's the case. But in general, I think the main reason why the models work so well on the Spain data is actually that for that data, it's more likely that there's actually something pronounced in the scans, because the patients went through, so they had like abnormal findings in colonoscopy, and then they did the CT scans. They were asymptomatic at the time point, so they were not diagnosed yet, but I think they had probably more clear findings in the scan itself. And in the Mount Sinai data, we did not really filter for, I mean, some of the cases that I showed also in the end, the findings or like the readings of the scans were normal. So I think it's just maybe more difficult for the model to pick something up there.
There's more self-selecting in Spain, possibly.
Mm-hmm.
Yeah. Thank you so much. Okay, thank you to all our speakers, and we will move on to our final talk for this session, which is by our very own Dr. Bruce Sands, who will present on the much-awaited DUET Crohn's disease and UC trials.
Thank you very much, Mansi. It's my pleasure to kind of reprise these presentations. The Crohn's disease study, DUET CD, I did present at DDW, and DUET UC was presented by Maria Abreu, but I was a co-author of that as well. And I think I'm interested to hear what your thoughts are for this very interesting pair of studies. So to get right into it, here are disclosures. And by way of background, you probably are aware of the VEGA study, which was a phase 2A study in patients with relatively treatment-naive ulcerative colitis, combining guselkumab, which is an anti-IL-23 antibody, and golimumab, which is an anti-TNF antibody, both of those being approved in ulcerative colitis. And the basis for that was really the concept of molecular synergy, showing that with one treatment or the other, you downregulated or upregulated a number of different gene patterns, expression profiles. With the combination, you actually regulated far greater numbers of gene expression pathways up or down one way or the other. So 1 + 1 is more than 1. And I think it remains to be seen as you look at the data whether you believe that 1 + 1 is indeed more than 1 for patients. But that was the basis of doing this. And so these were phase 2B studies. There was a lot that was unknown from the 2A study in VEGA. First of all, it was only UC. There was not Crohn's disease. Second of all, it was a relatively naive population. Is that the right population for which you would think of combining two biologic therapies? And so this was an exploration. Also, dose exploration was incorporated here. So a number of different features needed in order to move the program forward and to see if it should be moved forward. So we'll start with DUET CD, and these were Crohn's patients who had moderately to severely active Crohn's disease, defined in all the conventional ways that we normally do in clinical trials. This was a treat-through design with a 48-week co-primary endpoints in this case, both clinical remission defined by CDAI less than 150 and endoscopic response, meaning 50% drop in the SES-CD score at week 48. Patients were randomized 2 to 2 to 2 to 2 to 2 to 1. Basically, placebo had to be incorporated because the FDA really noted that golimumab had never been studied really or approved for the treatment of Crohn's disease. So they needed this reference arm, but that was not the primary concern for hypothesis testing, even though it was included. There were a number of stratification variables, including whether the CDAI was higher or lower than a cut point of 300, SCSCD higher or lower than a cut point of 12, which is about the average. These are averages that you would see in moderate to severely active Crohn's in most of our trials. And also on primary non-response to one or more systemic therapies, yes or no. Primary non-response, I will tell you as a clinical trialist, is very hard to define. It is basically defined by the investigator at the site, but there's a lot of variance in how that is defined. You can see that 3 different doses were explored. These were fixed dose combinations, defined as low dose, mid dose, and high dose combinations. And then you see the monotherapy arms of golimumab and guselkumab. Those were the standard approved doses, at least approved for UC for golimumab. So that's how the study was conducted. I told you about the co-primary endpoints. There were other key endpoints, including corticosteroid-free clinical remission at week 48, endoscopic remission at week 48, and deep remission at week 48. And I think those secondary endpoints are really important because they're deeper levels of criteria. So when you have deep remission, it means you have symptomatic remission by CDAI, you have endoscopic remission as well. And so it's both of those things in the same patient, not at a population level as conjoined outcomes. And the study was well powered to detect what was hypothesized to be a 20% difference or more for both co-primary endpoints at the high dose. That's where the main focus of attention was. All right, and then there were other subpopulations that were pre-specified but not multiplicity controlled. Again, keep in mind this was more for hypothesis generation in a sense for the next phase of development. So who are these patients? I think you can see they fit the criteria for having moderate to severely active Crohn's disease. All of them had failed one or more therapies. There were not naives in this patient population. You can see that these were sicker than the usual patients. You know, when you see a CDAI score of 323, an SES-CD mean score of 13.7, that's higher than we normally do expect. Also, relatively high use of immune modulators, oral corticosteroids. Those had to be maintained at stable dose during induction 12 weeks and then forced taper during the rest of the study. All right, and here is how it looked like in terms of the prior exposures. Half the patients had failed one systemic mechanism, as we now call it. We no longer are calling it advanced therapies because the FDA doesn't like that language. They call it systemic therapies or mechanisms. So this is not drugs, it's mechanism. If you failed 2 different anti-TNFs, you have failed one mechanism, but 2 drugs. So half of them failed one mechanism and 2 or more mechanisms were failed by the other half of patients. What did they fail? Almost everyone failed at least one of the anti-TNF subgroup. You can see about half failed ustekinumab, anti-IL-12 and 23. About a quarter had failed vedolizumab as well. And then because of when these studies were conducted, very little upadacitinib was available. It wasn't yet approved. So you see very few patients on those and very few patients who had failed anti-IL-23s. All right, and the disposition tells a story in its own right because you see a lot of patients in placebo and monotherapy golimumab actually discontinued study treatment before week 48 and much lower rates of discontinuation at the mid-dose combination and the high-dose combination. You also do see that relatively lower percents of patients discontinued early on guselkumab, which is a hint about what I'm about to show you. So here's the co-primary endpoint, the first part of the co-primary endpoint for clinical remission at week 48. First, you can see that the high-dose combination is markedly better than placebo. It is better than golimumab, statistically significantly so, but it is not statistically significantly better than guselkumab monotherapy. And the way I understand this is that guselkumab is still pretty good when you've failed an anti-TNF. And that's what you see here. It's numerically better for the combination, but it's not statistically different. However, when you confine the analysis to the half of patients who failed 2 or more systemic therapy mechanisms, then you start to see a differentiation. Here, certainly there's a difference between monotherapy of guselkumab, 27%, but also more than 20% delta over guselkumab alone. So in other words, you're seeing nearly a doubling of efficacy. And for endoscopic response at week 48, it's a similar story. On the left-hand side, you see that the high-dose combination over guselkumab is not meaningfully different. But if you look on the right, for the subpopulation of patients who failed 2 or more systemic mechanisms, you see a delta of about 12% over guselkumab alone. And it actually looks to be about additive if you look at monotherapy of guselkumab and golimumab. Other endpoints, clinical remission and corticosteroid-free clinical remission are shown here. Basically, anyone who achieved clinical remission also achieved corticosteroid-free clinical remission. I think that's important. And if we look at more stringent outcomes, here you begin to see probably more than additive efficacy. On the left is endoscopic remission, a very difficult outcome to achieve. That's 23% versus only 7.3% for guselkumab or golimumab. And a deep remission, which is same patient achieving CDAI remission and endoscopic remission. That's about 1 in 5 patients who got the high-dose combination, only about 5 or 6% on either of the monotherapies. Next question is, when you add 2 mechanisms, do you increase the safety risk? And the answer is you do not seem to change the efficacy, the safety profile rather, over TNF alone. There are infections. There isn't very much signal at all. Really, there's not more signal that it's any different than placebo overall for serious infections or infections in general. Other things, very low risks of cancers, opportunistic infections, very, very little increased risk. So just to summarize that part, it really seems like for patients who have 2 or more systemic mechanism failures, the combination of high dose of guselkumab and golimumab seems to offer benefits beyond what either monotherapy does alone, building upon what was seen with Vega in a more naive population. And now Duet UC, again, these are data that I did not present, but Maria did present it, but I'll show you the data. The background is the same, of course. The goal is very much the same, to look at the combination therapy in a more refractory group of patients with ulcerative colitis. The design is also quite similar. Here, keep in mind that golimumab is approved for ulcerative colitis, unlike in Crohn's. The design of the study is very much the same. A slightly lower number of patients, more than 500 though, were studied. And the stratification variables were MES, Mayo Endoscopic score of 2 versus 3. And the second stratification variable was primary non-response to 1 or more systemic therapies, yes or no. And here again, the primary endpoint was at week 48. Corticosteroids were stable dose till week 12, and then forced taper over the coming weeks. So very similar design. There were also caps here. Keep in mind that there was widespread use of JAK inhibitors here, so you'll see more of those. There's very little use of S1P receptor modulators, you'll see. But there were caps here for prior systemic therapy by mechanisms of 1 for 50%, 2 mechanisms 35%, and more than 2, 15%. Clinical endpoints were, the primary endpoint was clinical remission at week 48. Other key endpoints, endoscopic improvement and histologic remission and endoscopic improvement. Actually not HEMI, but HREI, I guess, and corticosteroid-free clinical remission. So once again, a rather sick patient population. You can see the severity of the modified Mayo score was in the severe range for more than 2/3 of the patients overall. Mayo endoscopic subscore was 3 in the severe range for nearly 3/4 of patients. So really overall quite a sick group of patients. And here you see the number of systemic therapies that they would have failed. Half the patients, actually a little more than half, had failed just one systemic therapy mechanism, and slightly less than half had failed 2 or more, so 45%. And what did they fail? Again, about 3/4 had failed anti-TNF, anti-integrin approaching half, JAK inhibitors in this case, about 1/4 of patients, 1 in 5 patients had failed ustekinumab, very little S1P modulator failure, very little anti-IL-23 failure, again, reflecting the time in which the study was conducted. So here, again, you see discontinuation rates far lower with the high dose combination as compared to either of the monotherapies, and certainly better than placebo. And here you see the primary endpoint, just as I showed you before. There is some numerical advantage, but not statistically significantly so over guselkumab alone. But when you look at the systemic therapy mechanisms, 2 or more failed, then you see a delta of 12.5% over guselkumab monotherapy. And in fact, this appears to be more than additive, the efficacy of golimumab and guselkumab in that subgroup of patients. If you look at endoscopic improvement, that means a Mayo endoscopic score of 0 or 1. Remember, you had to have had either 2 or 3 to come in, but about 2/3 to 3/4 had a 3. Here you see the overall population on the left. It does look like numerically there is important difference of high dose combination versus guselkumab, and definitely over golimumab. And for 2 or more systemic therapies failed, again, you see a delta of about 17% over guselkumab alone. And if we want to look once more at the even more stringent outcome of combining histologic remission and endoscopic improvement at week 48, this seems more than additive. It seems a little bit more like synergism, at about 1/3 of patients approaching this very stringent outcome, compared to only 16% on guselkumab and almost no one on golimumab alone. Corticosteroid-free clinical remission, again, if you achieve clinical remission at week 48, almost all the time it was corticosteroid-free clinical remission. And once again, the safety message is the same. There isn't really anything new that emerges other than what you expect from TNF itself. So the conclusions here are the same, that essentially for this group of patients who had failed 2 or more systemic mechanisms, that there seem to be advantages to combining guselkumab and golimumab at the high dose fixed combination. And this is really the first example of studying a fixed dose combination in inflammatory bowel disease in this large patient population, both for Crohn's and for UC. And with that, I'll stop, and I'm sure you'll have interesting questions for me. Thanks. And if you don't, I'm surprised.
Was super interesting, of course. And so we're waiting for this result. I have 2 questions. How will you build the phase 3, knowing that more and more we are using IL-23 first line now, right?
Yeah.
So, and how to translate in clinical practice? Because this is of course, as you were mentioning, the field has changed, and because
Yes.
we are using.
Yeah.
And my second question: do you have any rationale from the mechanistic data that you presented in your first slide, why the combination is working much better in multi-exposed as compared to less exposed? Is there any rationale for that?
I'm going to answer the second question first, because I think the combination doesn't work any less better in that more refractory population. It's just that it doesn't offer advantages over monotherapy with guselkumab, because guselkumab happens to be pretty good in those patients. So thinking of who you would use it for, which was part of your first question. It's really for the patients who had failed a couple of things, not just one thing. And I think the phase 3 study will certainly have to incorporate at least some patients, enough anti-IL-23 failure and JAK failure patients to understand how we would apply this in clinical practice. But for sure, J&J have said they will move forward, with phase 3 on the basis of these data. Nancy.
Thank you, Bruce. My quick question is that most of the patients who had failed a mechanism, a systemic mechanism, had failed anti-TNF. Do you have data on what proportion of those had failed it mechanistically? And so in those who had primary non-response to anti-TNFs, you wouldn't expect them to have a response to golimumab either by itself or in combination therapy. So I'm wondering what your thoughts are on that.
Yeah, I think we're trying to dig through those data. It's not easy. So I said at the beginning, defining primary non-response is really a weird thing because it's defined clinically. There's no hard and fast criteria. You're relying on the site investigator to say it. There are examples in this study of people who were checked off as primary non-response who oddly remained on their TNF for like a year. Is that primary non-response? It almost certainly isn't. So it's not likely, given that these were global studies and access to assays for drug levels and anti-drug antibodies, that you're going to get detailed answers for who failed despite adequate levels of anti-TNF in circulation and who had anti-drug antibodies. But we may get some hints of that. Hi, Ali.
Great talk. So in terms of how to incorporate some of this with the profile study, which showed that early sort of aggressive treatment may be beneficial. I know it's sort of targeting this now for a more refractory population, but should we be starting up front more aggressively, let's say in people who we think are high risk, and then pulling something off, especially since the safety data is similar? Is there any thought about designing a trial around that population?
I think what you say makes sense. We have to realize that when you're talking about the profile study, that is combination therapy also, a la Columbell, Sonic style. It is combination of thiopurine. And actually, one of the interesting things of the combination of anti-TNF and anti-IL-23 is, and this is published, that the anti-IL-23 to a large degree suppresses anti-drug antibody formation. So it has some of the benefits of thiopurines without the safety issues of thiopurines. I think the implicit question, what you asked is, okay, if you started a combination like that in the beginning, how would you know which patients to step down for? And I think that's harder to know. So I think from a drug development perspective, that is probably not where the company will go, but it may be where the field goes. Thanks.
Thank you, Bruce, for that excellent talk. We will now take a little break and we will reconvene at 9:55 sharp. Thank you.
Hello, everyone. Welcome to this, our next session on new risk factors and biomarkers of IBD. Our first speaker is Dr. Sasha Niatic, and the title of his talk is GM-CSF Antibodies in Immune-Related Colitis upon Checkpoint Blockade.
Thank you, Inga. And so today I will try to put that in context of IBD, but it's also presenting data on the cancer immunotherapy patients treated with checkpoint blockade. Let me see if I can put this in presentation mode. It's not showing up yet, but it's just that the mouse is, let's just see. Where is it? Oh, here, the mouse finally came up. All right. These are my disclosures. I do have a patent on GM-CSF antibodies that I will be talking about today. So we've been interested in GM-CSF as a potential target of autoantibodies, in part because my lab does a lot of ELISAs to different cancer antigens. And so we just established this high throughput ELISA for GM-CSF made in yeast, cybromycin, in the lab to be able to do some large-scale screening. And GM-CSF is a really interesting protein because it can have dual roles in the body. It can have both inflammatory properties by attracting macrophages and also potentially anti-inflammatory ones, depending on the site where it's happening. And there's been evidence in the literature of autoantibodies to GM-CSF being important in a variety of diseases. One of them being, for example, pulmonary alveolar proteinosis, which is almost diagnosed with the presence of these antibodies, but also in Crohn's disease compared to healthy donor or ulcerative colitis patients, where there is a prevalence of people with pre-existing antibody titers to GM-CSF, but their presentations are different because we know the GM-CSF autoantibodies are more IgG1 in patients with PAP, while they're more IgG2 and IgA in patients with Crohn's disease. These antibodies neutralize the activity of GM-CSF, where you can see STAT5 phosphorylation going downstream of the GM-CSF receptor. And importantly, they recognize in Crohn's disease patients at least modified version of GM-CSF. It's not like this lower band, it's more of the glycosylated versions. And with our colleagues in Portugal, they saw that GM-CSF itself within Crohn's patients is modified differently in terms of sugars on the surface of it, as well as within the lamina propria. There are enzymes that can be differentially expressed by ILC3 versus ILC1 cells. So we think that this may be a mechanism where antibodies to GM-CSF will change the microenvironment of the inflammatory gut milieu. And when you have them, the normal homeostatic mechanism is that GM-CSF is produced a lot by ILC3 and will basically attract myeloid cells, which in return would produce retinoic acid that can maintain ILC3 as well as Tregs. And when you disrupt that, you end up having more inflammation here, and also less retinoic acid production, as seen in GM-CSF deficient or patients or with antibodies. And in general, that results in a switch from ILC3 to more ILC1 and inflammatory T cells. So this is the normal setting in the gut. And when you have these neutralizing antibodies that recognizes the differentially glycosylated GM-CSF, you sort of remove the myeloid component and the switch to ILC1. So we saw that this happens throughout the course of Crohn's disease, starting from preclinical cohorts at diagnosis or even long-standing Crohn's disease, where the prevalence of these antibodies increases as the disease duration also increases. And more importantly, they're associated with a specific phenotype or endotype of Crohn's disease, which has ileal presentation, as well as complications of disease, such as stricturing, penetrating disease, or need for surgery, where there is this cumulative risk, lifelong risk, where if you have like Crohn's for 20 years, you end up almost all the patients end up having these autoantibodies. So it's an interesting mechanism that we now can try to dissect through maybe induced model of colitis in vivo, which is pretty interesting because this is what happens when people with cancer get treated with immune checkpoints, which is now standard care therapy for many cancer types that are listed here, especially with this drug blocking CTLA-4. Even though the drug itself increases the likelihood of response, it comes with a lot of adverse events, in particular colitis, immune-related colitis, specifically with ipilimumab, which is the drug targeting CTLA-4. And this has been a dose-limiting use of CTLA-4, where it has to be reduced in the clinic and probably in the suboptimal dosing compared to what it could do, simply because of the really life-threatening adverse events. So we put together a group of investigators in collaboration with Memorial Sloan Kettering and David Falek and our own Jean-Fred Colombel to do accrual of patients, both retrospective and prospective, who are cancer patients undergoing immunotherapy with a CTLA-4 backbone. And the idea was to collect tissues, stool, and serum samples to be able to understand what's going on within the tissue site and in the periphery as potential biomarkers. And you saw this slide earlier where our colleague Mira Berad has established a variety of different mechanisms happening in Crohn's patients, such as activation of T cells and recruitment of these macrophages that are inflammatory. And so our hypothesis is that maybe GM-CSF has a role in the generation of these complications of adverse events to CTLA-4, similarly to what they may have in Crohn's disease. So it's like a model to study that. So we did this collection, consented patients. We had to screen a lot of patients to enroll about 115 of them across the 2 sites, of whom 19 ended up developing colitis. We had both also prospective patients, which I just presented, but also retrospective cohorts from MSKCC, where we could do GM-CSF autoantibodies and a bunch of other assays that I won't have time to talk to you about. And so these are the results of the GM-CSF autoantibodies in patients developing colitis or who stay colitis-free. So what you can see that there are quite a few patients that have detectable titer that is really above log 2 here that we consider positive for autoantibodies to GM-CSF. And these, if they don't have colitis, even though they're there at baseline, they don't develop necessary colitis and they stay stable over time. But what we found interestingly is that patients who develop colitis, and you center it here from the day of their colitis start, there's what seems to be an increase around the time of colitis compared to pre-treatment samples as well. And this is also another way to show the same data. So in blue are the patients that did not develop colitis. In red or orange are the ones with colitis. And we're looking at here baseline versus week 6. And in those patients who develop colitis, we have also baseline in week 6 and then the sample closest to post-colitis and at resolution as well. And what you can see is that both IgG and IgA to GM-CSF increase at the time of colitis at resolution, but even statistically right before colitis in the few patients where week 6 was captured before colitis occurred. And this was confirmed both in the retrospective cohort and in prospective cohort. So it was an interesting mechanism, which was a bit different from what we expected. We thought maybe patients who had that pre-existing antibodies would have higher chance of developing the antibodies, but it's really not what we're seeing. We're seeing that this is a more induced mechanism that happens at the time of colitis rather than something pre-existing. We also compared that to the ASCA microbial antibody, which didn't show as much of the same trend. There was a slight increase maybe at time of week 6, but it really stayed mostly flat, and so did most of the other microbial antibodies, except OMP-C, even though there was correlation here between the titers to GM-CSF and the presence of ASCA-A, ASCA-G, or OMP-C as well, but not with the others. So this together maybe indicates a mechanism by which these autoantibodies contributed to some of the severity of the adverse events in a subset of patients where potentially by, again, we assume a neutralizing function could prevent some of the homeostatic capacity of GM-CSF in the gut. And this could potentially indicate that there is also some type of microbial ontology where our colleague Jeremiah Faith also looked at the stool from these same patients and looked over time and found that, for example, proteobacteria increase right before the onset of colitis. And these are some of the bacteria that are basically contributing also to the autoantibodies that we saw before. So I think that's generally the idea is that maybe GM-CSF could potentially be rescued again as a drug for some of these adverse events. It was tested before, and we see that it did achieve the secondary endpoint, which was a reduction in the CDIA score, but it was really dropped from the clinic. And so now we're thinking about maybe producing a new GM-CSF drug that can escape these neutralizing autoantibodies with variants of GM-CSF that miss the epitopes. So I want to thank the colleagues that contributed to this study and our funding from Helmsley in particular. And thank you for your attention.
Thank you very much, Sasha, for the great talk. Our next speaker is Mansi Agrawal, and the title of her talk is Differences in Fecal Microplastics in Pregnant Women with and Without Crohn's Disease.
Thank you, Inga. And thank you everyone again for joining us today. So speaking about microplastics, I'm sure all of you have read about this in the news. These are ubiquitous, these are pervasive, they're found everywhere in our environment, in the air we breathe, in the food we eat. And broadly speaking, we are now recognizing that the tiniest plastic particles are very detrimental to human health. These are considered to be microplastics if they're few micrometers or smaller in size, and nanoplastics if they're less than 1 micrometer in size. And it's also important to understand that these chemicals are extremely heterogeneous, which makes it very difficult to study them, and it makes the effects, the impact of microplastics on human health even more complex and heterogeneous. So the size of microplastics and nanoplastics matter because that influences absorption, clearance, deposition across different tissues. The physical and chemical properties also matter. Chemically, not all microplastics are the same. They're made of many, many different types of polymers. Some are very hardy, some are very susceptible to breakdown, and so that impacts the harm due to them. And also the other chemicals that they absorb on their surface, their physical properties, all impact their kinetics and their dynamics. And then finally, how we study microplastics matters a lot. First, in terms of sample collection, we have to be very stringent with our protocols to collect sample in the most microplastic-free manner that we can. And then the sample preparation, which is dependent on the type of sample. And because this is a new technique, this is an emerging field, the sample preparation protocols are also just getting developed, and they're very, very new. And then finally, the methodology that's used is very, very labor intensive because most of these methods involve spectrometric techniques. And so they're very manual. And each method has its pros and cons in terms of the chemical composition, the size of plastics, etc. And of course, all of these techniques are very expensive. So these are some of the caveats that we have to take into account when we do microplastics research. And so for this reason, we established a birth cohort called Planet because we wanted to understand the impact of microplastics and related chemicals on women with and without Crohn's disease and their offspring. So we recruit these study participants during the 3rd trimester of pregnancy. We collect clinical data, survey data, and stool samples using microplastic-free protocols. We follow the mothers and the babies longitudinally. And so the data that I will present to you broadly is of 2 categories. I'll present some survey data. We developed questions to understand personal plastic exposure across domains. We asked them questions about different kinds of beverages, food packaging, food preparation, personal care items, and cleaning products. And based on their responses, we developed scores in terms of survey-based plastic exposure. And then with respect to the actual microplastics analysis, we conducted new Fourier transformed infrared spectrometry, which, like I said, is a microspectrometric technique. And we measured these plastics in stool samples. And we looked at microplastic abundance, so the number of particles per gram of stool, the microplastic size, their shape, as well as their chemical composition. So here are some of our results. And this is a very preliminary analysis because we conducted this in our pilot sample, which is approximately 21 women with Crohn's disease and 21 without. And so when we look at these plastic scores and we compare them against stool microplastic profiles, that is microplastic abundance, shape, size, etc., we found that food preparation was associated with the highest amount of microplastics in stool, as well as a proportion of microplastic fibers, which is the more harmful shape of microplastics. Personal care items correlated with the size of microplastics. So study participants who reported more personal use items that contained microplastics, granules, etc., had a higher likelihood of having the tiniest plastics. Beverages were also associated similarly with the small microplastics, and the composite score was highly variable because we recognized that each of these domains is very distinct in the amount of plastic exposure and the size of plastic exposure. So all of this to highlight the heterogeneity of microplastics and the importance of studying specific domains of plastics and how one domain may be more relevant in terms of disease risk and intervention strategies than other domains. Then looking at the microplastics in stool samples itself, this is data from 42 participants, which includes both women with and without Crohn's disease. And as you can see here in this bar plot, every single study participant had detectable microplastics, which is a little bit scary. But the good news is that all of these microplastics had a very wide range. Some participants had only a few particles per gram of stool, whereas others had hundreds of particles. And so that perhaps is a reflection of, daily practice, daily habits, and that suggests that by modifying our behavior, the amount of plastics that get internalized can be changed. We also noted a very wide distribution in the chemical composition of plastics, and that tracked very well with the most commonly used plastics versus not. So the ones in green are polyethylene and polyester and polypropylene, which are the most commonly used plastics. Next, we wanted to understand if there are differences in the stool microplastics in participants with and without Crohn's disease. And so we looked at the relative size. So the graph on the left denotes the relative size from the smallest 10% particles to the largest 10% particles. Controls are in purple and CD is in pink. And so as you can see in the bar plot, as well as in the PCA analysis on the right, there is quite a distinction in the distribution of the relative size of plastics in CD versus controls. In controls, it's the smaller particles that predominate, whereas in CD, it's the larger particles that predominate. So that begs the question, what happens to the tiniest microplastic particles in those who have Crohn's disease? Do they pass through the mucosa? Do they get internalized? Or there is a difference in the pattern of microplastics exposures. There is not a lower microplastics exposure in women with Crohn's disease. On the contrary, as I showed earlier, women with Crohn's disease may have a higher microplastic exposure, but simultaneously, the distribution is distinct. And also remember that the tiniest microplastic particles are the most harmful ones because they get absorbed most easily. They have a larger surface area, so other chemicals adsorbed on the surfaces are more. Then we wanted to understand the relationship of these chemicals with fecal calprotectin, as well as the impact of different types of microplastics. And so here we look at the number of microplastic particles per gram of stool and its relationship with calpro, as well as the mass, so the weight of plastics. And we find that there may be a trend of number of plastics with calpro, the relationship, but there wasn't a statistically significant association. When we looked at the chemical type, there was a signal for polyamide or nylon, which also represents some of the smallest particles of plastic and those that are very, very present in our environment through our personal clothing as well as through our ambient environment. And so this may be a potential area of further study to understand the role of polyamide or nylon, as well as the tiniest microplastics, that is the nanoplastics in Crohn's disease. And so how do we translate this to our clinic? Is it too early to translate this to our clinic, or there is some advice that we can provide to our patients? And absolutely, we need much, much more data. These are very early pilot data in a very small sample, and we're recruiting more study participants and looking at more analyses to understand deeply what this differential plastic distribution means. But simultaneously, I think we can advise our patients about minimizing plastic materials, nonstick cookware, advise them on minimizing ultra-processed foods, synthetic materials, and so on, because these do contain plastic particles, and there are plenty of data that minimizing them decreases the amount of plastic exposure. And simultaneously, we can encourage the use of fresh home-cooked foods, natural materials, mopping, cleaning the homes regularly, and so on. And this empowers our patients, and it's also relevant across diseases. And so in summary, micro and nanoplastics are ubiquitous chemicals with complex physical and chemical properties. They impact human health adversely. Plastics and chemicals measurements is very, very challenging. And so we have to be very careful about the techniques used. Personal MNP or plastics exposure appears to be different in individuals with and without Crohn's disease, as well as there is a differential fecal plastic size distribution in CD versus controls. And so these preliminary data indicate that plastics are relevant to Crohn's disease outcomes and possibly to even risk. And so that warrants a deep dive. And so with that, I thank you for your attention.
Thank you so much, Monsi, for the excellent talk. Our next presenter is Dr. Haider Saeed, and the title of his talk is Impact of Circadian Rhythm on Drug Efficacy in IBD.
Before we begin, I just wanted to thank the organizers for having me today to be able to talk about our research on the impact of circadian rhythm on drug efficacy in IBD. And so just some background in regards to circadian biology and its role in immune regulation. As many of you may know, circadian rhythms synchronize central immune and intestinal clocks with certain environmental cues, and the most important of which are light and sleep, which will synchronize the central circadian clock, which in turn entrain many different peripheral clocks throughout the body, one of the biggest reservoirs of which is the GI tract. And this plays important roles in many different physiological functions, including immune system and inflammatory response, by regulating cytokine signaling, leukocyte trafficking, and gut barrier function, which can oscillate diurnally throughout the day. In IBD, circadian disruption is common and can be linked to mucosal inflammation, dysbiosis, and impaired barrier function. And that can lead to impaired gut microbiome host interactions and ultimately lead to intestinal and systemic inflammation. Treatment effects may also be time-dependent, as circadian rhythms shape drug exposure and immune target availability. And this has actually led to the advent of an entire field of chronopharmacology, or chronotherapy, which tests whether aligning treatments to biological rhythms can improve response. So this is not entirely new to the immune-mediated space. Chronotherapy has improved outcomes in other IMIDs, including rheumatoid arthritis, which you can see here on the right. This was just a clinical trial that looked at modified release prednisone and dosing it in the evening prior to symptom onset. And so they basically attempted to dose this to where the release would occur before morning stiffness and pain would occur. And so you can see the top graph, there's a 20% reduction in pain, which is a standard score that they have in RA trials. There's a nice reduction with the evening dosing, and then also with the reduction in morning stiffness as well. And this has been similar in other immune-directed interventions, such as vaccinology, especially with the flu shot. Additionally, one of the more exciting areas as well is in oncology, where emerging data suggests that earlier immunotherapy dosing may improve outcomes. And this is exciting because these are long half-life drugs, every 3 to 4 weeks. And this is a paper published in Nature Medicine earlier this year that essentially found that early dosing, so before 11:30 a.m., which is the graph with the blue you can see in the Kaplan-Meier curves, that led to improvements in progression-free survival and overall survival. And this was for metastatic non-small cell lung cancer. And so just the numbers are a little bit hard to see, but this basically improved the progression-free survival from 6 months to 11 months, which is significant statistically and clinically. And then for overall survival, there was actually almost a 12-month increase. And so, that was one of the exciting areas in chronotherapy. In IBD, there has been one study of chronotherapy, which was with thiopurines. This was done in 2023. And essentially what they did, it was just a randomized crossover study. And so they dosed the thiopurines in the morning, and then they transitioned over to the afternoon, or vice versa. And you can see the bullets on the left essentially are the morning doses, and on the right are the PM doses. And there are higher levels of therapeutic 6-TG and lower levels of hepatotoxic 6-MP metabolites. However, whether timing of biologic administration affects IBD outcomes is unknown. And so this is what led to the study, which I want to give a special shout out to Dr. Suzanne Ibbing, who's in the crowd, who helped to lead some of these analyses. And this was a cohort of over 1,100 patients, where we looked over the entire Mount Sinai health system from 2011 to 2025. Primary outcome was treatment non-response, which was essentially derived from biologic discontinuation, IBD-related surgery, or IBD-related hospitalization. The exposure was simply timing. And so there had to be a few constructs that we created. The first of which was PM ratio, which was just a proportion of infusions after 12 p.m. So it scaled from 0 to 1. And there were other timing features to look at the variability of the timing, such as skewness, variability, IQR. And the modeling was using XGBoost modeling, where we compared clinical versus clinical and timing features for model performance. And then we attempted to externally validate this in the all of us cohort. And so this is sort of a busy slide. We're only going to just show a few points here. I think just to show this looks at drug response versus no drug response. And, there were certain factors that we know clinically make sense in regards to drug non-response. Lower albumin, higher baseline CRP. But interestingly, there were actually pretty significant differences in these timing features as well, which I'll go over in the next slide. And so the first thing to note here with this P-swarm plot was that the top 4 predictors of treatment non-response were actually timing features. And so this attempted to show that temporal features outperformed conventional clinical predictors. Really it showed that higher PM predominant dosing and greater timing variability predicted non-response, so favoring morning consistent dosing. Including timing features actually improved our model performance as a whole, with area under the curve going from 0.59 to 0.83. And then also improvements in the precision, which is essentially the positive predictive value of the model, and then the recall, which is a proxy for sensitivity. And the predictive performance was consistent across disease subtypes, biologic classes, so infliximab and vedolizumab, sex and race. Next, we attempted to take this a step further and validate this against an external cohort, which was the all of us cohort, which was smaller. It was just about 140 patients. And the PM ratio, which was the predominant thing we were interested in assessing, improved discrimination externally. However, there was some degradation of calibration on the external data, supporting the need to further investigation, ideally through a prospective validation. We also performed an exploratory endoscopic analysis where we just took the extremes. So people who only had morning or only had afternoon infusions throughout this time period. It was actually very interesting. The endoscopic remission was pretty significantly different between the two. And so you see on the right in the red, there's a 19.2% endoscopic remission rate on the treated cardiac scope for those who had a PM ratio of 1 compared to 42.3% for those that had a PM ratio of 0. And so this essentially has led us to now be interested in looking at this prospectively, because there are many different signals that we are not capturing, obviously, in the CHR data that need to be looked at, in the future. Because for one, this is a very easy, scalable potential approach to our biologic therapy. And so what we are looking at, with Dr. Ibing, Dr. Ungaro, Dr. Colombel, is basically UC patients starting new biologics, specifically interested in those infusion-based therapies as well as guselkumab, randomizing those patients to AM and PM dosing, and then following them up for at least 6 to 12 months, looking at adherence because it's a pilot, but also clinical remission, biomarker response, endoscopic response, and then transmural remission as well. And then one of the questions that we always have is, what would this mechanism even be? And so we're interested in looking at this through a multimodal approach. One, by tracking circadian rhythms longitudinally using some of the wearable device algorithms that we have, but also through immune profiling with Dr. Mahan and his group as well. And so our future directions are as follows. We want to, have a multi-site validation. We're expanding the EHR cohort, which Dr. Ibing is leading, with a Mayo cohort, a cohort from the UK, and so on. We also are interested in post-hoc timing analyses from biological trials. And so that is another step in regards to validating these clinical signals across independent cohorts. We are performing this prospective trial, which we are enrolling, so I'm sure I'll be emailing all of you about patients in the near future. But we also are interested in creating these precision biomarkers that are scalable to identify if this truly is a signal, which patients would benefit most from it. And the last thing would be, ultimately, I think the holy grail would be to have an integrative chronotherapy approach where we have precision strategies combining not just biologic timing, but other features that we've shown that can impact the circadian rhythm, such as sleep, light, circadian behavioral interventions, such as food timing as well. And in conclusion, circadian immune regulation suggests biological efficacy in IBD may vary by time of administration. In our retrospective cohort, timing features predicted biologic non-response beyond standard clinical variables. External validation, exploratory endoscopic findings support this as a clinically relevant signal. And we are performing a pilot randomized chronotherapy trial to prospectively test whether timing can improve biologic outcomes. And thank you to everyone here and to, of course, the collaborators that have helped with the study.
Thank you so much for the wonderful talk. Our last talk for this session is by Dr. Stephanie Gold, And the title is The Role of GLP-1 Therapies in IBD from Metabolic Health to Disease Outcomes.
Wonderful. Thank you so much for inviting me today. So I'd like to take the next 10 minutes or so and tell you a little bit about some of the data we've had with our patients with IBD who have undergone GLP-1 therapy, and a little bit about what we know about obesity in this population. I have no conflicts of interest related. So I don't need to tell anybody here that overweight and obesity is a rising epidemic in this country. And we know that over half of the US population will suffer from obesity by 2030. And it's estimated that 1 in 4 Americans in the US will have severe obesity with a BMI over 35. So we did an interesting study looking at TriNetX data to see, is this actually approximated in the IBD patients? So we know that IBD has traditionally been a disease associated with malabsorption and undernutrition, but in fact, roughly a third of the US population with IBD are actually living with concomitant obesity, and 2/3 with either overweight and obesity. And so this is something we're seeing in all of our clinics. We know that obesity is associated not only with worsened cardiometabolic disease, but also poor IBD outcomes, and I'll show you some of that data today. When we think about obesity and IBD, we know that these patients are having more severe phenotypes at presentation, more frequent flares, so less time between the next flare, increased rates of surgery, needs for hospitalization with longer lengths of stay, higher hospitalization costs, poor response to biologics, specifically some studies looking at TNF inhibitors, and higher rates of surgical complications. But what's most interesting about this is that it's not the BMI per se that's driving this, but when we look at the data, it's patients with higher amounts of visceral fat that are actually having these poor outcomes. So when we looked at the data specifically for visceral fat, we know that patients who carry more of that central or visceral adiposity have more complex Crohn's phenotypes at presentation, higher rates of post-op recurrence after ICR, decreased time to that next IBD flare, and need for significantly higher levels of infliximab in order to achieve steroid-free clinical remission and endoscopic remission, as you see in this graph on the bottom right. So when we looked at our data here, when we see these patients in clinic, we identified that the obesity phenotype in IBD just looks different from that of the general population. So we accumulated a cohort of patients who did not have IBD, who had overweight and obesity, and then compared them to our patients with IBD and overweight and obesity. And what we saw is that you see significantly lower rates of diabetes, prediabetes, CKD, obstructive sleep apnea, metabolic liver disease. Similar, but still lower levels of hyperlipidemia and hypertension. But even more interesting, what we saw is that these patients have more of an inflammatory phenotype. They have more EIMs, more uveitis, spondyloarthropathy, peripheral arthritis, more cases with psoriasis and thyroid disease. So this is a different phenotype than the standard kind of general population patient you're seeing with overweight and obesity. So what do we do about it? So we know that this is kind of the standard interventions that we've talked about in the past, where patients may have started with a lifestyle intervention, which only leads to maybe 2 or 8% total body weight loss, and then potentially consider things like pharmacotherapy, endoscopic, and bariatric procedures. But we've really tried to rethink that here at Sinai, where we understand that lifestyle modifications underpin all of these interventions, but for most of our patients, they need a boost from something else. And that could be a medication, an endobariatric, or a bariatric surgery. So this is some of the data looking at weight loss efficacy for GLP-1s in patients with IBD. We believe it to be effective, similar to that in the general population. In our practice, it's been more effective. We see, and I'll show you some data on that, but you can see variable data here showing the efficacy at 12 months. And our experience has been that low dose is sufficient for clinically significant weight loss, and just titrate the dose slowly. Perfect. So this is the study we did. So we looked at about 115 patients over the course of a year who were seen in our WeightWise GI program. All of them had IBD, all were either overweight or had obesity, and 95 had a minimum of 3 months follow-up. Half of the patients, almost exactly, were started on a GLP-1, and everybody got the same lifestyle intervention that was here. So the lifestyle intervention was a plating strategy, half a plate of non-starchy vegetables, quarter plate of lean protein, quarter plate of starch, no snacks during the day unless hungry, and if hungry, patients were offered a fruit or a vegetable, but nothing else, and then no sweetened beverages. Patients were encouraged to walk 30 minutes a day and resistance training twice a week. And so half of the patients were just involved in the lifestyle intervention, and half of the patients ended up going on to a GLP-1, majority of which was tirzepatide weekly dosing. And we looked to see what happened to patients at a year. At median BMI before they started was 35, and about 72% had hepatic steatosis on FibroScan, but thankfully only 3% had any fibrosis, which is what we've seen clinically in our patients. We looked to see what happened, and after a year, the patients treated with the lifestyle intervention plus GLP-1 had significantly more weight loss at all of the time points. So at 6 months, you see here at 9 months, and then up to 12 months. And at 12 months, the group that got the GLP-1 plus the lifestyle had an average of 20.9% total body weight loss, while the group that got the lifestyle intervention alone actually had about 2.9% total body weight gain. And so we saw that the GLP-1 was significantly beneficial for these patients. But more than not just the weight loss, we asked them about their lifestyle and what else was better. These patients on the GLP-1 were significantly more likely to report improved stool frequency, so using that anti-motility agent from these medications, and then as well as improvement in fatigue at 3 and 6 months of therapy. And we looked at complications. There was no difference in ER visits or hospitalizations among the two groups, so nothing to suggest any side effects that were concerning in the GLP-1 group. What about the impact of GLP-1s on IBD outcomes? So this is an area of significant interest. The first thing we just talked about, which is the anti-motility effect. So this is an excellent medication for patients who have refractory diarrhea or who have high output from their ileostomy, pending that you're monitoring their creatinine. And we know that the joint pain that patients can present with IBD actually can improve on the drug independent of weight loss. So there's a dual mechanism there. But when we think about disease-specific outcomes, we've seen studies showing significant reduction in CRP at 1 year, as well as improvement we've shown in clinical disease activities, decreased needs for surgery, and then a composite outcome with decreased risk of surgery, hospitalization, steroid use, and use of advanced therapies. How does this work? I think there's a little bit of question about how this works, but we know GLP-1 is secreted by the intestinal epithelium, the enteroendocrine L cells with a high density in the TI and in the rectum. And dysregulation of GLP-1 in IBD rodent and human models has been shown to lead to active inflammation. And GLP-1 use is associated with a wide range of immune effects, reduced macrophage migration, decreased concentrations of pro-inflammatory cytokines, things such as TNF and IL-1. And so higher concentrations of GLP-1 may actually support mesenchymal and myeloid cell populations that are needed for intestinal healing. So in summary, we know that the prevalence of obesity is rising among patients with IBD and similar to trends in the general population. We really want to be thinking about visceral fat in our patients with IBD as that is associated with that more severe phenotype. We know that the IBD obesity phenotype is different from that in the general population. Less cardiometabolic disease, more inflammatory disease. And the treatment should really involve effective strategies to achieve a healthy weight and visceral fat reduction. Here at Sinai, we're working on now prospective data to be following patients who are starting on a GLP-1, monitoring their FibroScans, clinical outcomes, IBD outcomes, and so hopefully we'll have further data for you in the years to come. Thank you so much.
Thank you very much, Stephanie, for the great talk. And I would ask all the speakers to come up. Okay, so I see we have questions. Jean-Fred, please.
Yeah, I have a question for Sasha. Sasha, in our experience, of course, GM-CSF antibodies are strongly associated with ileal complicated Crohn's disease. So, but in colitis induced by checkpoint inhibitors, this is mostly a phenotype which is colonic. And you didn't show any data about the alpha V beta 6 antibody. You didn't find any in those patients, right? I don't know.
Is it better? Yeah, with Sarab and Ali, we looked at the antibodies to alpha V beta 6 as well, and they were surprisingly all negative in these patient populations. we couldn't really find any, which, as you said, like when you look at IR colitis, it looks more probably like regular colitis and colonic presentation than it does with ileum. But it's interesting that these antibodies may have a role. And we should still say that, like, even in ulcerative colitis, we don't see a lot of antibodies to GM-CSF, but they are slightly more prevalent compared to the healthy donors. So there may be a slight subset that could still have some effect more generally in the macrophage balance in the gut. I don't know.
And I have a question for Nancy. Nancy, of course, what will be very interesting is to look at microplastic in the tissue of our patient with Crohn's disease. But how will you be able to do that? Because, you know, that means that the surgeons will have to change everything. So do you think it's possible? Because you need no plastic and they are using a lot of plastic when doing surgery, right?
Yes, that's a great question. Thank you, Jean-Pierre. I think that studying microplastics in tissue is a very important next step to understanding its role in disease. And I think it can be done in two ways. One, looking at endoscopic biopsies from colonoscopies, and two, in surgery. I think in tissue, external contamination is a little bit less of a problem, especially if you're looking at deeper layers of tissue than it is in other specimens like stool and saliva, etc. And so we're actually working on a study where we're looking at formalin fixed slides, looking at microplastics within granulomas in ileal biopsies and in colonic biopsies. So I completely agree with you. This is the next important step.
Thank you for the excellent talks. Actually, I had two questions, but Jean-Fred asked the one that I had for Sasha. I have another question for Nancy. Just quickly, what was the rationale for selecting only CD patients in your PLANET study and not UC patients using others?
We selected CD patients, one, just to look at one disease more homogeneously to make it less of a heterogeneous population. And two, I think there are a little bit more data, or mechanistically, we can explain the role of plastics in CD a little bit more than UC, where in CD there are granulomas and there is inflammation in the ileum, because we recognize the relevance of Pierce patches in their relationship or the interaction with exogenous factors and also, you know, the foreign body reactions around granulomas, etc. Also, the very long preclinical period in Crohn's disease. But to your point, Catherine, I agree that this is just a start, and I think it's relevant to study plastics across diseases, including UC. Thank you.
Hi, I'm Katharina Gutwein from Saurabh Mehandru's lab, and I also have a question for Mansi. So you showed that there's a different distribution in the microplastics in CD patients, and I was wondering whether you think with the study you will be able to answer whether it is that the microplastic leads to more CD, or is the other way around, that because of the reduced barrier integrity, they have different distribution.
That excellent question. I think so. I don't think we can answer if plastics are associated with increased risk of CD, because at the time of enrollment, all these participants already have disease. I think it's more the second point that you mentioned. And I think that's my hypothesis too, that in the context of having impaired barrier function in participants with CD, they may be absorbing, they may be internalizing more plastics, which suggests that people with Crohn's disease may be more susceptible to the adverse effects of plastics. And as to the first point about plastics and their impact on intestinal inflammation and CD risk, that's another study that definitely needs to be done.
Thank you.
Thank you for the nice talk. I have a question regarding the GLP-1. Yeah, so fantastic presentation. As we know, like chronic inflammation can induce like muscle wasting, and GLP-1s can also promote some muscle loss, especially non-skeletal muscle. So what are the concerns that providing that type of treatment to patients in terms of their non-skeletal muscle that might be important for their bowel movement or other functions?
Yeah, absolutely. It's a great question. So we monitor muscle mass in all of our patients, both using muscle function and then direct ultrasound to actually measure muscle mass prior to starting the GLP-1 and then throughout the course. And we're using this as part of our prospective study. For now, when we've been doing our studies, we're very big on focusing on protein as well as resistance training to try to get our patients to build more skeletal muscle while on the drug. but we counsel all of these patients about the risk of sarcopenia in the setting of having active IBD, as well as the risk of sarcopenia and muscle loss from the drug. So this is something we're worried about. Absolutely.
And you're going to keep like studying that because I think that's very important for the field to understand.
Absolutely. And in our prospective study, we're getting rectus femoris and biceps direct ultrasound measures, as well as grip strength, sit to stand. So we're getting a full anthropometric picture of these patients.
Steph, a question. Steph, what are your thoughts on lean obesity? So individuals who may have normal BMI, who may appear to be not obese, but actually they do have substantial visceral fat. How inflammatory that is, and how may that impact IBD outcomes?
Absolutely. Thank you. That's a great question. So I think the community has really come to change how we're defining obesity. And we're going to be moving away from BMI, I think, in the next couple of years. We've really started to talk about clinical obesity versus preclinical obesity, where it's really more dependent on, are you seeing metabolic disease associated with weight, and especially visceral adiposity? We know that the visceral adiposity is hormonally incredibly active. It secretes TNF and IL-1. And so this is the tissue we need to be focused on. And so I do think focusing on visceral adiposity as opposed to weight or BMI is crucial. We see a lot of this lean obesity.
Yes, please.
I had a question for the circadian rhythm. So I know that your clinical trial is designed based on patients getting infusions, but now that a lot of the medications are switching to being sub-Q, are you going to go ahead and tell your patients, like, maybe you should do this in the morning? And also, are you also going to account for individuals who do shift work?
Yeah, great questions. With shift work, those patients are right now excluded just because for most circadian studies, they have to be just because they're not generalizable. But it is, a proportion of our patients. And there's been some data that shift work actually can increase, complications in IBD in terms of structuring and fistulizing disease. And they're more associative studies, but totally a patient population of need. In regards to the sub-Q, it's a great question. So what we're doing is we're actually stratifying. We're actually doing sub-Q induction and maintenance of gasolcamab, because I think we're interested also, this is in a different strata, in looking at, is it that we have a peak level of IV infusions within an hour, of that treatment? And is that really how this mechanism works, rather than the target specifically, versus sub-Q, which can take up to 3 or 4 days to sort of peak in that way? So I think it's actually a very important question, because as we're positioning now more towards sub-Q medications, if they don't have a chronotherapeutic benefit, that actually might be a reason also to give them as well.
Wonderful. One last question.
Hi, Monsi. My question is for you. Because you spoke about that you were doing with tissue and like fixing them, and seeing whether you have microplastics in them. Do you think that the differences that you're seeing is because of tissue fibrosity? Like if it's an intact tissue, you see a different kind of microplastic bioaccumulation versus if it's more inflamed, it has more. Do you have like anything to comment about that?
So the data that I presented were on stool samples. Separately, we've developed the protocol and we're looking at slides, so formalin fixed slides. And I think I will have a clarity about your question the next time we have this conversation.
Since you mentioned that you were doing that,
Yes, we're just starting, so I don't have those data for you, but that's an excellent point. I think it warrants a deep dive. Yes.
Thank you.
Wonderful. We're right on time. I would like to thank our presenters. We'll take a short break and be back at 11 o'clock sharp. Thank you so much.
Okay, so it gives me pleasure to introduce Catherine LeBaire, microglial-like similarities of submucosal glial cells.
Good morning, everyone. So thank you, Jean-Fred and Saurabh, for giving me the opportunity to present some of the work that I've been doing here during my year at Sinai, which is almost done, unfortunately. So the enteric nervous system is the intrinsic nervous system controlling intestinal functions, especially in the small bowel and colon, independently of the central nervous system. It's basically organized into ganglia, grouped into 2 main plexuses, the myenteric plexus, which controls gut motility, and the submucosal one, which controls the intestinal epithelial barrier. It's organized into ganglia, which contain clusters of neurons, and glia, interconnected by interganglionic fibers. Okay, go ahead. So the enteroglial cells actually outnumber the neurons in both the myoclonic plexus and the submucosal plexus. And they have a remarkable plasticity, which makes a strict classification difficult to apply in practice because they have a dynamic expression that changes according to the anatomical location and the environmental stimuli. And beyond their support to neurons role, they interact with many neighboring cells. So they interact with the microbiota because they express, for example, TLR4. They produce a number of lipid mediators with a role in epithelium differentiation, permeability, and they promote their healing. And they also interact with a number of immune cells, for example, the macrophages, especially those in the muscularis and intraganglionic macrophages, by the production of MCSF, but also the production of GDNF, which allows to activate some of the ILC3 and allow the production subsequently of IL-22. And they also have been shown to inhibit the proliferation of T cells. And in IBD, there have been demonstrated to have structural changes, but also functional alterations, such as a dysregulated secretion of gliomediators, impaired production of lipid metabolites, and immune interactions such as plexitis associated with postoperative recurrence in Crohn's disease, and an increase in MHC2 expression. So it does have emerging functions, but actually their identity in IBD remains kind of unresolved. Some at the single cell level, some studies, some teams did look at the single cell level and at the enteric nervous system, but actually most of them focused either on the myoclonic plexus only or the neurons only, and without any focus on enteroglia. And only one of them had focused on IBD patient and namely active UC patients. And in this study, you can see that the number of patients was very small and there were no patients with inactive UC or uninflamed area. So the objective of this work was to characterize the single cell transcriptomic profile of submucosal and mucosal enteroglial cells in UC patients across disease activity states. So single-cell transcriptomics revealed 3 distinct enteroglial cell states. Actually, in the UMAP, you can see 7 subclusters, but I excluded 2 of them because there were contaminations by either T cells or B cells. And I removed also 2 of these subclusters because they were very too small in size. So I will mainly focus my presentation on these 3 subclusters. And as you can see here very well on this figure, these 3 subclusters distribution reflects UC disease activity. So the cluster that is predominant in healthy controls display a profile consistent with a mature homeostatic state of the glial cells. And enriched pathways, including gliogenesis, axonogenesis, muscle contraction, myelination, reflect a program dedicated to maintaining physiological neuroglial functions. Conversely, the downregulation compared to UC patients of immune-related pathways, including T-cell activation, antigen presentation, and cytotoxicity, suggests that these enteroglial cells are in a state of active immune tolerance, consistent with their role as regulators of mucosal homeostasis under steady-state conditions. The cluster that is almost exclusively enriched in active UC is characterized by the overexpression of pro-inflammatory genes and the enrichment of pathways related to TNF response, T-cell activation, and antigen presentation, notably involving CD74 and the MHC2 complex, suggesting an acquired pro-inflammatory state of these enteric glial cells. And last but not least, the cluster that is nearly absent in healthy control but present in both active and inactive UC displays a transcriptomic profile of tissue remodeling with enrichment of pathways related to wound healing, extracellular matrix organization, NF-kappa B signaling, or glial cell development, consistent with a persistent reactive state that may be potentially detrimental. And furthermore, the downregulation in this cluster of calcium response pathways, as you can see here, could reflect an impairment of intracellular glial signaling, as documented in models of chronic neuroinflammation in the CNS. And in this context, PLCT2 is of great interest. So PLCT2, as you can see here in my data set, is strongly downregulated in both active and inactive samples from UC patients compared to normal volunteers. And PLCT2 is it's the short for phospholipase C-gamma-2. It encodes a membrane-associated phospholipase acting as a key intracellular signal transducer. And downstream of membrane immune receptors, its recruitment depends on lipid microdomain integrity, linking receptor activation to intracellular calcium mobilization, lipid mediator generation, and subsequently coordination of cell survival, autophagy, proliferation, and inflammatory responses. As you can see here, in the central nervous system, it's more and more studied in the microglial cells. And it's, for example, in Alzheimer's disease, both gain of function and loss of function variants have been associated with the risk of Alzheimer's disease, but also other neurodegenerative disorders. And beyond neurodegeneration, a protective variant has also been associated with a reduced risk in multiple sclerosis, so suggesting a broader role in neuroimmune homeostasis. And at the systemic level, a dominant activating mutation is also responsible for the aplate syndrome, which is a severe autoinflammatory disorder underscoring PLCT2's central role in innate immunity. In IBD, PLCT2 variants have been associated in GWAS studies with UC, but no study has since investigated the role of PLCT2 in IBD, and no expression had ever been described in enteric glial cells. So it's the first description here. So in conclusion, single-cell transcriptomics of submucosal enteric glial cells identifies 3 distinct glial states whose distribution closely mirrors UC disease activity states. And one subcluster is absent in healthy controls, but present across both active and inactive UC. And it carries a reactive signature of tissue remodeling, NF-kappa B signaling, and impaired calcium response consistent with a potentially detrimental chronic glial cells that could, for example, have a role in the persistence of functional symptoms despite IBD remission. The reduction of PLCT2, previously undescribed in enteric glial cells, may reflect the collapse of a homeostatic lipid signaling program and a broader innate immune-like reprogramming mirroring microglial dysfunction in the central nervous system neuroinflammation. And these findings obviously now call for experimental validation at the protein and the transcript levels, and for functional studies exploring the consequences of this glial reprogramming on the enteric nervous system signaling and mucosal homeostasis. With that, I would like to acknowledge Jean-Fred, Saurabh, and all the Mehendru lab members, especially those who processed these biopsies to generate those data, as well as my lab members in my lab in France and my funders. And I thank you for your attention.
That's terrific. Even with that safety warning, she's on time. So our next speaker will be Divya Jha, remodeling of intraepithelial gamma delta T cells and ulcerative colitis.
All right. Hello, everyone. I'm Divya Jha, and I'm a senior scientist in Dr. Saurabh Mehendru's lab. And today I'll be talking about remodeling within intraepithelial gamma delta T cell compartment in ulcerative colitis. So needless to emphasize to this crowd, ulcerative colitis is a chronic inflammatory disease of the colon with a complex multifactorial pathophysiology. And one of such factors is impaired epithelial barrier function. And when we talk about barrier function, We also need to mention about IES, which are very crucial for the maintenance of this barrier function. These are the unconventional T cells that reside in the intestinal epithelium, and they carry out protective functions at the barrier surfaces because they quickly respond to any kind of tissue injury or infection. But because of their heightened activation status, they can also exacerbate intestinal inflammation as seen in certain diseases such as celiac disease. And IELs, based on their T cell receptor composition, could either be alpha beta or gamma delta in their subtypes. And gamma delta T cells are distinct from their alpha beta counterparts in the fact that they can directly recognize the antigens bypassing the MHC molecules. Also, they express natural killer receptors on their surface, putting them functionally very close to the natural killer cells. So in our study, we adopted a colonic epithelium-focused approach, wherein after receiving the colonic biopsies, we isolated the epithelial compartment and investigated this compartment using single-cell RNA sequencing and flow cytometry. In our flow cytometry dataset, when we compared the alpha beta and gamma delta T cell frequencies, we found that there was a significant reduction in the frequency of gamma delta T cells in the inflamed UC samples when compared to healthy or uninflamed UC samples. So we then wanted to take a deeper dive and understand the heterogeneity within gamma delta T cells, both under steady state condition and in disease condition. For this, we made use of single cell RNA sequencing data that we generated in the lab on 9 normal controls and 9 active UC patients. And based on the expression of gamma delta specific transcript TRGC2, we then subsetted this compartment into further subclusters. And while there was a large degree of overlap between these subclusters, we could also identify certain unique transcripts across these subclusters. So based on the gene composition, we then annotated these subclusters into gamma delta T cell subtypes and studied the association of these subtypes with active disease. And we found that certain subtypes associated negatively with the disease, while certain others showed positive association with the disease. For today's presentation, I'll briefly discuss 2 of the protective subtypes and 2 pathogenic subtypes of gamma delta T cells. So the 2 healthy or health-associated gamma delta T cell subtypes were natural killer-like gamma delta T cells and resting or quiescent gamma delta T cells. And when we carried out pathway enrichment analysis on these subtypes, we found that when UC versus healthy samples, the downregulated samples in UC patients showed a downregulation of pathways that are essential for the maintenance of epithelial homeostasis, such as tight junction, also nucleotide biosynthesis, metabolism of amino acids, as well as certain Wnt signaling pathways. And all of these pathways are very crucial either for the maintenance of the epithelial barrier function or for the maintenance of intestinal stem cells, as well as for mucosal repair systems in the at the barrier surfaces. On the other hand, this reduced subtypes showed now upregulated levels of more pro-inflammatory pathways, such as cell killing, interferon response, as well as MAP kinase pathways. And at the gene levels too, we found that there was a reduction of genes encoding natural killer receptors in UC-associated gamma delta T cell compartment compared to steady state associated gamma delta T cell compartment. So here you can see that there is reduction in expression of NK receptors like CLRK2, CLRK3, CLRK4, which are all NK receptors, as well as natural cytotoxicity receptor 1 and 2, along with adapter molecules styrobp. Moving on to the pathogenic subtypes, we found a significant positive association of IL-17 expressing gamma delta T cells and NK-like cytotoxic GDTs with active UC. And we found that this pathogenic subtype had upregulated levels of pro-inflammatory pathways such as cellular response to interleukin-1, interferon signaling, IL-17 signaling, IL-2, and JAK-STAT signaling. We also found that unlike in healthy gamma delta T cell compartment, in inflamed UC gamma delta T cell compartment, there was this emergence of interferon gamma, IL-17 co-expressing gamma delta T cells, which in literature have been shown to be highly inflammatory in nature and are highly responsive to IL-12 and IL-23 and being very pathogenic in nature. We also saw a significant increase in the frequency of NK-like cytotoxic gamma delta T cells, which were more involved in pro-inflammatory pathways similar to the GDT17 cells. And these pathways were interferon signaling, cellular response to IL-1, JAK-STAT signaling, and cytokine production. We found that at the gene level, within the gamma delta T cell compartment, there was an increase in the genes encoding for cytotoxic effector molecules such as granzymes, granulysins, perforins, and also genes related to interferon gamma and IL-17. Having seen these associations of protective and pathogenic subtypes with active disease in our small cohort of 18 subjects, we also wanted to see if it holds true in a larger data set. So we made use of MSCCR cohort, which is Mount Sinai Crohn's and colitis registry, and has bulk RNA sequencing on biopsies from a larger number of patients. And when we studied the association of the protective subtype NK-like gamma delta T cells with both histologic severity and endoscopic severity, as depicted by Nancy Index here and based on Mayo scores for endoscopic severity, we found that the gene signature from NK-like gamma delta T cells showed a significant negative association with disease severity in UC. Also, the pathogenic subtypes GDT17 cells showed a significant positive association with increasing disease severity. So to sum up, today I have shown you that there is a transcriptomic remodeling within intraepithelial gamma delta T cell compartment in UC, where we are seeing a downregulation of protective pathways that are essential for the maintenance of barrier function, and that includes tight junction, nucleotide biosynthesis, amino acid metabolism, and Wnt signaling. On the other hand, we are seeing a concomitant increase in more pro-inflammatory programs at these local inflamed sites, which are GDT-mediated interferon and IL-17 signaling, cellular response to IL-1, and JAK-STAT signaling. And our future work now includes to identify more cell-cell interactions as well as pathways for all these gamma delta T cell subtypes, and then to study the associations of all these subtypes with clinical outcomes in patients. With this, I would like to end my presentation, and I express my thanks to Dr. Saurabh Mehandru, our mentor, and entire Mehandru Lab team, and everyone who has participated in this study. Thank you.
Thank you, Divya. Our next speaker will be Joanna, continuing our discussion of intraepithelial lymphocytes, but now in the small intestine. Joanna de Barrios Martins. Joanna.
Good morning, everyone. I would like to thank the organizers for allowing me today to present my work that I've been developing in Karen Zetterblom lab for the last year. So it's needed to remind everyone here in the audience that several therapies have been developed to treat patients with IBD, and they're mainly focused in targeting either pro-inflammatory cytokine signaling or immune cell recruitment. But it's important to highlight that most of these treatments that have been developed is focused on treatment of lamina-appropriate immune cell populations and acting predominantly in chronic stages of disease. However, the role in the IEL compartment, as Divya has just highlighted, is poorly understood. Again, I don't need to introduce this because Divya did a great job, but intraepithelial lymphocytes are cells that are located within the basal membrane and between the adjacent enterocytes, as you can see here in picture depicted there, and they provide a first line of defense against luminal microorganisms. They can be subdivided into two populations, such as induced IELs, the TCR alpha beta expressing IELs that can be CD4 and CD8 alpha beta, and as mentioned, they are MHC dependent, and the natural IELs, which are characterized by their expression of CD8 alpha alpha homodimer, and can be either TCR alpha beta or gamma delta, and as the title suggests, my lab focused mainly on these gamma delta IELs, which are MHC independent. One important thing to notice In comparison to other T cells, gamma delta IELs develop in situ, and they differentiate from a stem-like precursor population into effector-like by responding to TCR engagement and cytokines such as IL-12 and IL-15. And while stem-like gamma delta IELs retain their ability to respond to TCR, this effector-like phenotype effector-like population does not. And in consequence, these cells are not able to produce cytokines. However, it's important to highlight that these cells produce a lot of enzymes in their core by the upregulation of CD8 alpha alpha. It's correlated to the upregulation of the CD8 alpha alpha. However, the gamma delta T cells play an important role in epithelial barrier function, and they do so by keeping their response at bay. And in order to do so, they downregulate or upregulate inhibitory receptors and immunotary molecules such as CD39, which help them retain their immunological quiescent state. So what do we know about IELs in Crohn's disease? A study from Mark Corona's lab has shown previously that there's a decrease in the frequency of gamma delta IELs in biopsies from ileal resection or from ileal resections in patients. And this was not only observed in ileal and inflammation side, but also in non-inflamed side. However, we don't know whether this reduction in gamma delta IELs is a cause or consequence of this inflammation. So in order to answer this question, our lab is using TNF delta ARI mice, which are transgenic mouse that has a deletion in the ARI 3' EGR region of the TNF mRNA, leading to an increased mRNA stability and exacerbated enhanced translation, leading to increased production of this protein TNF alpha. And as you can appreciate, although at 6 weeks, these mice present a normal ileum, at 8 weeks, there's an increase or infiltration, submucosal infiltration, which is concomitant to their disease onset at 8 weeks. We've previously shown that these mice have a decrease in the frequency of gamma delta IELs as early as 5 weeks of age, which is far along before the 8 weeks time point where they develop this chronic like ileitis, Crohn's disease like ileitis. It's important for me to now introduce a bit of mouse biology. So here I'm going to just tell you that the gamma delta T cells can be differentiated in mouse by their gamma chain. And the gamma chain detects where the cells are going to home in the mouse. So while VGamma 7s are exclusively homing into the gut, VGamma 4s and VGamma 1s, for example, are predominantly present in circulation. However, this distribution is not a complete black and white situation. So although the majority of the gut epithelium is comprised of gamma 7s, there's still a proportion of cells that express the VGamma 1s and VGamma 4s. So we wanted to know whether this decrease in gamma delta T cell population that we observed in these mice was specific to one population or overall. And indeed, it's actually caused by the decrease in the frequency of VGamma 7s as early as 4 weeks of age. However, as you can appreciate here, we see an increase on this VGamma 1 population prior to disease onset in these mice. What are the differences between those two populations? So while VGamma 7 express higher amounts of CD8 alpha alpha at steady state as early as 6 weeks, and as a reminder, CD8 alpha alpha is a marker that distinguishes the effector from stem population. VGamma 1s retain 50-50 in their population, so 50% of their cells express this homodimer. At 8 weeks, however, this difference is lower. But gamma 1s retain a higher percentage of their population with a stem-like phenotype. And although it's a bit busy, as you can appreciate, these double negatives, so CD4, CD8 cell negative VGamma 1 T cells in homeostasis express higher frequency of markers associated with stem-like, while the CD8 alpha alpha have the higher expression of these markers associated with effector-like phenotype, and this was further enhanced at 8 weeks. And because these cells have had this increased frequency of stem-like precursors in the population, we wondered whether these VGamma 1s were constantly being replenished by the cells coming from the periphery. And indeed, when we looked at the TNF delta Ari mice, VGAM1s in MLN expressed higher frequency of CD113, and one molecule that is crucial for the migration from MLN and homing into the gut epithelium. And this was also found at 8 weeks, where despite all cells, wild type and delta Ari VGAM1s in MLN having stem-like phenotype, they upregulated Thank you. So these gamma-1s in the MLN from delta Ari mice had an increased expression of CD113, indicating that they're suggesting that they are homing into the epithelium at this point at disease onset. So when we characterized and looked at the VGAM1s in IEL compartment, and we wanted to see whether these cells still have a difference in their stem or effector-like phenotype in the delta Ari mice. Indeed, they VGAM1s at 6 weeks of age, so prior to disease onset, express higher frequencies of markers associated with stem-like, while in wild-type VGAM1s had already started expressing these effector-like markers. And this was further exacerbated at 8 weeks, where while wild-type VGAM1s upregulated markers associated with effector, the population of VGAM1s in delta Ari mice had literally or virtually no difference between the 8 weeks and retaining this higher expression of stem-like markers. With this, we wanted to know whether can we find these two populations in humans, and in order to do so, we isolated epithelial fraction from ileal biopsies of healthy and treatment-naive Crohn patients and performed single-cell TCR transcriptomic. And as you can appreciate, what is not showing? Great. So here, because I didn't see this before, we could identify 3 clusters, 2 clusters of effector-like phenotype and 1 cluster of stem-like phenotype. And when we subdivided these cells into whether the cells gamma delta came from Crohn's disease or healthy controls, Crohn's disease patient cells were enriched in the cluster that expressed these genes, which are associated with effector-like with stem-like phenotype, highlighting that these gamma delta IELs in Crohn's disease patients have a higher stem to effector ratio. Okay, this shows so preliminary data that we wanted to kind of corroborate this data and check whether this was true in other tissue and other samples. So we to validate this single cell sequencing data, we analyzed IELs coming from the active ileal Crohn's and compared them to the remission samples from patients in remission and healthy controls. And as you can appreciate, while gamma deltas IELs coming from active ileal Crohn's disease had a higher expression of markers associated with stem, patients in remission and healthy controls had higher expression of markers, so this is 39, associated with effector-like phenotype. And not only these also remission patients recovered had their CD8 alpha expression restored, highlighting the fact that, or suggesting that if effector-like gamma delta T cells phenotype can be restored in response to therapy. And this was further shown as well in paper from Adrian Hayday's lab, where they shown that in UC patients, the maintenance of remission was highly correlated with the increased frequency of gamma delta T cells expressing this this CD103 population. So this brings me to my conclusions, where I shown you that VGAM1 gamma delta T cells retain a substantial population of stem-like T cells at steady state, suggesting that T cells are continuously being replenished from cells from the periphery, and that these cells in the case of Crohn-like ileitis prior and during the onset of the disease, they fail to terminally differentiate. And in patients as well, this active ileal CD exhibits an increase of this stem to effector-like ratio in the gamma delta IL compartment. And it seems to be that this compartment can be restored to an immunoregulatory effector state in response to therapy. So we still don't know what are the signals, however, that drive this differentiation, and whether these ILs can be reprogrammed to effector-like phenotype. And with this, I would like to thank my lab, Karen, and all the members in the lab, and I want to highlight Ben, Irving, and Natasha that were determined to develop these projects, and also the Mount Sinai, our collaborators in Mount Sinai and Rutgers. And thank you for your attention.
Thanks, Joanna. Our next speaker is Salimi Suwali, changing directions to hematopoietic stem cells and progenitors in Crohn's disease.
Right. So good morning, everybody. Thank you for having me here. My name is Salima Suwali. I'm part of Louis Cohen's lab that I joined a couple of months ago. I'm very excited to be here to share the project that I'm currently working on, which is investigating gut hematopoietic stem cells in Crohn's disease. So I'm sure there's a lot already of very nice introductions, so I'll go really quickly. But as a background, I wanted to remind few important facts that today there is no cure for Crohn's disease, even though there is multiple targeted therapies or strategies that are being used and are effective. There's still no effective cure for this disease. Very little is also known about the etiology of the disease and how it starts and how it can evolve. It's very variable from patient to patient. And I think it is pretty well accepted now that there is a need for proposing new strategies and therapeutic. Current protocols use biologics or conventional drugs, sometimes combination of both. One of the I knew it would happen. Is that all? Okay. The caveat with these therapy methods is that not all the patients respond in the first intention of treatment, and the non-responder number increases within the next years, which then requires clinician to come up with combinatory strategies or propose new therapeutics. There's also the highlight that I wanted to do for this type of methods is the side effects and also the complexity of deciding for combinatory treatment strategies. One proposed therapeutic potential that has been emerging in the last years is the role and the use of hematopoietic stem cell transplant. There are now multiple studies that show that transplanting hematopoietic stem cells in patients, especially in refractory Crohn's disease patients that are not being able to be managed medically or at the surgical level, can help remove autoreactive immune cells and restore regulatory immune subsets in the gut. And also there is an emerging hypothesis that performing this type of transplant can help mucosal healing. And so just few numbers about this methodology is that after hematopoietic stem cell transplant, there is a very high level of remission at the clinical level, also at the endoscopic level. I here put only US data, and it's in between 60 to 80%. Unfortunately, these high level numbers do not sustain over the years. But what's interesting is that the method seems to be working, at least for a little bit, and understanding the mechanistic behind this therapeutic could be helpful for the patients. In our lab, Daniela actually carried and led this study that she published last year in Gut, where she showed this very positive impact of stem cell transplant in patients, which showed a very high level of remission after 6 months. I don't show all the data here because this is published, but one of the main and key findings that she has shown is that basically after transplant, there was an increase when she sequenced the immune cells from this transplanted patient and also looked at the profiling by site of, sorry, she was able to show that there was an increase in the myeloid CD14 positive cells, and that could contribute to mucosal healing because most of the targets that she had concomitantly expressed with this population increase were related to epithelial cell regeneration and stem cell function. I also wanted to highlight these two studies. Just one thing that I forgot to mention here is that one very important and kind of interesting fact is that also looking at these patients pre-transplant, in this case where those patients were refractory Crohn's disease patient, there were a high level of diversity, which also shows that the microenvironment and the context for each patient is very variable. And so therefore identifying key features that could help this patient have a better transplant or a better response to transplant is very key in this case. And so we would like to study gut hematopoietic stem cells in Crohn's disease patient. In this case, everything I'll present won't be in the refractory patient, just in Crohn's disease patient, inflamed and non-inflamed. And these two studies that I wanted to show report actually presence in healthy patients, a healthy donor of hematopoietic stem cells in the gut. On the left panel, this is a study from 2006 that reports presence of HACs in different layers of the gut tissue. In some cases, actually much higher than in peripheral blood, as well as in bone marrow. And then a more recent study carried out by Megan Sykes' lab at Columbia shows presence of this population in different layer of the gut, in the ileum, lamina propria, Peyer's patches, and mesenteric lymph nodes. So these cells are present there. The debate here is whether they are circulating or are there some of these populations that are resident in the gut, and that's also something we'll hopefully be able to answer with this project. Since this is going to be a very introductory presentation, I just wanted to highlight the goals and the experimental strategy that we are focusing on. Basically, number one would be to identify, isolate, profile these gut HACs in the context of healthy donors, Crohn's disease, inflamed and non-inflamed, and also assess their functional capabilities using different assays that I will present here. And so currently what I've been working on is optimizing the isolation of these this isolation from gut pinch biopsies. Here we have two outcomes. Basically, from these gut biopsies, I will isolate intestinal crypts and generate organoids to then expose them to different treatments, cytokines that are candidate from our HSCs, stem cells and progenitors, and immune cells in that case. And on the other side, I do dissociate those cells in order to really be able to profile them at the sequencing level, sort them, but also co-culture them with epithelial cells and see how they will sustain regeneration of the tissue or not. This is just a illustration of that. So basically, pinch biopsies and then the isolated crypts and stromal cells that we can either keep culturing and then submit to differentiation protocols. And this is just basically one type of experiment we will carry with the cells. Here I isolated intestinal from gut pinch biopsies, ileum and rectum, what I believe could be hematopoietic stem cells based on the markers CD34 and CD45 positivity. We have different level of expressions here. So I would like to basically try to functionally distinguish this population, whether they are more true stem cells or progenitors, and then hopefully reach out a point where we are able to culture these cells in a CFU assay to prove the clonogenicity of these hematopoietic stem cells and show that they are functional. Comparing healthy and Crohn's disease patients will really help understand whether they are defective in some inflammatory contexts. Another type of experiment where we have started to do here is to co-culture these differentiated hematopoietic stem cells that we isolate with organoids. And here, what I want you to just focus on is in just a few hours, we are able to completely shift the potential capability of the gut epithelium to generate organoids and therefore comprehend and understand how hematopoietic stem cells and progenitors are able to influence tissue regeneration in vitro. And just to conclude, really, this is the last slide. We are also evaluating the existence of these hematopoietic stem cells in situ by working in collaboration with the CHO lab and looking at pre and post transplant Crohn's disease patient, looking at the tissue and locating these cells. And basically what the goal is here is to identify molecular marker for these HSCs and progenitors, locate secretion, identify their target cells, and really better define their local microenvironment. And basically the next step will be to really understand better how this cell interaction and this dynamic functions between hematopoietic stem cells and gut tissue to propose new therapy. Thank you for your attention, and thank you for the Cohen Lab to have accepted me as a as a person in their team.
Thanks so much, Salima. And so the final speaker in this session will be Matthias Sulemans, talking about alpha V beta 6 autoantibodies.
Thank you for the kind introduction. Also, thank you to Dr. Colombel and Dr. Meandru for organizing this great meeting and for giving me the opportunity to present here today our work on alpha V beta 6 autoantibodies in colonic IBD. A bit of a background, the Meandru lab has previously shown that there is a profound B-cell dysregulation in ulcerative colitis. As you can see here on the left graph, there is a switch or a relative overproduction of IgG antibodies by plasma cells in the intestinal mucosa over more homeostatic IgA production. And this is also seen in switched memory B cells on the right-hand graph. In the same project, And the authors could isolate individual clones of plasma cells from the intestinal mucosa of healthy controls and inflamed UC patients. And it turned out that one of these clones was reacting to alpha V beta 6, demonstrating that there is an autoimmune reaction originating in the intestinal mucosa in UC. A bit more about alpha V beta 6. This is an epithelial-specific integrin that can be found in the intestinal lining, and it has a couple of homeostatic functions, including the activation of TGF-beta and interaction with the extracellular matrix. Now, a couple of years ago, there was this Japanese study, which you can see on the left, that was really the first to identify antibodies against this integrin alpha V beta 6. And we quickly could replicate these findings, showing higher levels of the autoantibody in the circulation of inflamed UC patients compared to controls. A bit later, Dr. Ali Levanos in our lab could also identify these autoantibodies in ulcerative colitis 10 years before the diagnosis was made, attributing important prognostic value to these antibodies. Ongoing research in our lab has compared the levels of these antibodies, not only in UC on the right versus controls on the left, but also to CD patients in the middle. And it turned out that although levels were generally lower than ulcerative colitis patients, that there is a proportion of patients with CD also displaying reactivity against alpha V beta 6. And when subgrouping these patients based on their disease location, we see that it's mostly the L2 or the colonic Crohn's disease group that has the highest reactivity to alpha V beta 6 to a lesser extent, but also more than ileal disease L1, the ileocolonic disease L3 has some reactivity as well. So that suggests that there is broad implication of anti-alpha V beta 6 autoantibodies in colonic IBD more than UC alone. So this led to the aim of our project, which is to investigate alpha V beta 6 antibody-related mucosal immune alterations in colonic IBD. And therefore, we prospectively included controls and patients to collect biopsies, which we processed in the lab to derive single-cell suspensions, which were analyzed by flow cytometry. On paired blood samples, we measured the alpha V beta 6 autoantibodies with an in-house developed ELISA to divide the cohort in antibody-positive and antibody-negative individuals. On the right, you can see a summary of the baseline characteristics of our 22 normal controls, 29 UC patients, and 32 Crohn's disease patients. And on the bottom line, I want to point your attention to the antibody positivity rate, which was about 55% in UC cohort and about 25% in CD cohort. So moving on to the results, first starting with neutrophils, which is a hallmark of the infiltration often seen in IBD-related inflammation. So total neutrophil counts were higher in the antibody-positive group in red versus controls in gray, but also versus antibody-negative colonic IBD patients in blue. Similarly, the proportion of activated neutrophils, defined by CD177 expression, was higher in the antibody-positive group compared to both control groups. And also the expression profile, defined by CXCR4 and CD10, which represents a more immature neutrophil phenotype, was distinct from the control groups in the antibody-positive group. Moving on to monocytes, we observed a similar difference, so high classical monocytes in the antibody-positive group compared to the control groups, as well as non-classical monocytes infiltrating in the tissue, which were higher in antibody-positive group, although you can see there is a little more variability in antibody-negative group here. And then the last myeloid population we looked at was conventional dendritic cells, which again showed the same trend, which was higher in alpha V beta 6 positive groups compared to the antibody-negative population. And also the inflammatory subset characterized by CD14 expression was highest in the antibody-positive group. So distinct myeloid dysregulation in this group. Okay, may I have your attention, please, back now. So moving on to the lymphoid compartment, we see pronounced T cell activation, which we studied by two measures, which is HLA-DR expression on the y-axis and CD38 expression on the x-axis. And you can see, especially for CD38 expression in the T helper cells, there is a profound T cell activation in antibody positive group. For cytotoxic CD8 positive T cells, this is true for both CD38 as a marker of activation as well as HLA-DR. Previously, there was an association shown between alpha V beta 6 autoantibodies and active disease. So we wanted to see if we could replicate this finding again. And indeed, you can see that the proportion of active disease is way higher on the left-hand side in antibody-positive individuals compared to antibody-negative individuals. And also when looking at the individual antibody titers, apologize for the blurry graphs here, also the individual antibody titers in active disease versus inactive disease. So therefore, we wanted to look specifically in this active disease group, whether some of the changes we previously found persisted. And starting with these myeloid alterations, we can indeed find the same trends or significant results for neutrophils and activated neutrophils, which were higher in antibody-positive individuals, with also a significant correlation between the cell infiltration and the antibody titers. Same goes for classical monocytes and inflammatory CDCs. So again, significantly higher in active antibody-positive group compared to active antibody-negative group, with a significant correlation for the inflammatory CDCs. And then basically the same goes for the lymphoid alterations. So also these persist in the active disease group, especially for activated cytotoxic T cells on the right-hand side, again with a difference between the groups and a correlation with the individual antibody titers. And lastly, we looked at the B cell compartment, where we again looked at the proportion of IgG producing cells versus IgA producing cells. And here, the numbers are a little lower, so we don't always reach statistical significance. But in the mature B cell compartment, you see visual or numerical trends for increased IgG over IgA ratios in the antibody-positive group, both in the whole cohort and in the active disease cohort. But you can also appreciate a significant correlation with individual antibody titers. And then a little more significance we get in the switch memory B cells for the IgG over IgA ratio. So in conclusion, we can say that alpha V beta 6 autoantibodies mark a distinct immunopathological subset of IBD with increased myeloid cell infiltration and activation, with activated T cell responses and an IgG skewed humoral immunity. These mechanistic insights show us how alpha V beta 6 directed reactivity may amplify the mucosal inflammation we see in these patients, and how this might underline adverse clinical outcomes. Ongoing work includes advanced characterization of this patient cohort with spectral flow cytometry, single-cell RNA sequencing, and various functional assays, all in all to gain insights in the origin and effector mechanisms of alpha V beta 6 autoreactivity. So with that, I'd like to thank you for your attention and everybody who collaborated to this project. Thank you.
So if all the speakers could come up and come to the microphone with your questions. Jean-Fred. if others could line up for their questions.
I have a question for Matthias. So all those abnormalities, did you find the same in patients with UC? Because you were looking at colonic Crohn's disease, but do you have the same data in UC patients? My second question is that because this antibody is basically one of the only preclinical markers that we found in UC, and it's there 10 years before. So what does that mean regarding the onset of the disease? And why people who are antibody positive, what is missing that they start their disease basically? Because they are antibody positive many years before.
Two excellent questions. And to your first point regarding the differences in UC and CD separately, of course, we lose some power if we only look at the different subgroups. From the first analysis, it looks like most of these changes are persisting both in the UC subgroup and in the CD subgroup. But the formal statistics I still have to do. But based on what we know from the antibody levels in UC versus CD, I suspect that the changes would be most pronounced in UC. Regarding the second point, that's a very good question, and I think that Dr. Ali Lovanos will give more comment on that in her presentation this afternoon. But I think that it can go both ways. I think the autoreactivity can target the intestinal barrier and predispose to alterations in that regard. But I think also direct immune changes over time, which start way before diagnosis and persist up to diagnosis, can sort of create a multi-hit approach or theory for the eventual disease onset.
Thank you, guys. Great talks all around. I had a question for Divya. You had mentioned that you see a decrease in the NK-like gamma delta T cells, but an increase in NK-mediated cytotoxic gamma delta T cells. And I wanted to ask what delineates those two populations and how are they different?
That's a very good question. So in NK-like, the protective NK-like gamma delta T cells, they have very high expression of NK receptors like NKG2C, 2E, and 2F. All three of these are activating NK receptors. And we also see a high expression of TYRO-BP, which is the adapter molecule that pairs with these activating receptors and carry out the baseline immunosurveillance and rapid antigen recognition in case they see any kind of viral infection or malformed or transformed cells. On the other hand, the cytotoxic NK-like T cells have other sorts of NK receptors like NKG7 and have very high expression of cytotoxicity-related molecules, like more of granzymes, different kinds of granzymes, granzyme M, granzyme K, and not just the baseline granzyme B levels, as well as other perforins and granulysin molecules also go.
Thank you. I actually also had another small question related a little bit. You said you see an increase in IL-17 producing gamma delta T cells. Where do you think they're coming from?
That's a very good question. So I do not know if there is like remodeling, like something changes within the baseline gamma delta T cells and they get changed into IL-17, or there are newly recruited IL-17 producing gamma delta T cells. But in our data set, we do not see IL-17 expressing gamma delta T cells in the healthy samples. And we see both the increase in IL-17 only expressing gamma delta T cells, as well as IL-17 and interferon expressing gamma delta T cells.
Great talks. I also have a question for Divya. So what's the proportion of those gamma delta 17 T cells in the whole gamma delta population in your samples?
That is a very minor population. So I would say it's just maybe 5% or 5 to 10%, I would say. Whereas the baseline gamma delta T cells, they are like the first gamma delta subtype that I described, NK-like GDT cells. Those are more than half of the gamma delta T cell population in health.
Yeah, because like in our experience, especially in mice, most of the gamma delta T cells, they are interferon gamma producing. So I'm wondering, like, maybe human, they are different.
Yeah. So as you might be aware, the proportions are different in human versus mice subsets. So yeah, that can account for that difference.
This question is for Catherine. As the expert in glial biology, how much do you think in the overall scheme of things? So what is the, let's say, antigen presenting function of glial cells? We traditionally don't think of them as APCs, but do you know of any data where it's enhanced maybe during inflammation? I mean, you're showing transcripts, but functionally, what is it?
Yeah, absolutely. That's a great question. So yeah, there's an increased expression of MHC2 under inflamed conditions, but a recent paper published last year showed in vitro and in mice that it was not functionally active. So I think there remains to be, studies studying that functionally in human and in human cultures. Yeah, that's an excellent question.
Thank you.
I'm the fire marshal, so we're allowed to go 5 minutes after. So a question for Salima. What's your thoughts about what you're losing with early cell isolation versus early fixation in terms of assessing cell abundance? Have you thought about that in terms of your study design?
You mean for the HSCs? I think that we're still exploring the data right now. We might not be losing so much, actually. The dissociation protocol that we're optimizing right now, we're getting really, really high viability. We're about 95% out of the sorter after dissociation. And so immediately we are able either to fix or to proceed to single cell protocol. So I think we're not losing a lot. And also the percentage of cells we are isolating and getting out is pretty similar from other studies that have been done. So I think altogether, we haven't performed the sequencing yet for those isolated hematopoietic stem cells, just from total dissociation. We are able to look at them, but I'm expecting that we're not hopefully losing too much.
Thank you.
I have one last question. It's actually for Salima. In your generation of your organoids from biopsy samples, I'm not sure if I missed this, but do you see differences in the morphology or in the growth pattern of organoids isolated from patients with and without disease?
Yeah, that's a great question. I do see differences. I would say that every type of organoid culture you do derive from human patient biopsies will have their own characteristics and features. Healthy patients' organoids usually grow faster, they expand better. There are also phenotypic differences that you see in Crohn's. So usually you have a little bias towards more secretory populations. They will still grow very well, but they will have more, they will be more prone to differentiate faster. So you have to keep that in mind when you actually design experiments.
And just adding on to that, so sorry. Do you see differences in the way that the co-culture then gets set up? Do the immune cells react differently to being introduced to that system?
Not so much. So the differences are still very subtle, and I think the model itself, at some point, you start to learn how this each patient biopsy behaves and how the organoids are going to grow. So ultimately, at very early stages, you are able to evaluate how much proportion of differentiation, spontaneous differentiation, you will get from one patient or not. So usually we are still pretty standardized, but we do keep an eye on this and we do monitor phenotypically things very carefully. So that's also why the optimization step and the characterization of each model is very important at the initial point.
Quick question, quick answer for Joanna. So one of the characteristic features of IBD is thickening of the muscularis mucosa. Is there any literature on that thickening causing a barrier for lymphocytes?
In the Delta area mice?
Yeah.
Yeah, it has been reported that this is exactly replicating that.
Terrific. Thanks so much for the speakers for a great session.
So let's move on with the fourth session of the day, which is a clinical one. And it's my great pleasure to introduce our first speaker, who is Jose Clemente, who will talk about the early life microbiome and inflammatory markers in infants born from IBD mothers, the meconium study.
Right. Thank you for the introduction, Jean-Fred. Saurabh, thank you for continuing to putting up a fantastic meeting over the years. I've been here for 13 years, and I think it was on the first or second one, maybe. So it's been that long. I need reading glasses now. That's how you tell. So I'm going to tell you very briefly about some work we've been doing on understanding the relation between early life microbiome and inflammation. And to do so, we're going to be leveraging a cohort that many of you are aware of and know very well, the meconium study that is studying infants born to mothers with IBD. And I think this is not new to most of you. We know that the microbiome is not a static thing. It changes over time, but it changes particularly during the first 3 years of life. So from the time you're born until you're 3 years of age, you essentially become adult-like. And why this changes so quickly? Well, because a lot of things happen in those first 3 years. If you're born by C-section or vaginally, you acquire different microbes to start life with. If you are breastfed, you're going to be promoting the growth of certain bacteria versus others. When you introduce solid food, who do you hang out with at the nursery? You get microbes not just from your family, but also from other kids that you play around with. So all of these things are shaping how our microbiome develops. And this is happening at the same time that our immune system is developing, right? So we're learning to recognize substances that maybe we've never been exposed to. So the hypothesis that all of us have is that maybe there is a very strong connection between these two things. Our immune system develops in conjunction with how our microbiome develops, and that modulates disease risk. For the most part, I think people think about how lifestyle factors impact microbial development. There's one factor that I think we often ignore, willingly or not, which is how genetics can shape what microbes we acquire and whether those microbes stay around for long or not, because this is potentially going to have an indirect effect on our risk of disease later on. And so a number of years ago, Inge Peter had the incredible vision to think, well, let's actually study this. And the way she thought about it is, can we identify how maternal IBD is going to shape early life microbial development and disease risk over time? And so she put together this incredible resource, the meconium cohort, that follows mothers from the time they're pregnant, the 3 trimesters, and then their infants for the first few years of life. And so we have families where the mother has IBD and controlled families where the mothers are healthy. There is over 10,000 samples collected already. I'm not going to show you 10,000 samples, just a small subset of that. We're going to look a little bit about at the microbiome of the mothers and the infants. So if you look at the microbiome of the mothers, what do you find? Well, you find what I think other groups have also shown before. You find that IBD status shapes dramatically what type of microbes you have. And so you have lower bacterial diversity, you have significant differences in composition, you see an increase in the number of bacteria that are, for the most part, pro-inflammatory, like you see a reduction of bacteria that produce short-chain fatty acids, like bacteria that produce anti-inflammatory compounds. So this is well known. What about the babies? So if you look at the babies from these mothers and the control families, what you see is that there's actually no significant differences. These are babies born to mothers with IBD, but the babies are otherwise healthy. And so in terms of bacterial diversity, you see the usual low amounts initially, a bloom after you introduce solid food, but no differences between infants born to mothers with IBD or healthy mothers. And this is in terms of diversity, and it's in terms of composition, so no major differences in overall diversity. But the mothers have different microbes, right? And so what we try to answer in this study is, whether there are differences in what is being transmitted from the mothers to the infants. And so what we're going to be looking at is how the rate of bacterial strains are transmitted in the IBD families and in the control families. And so if we ask this question of, are there differences in these two groups? The answer is actually no. So we see that over time, from the first samples we have at less than 2 weeks all the way to 5 years of age, there's a decrease in what things you're getting from the moms. So that rate decreases over time, but no significant differences whether your mom has IBD or not. So no overall differences. Okay, but you're not just getting microbes from your mom, you're getting microbes from other people, including your siblings. So maybe there are differences in what we get from the siblings, right? Is that the case? No, it is not. So you actually tend to get on average more strains from siblings than from the moms, but there's no significant differences between healthy controls and IBD families. So we're getting the same things. Do those things stick around for the same amount of time? Do those strains that we are acquiring persist for same or different amount of time? And so what we look at here is whether strains that appear early in life are repeated. We keep seeing them over time after on. And the answer here is different. The answer here is yes. We see that in infants who are born to mothers with IBD, the persistence of those strains is actually lower. So they remain, there's a higher amount of turnover. What's the reason for that? So one possibility is that there is something in the environment in which these strains remain that is different between the IBD families and the control families. And so Inga actually did all the hard work of collecting the samples and measuring one potential marker of how the environment differs, which is fecal calprotectin. So this is also a well-known trend. Infants initially start life with high levels of inflammation, high levels of fecal calprotectin that goes down over time. And for the first 3 months of life, there's no differences between control and IBD families. But after a year, you see that infants from the control families have notably lower levels of calprotectin compared to the IBD infants, to the infants born to mothers with IBD. And so we thought perhaps this is one of the differences that explains why the persistence of the strains depends on maternal IBD status. And so if you relate the amount of calprotectin, the calprotectin excess that we see in these infants against the rate of persistence of bacterial strains, you see that in the control families, there appears to be no relation. But in the IBD families, we see that there's a negative correlation. So the higher the calprotectin levels, the more likely it is that the strains do not remain around. There's a higher turnover in these bacterial strains. And with this, we can also ask questions about, well, which strains actually remain in IBD families, in IBD babies versus control babies. This is a relatively complex slide, so I'll just mention a couple of findings that we thought are interesting. In babies born to mothers with IBD, we see that strains that have been associated in adults with IBD, things like Bacteroides cacao, Immunococcus torques, we see that they persist for longer. So perhaps they're better adapted to this more inflammatory environment that we see in these babies compared to the control families. So to conclude very briefly, what have I shown you? Well, I've shown you what you already know. IBD shapes maternal microbiome. IBD does not necessarily shape the microbiome of the infant, but it shapes how the bacteria that they are acquiring in early life persist over time. And one potential hypothesis is that this is driven by a higher inflammatory environment that selects for different types of bacteria that in the future perhaps might increase the risk of inflammatory bowel disease. And so with that, I would like to thank first and foremost Inga, who has been the mastermind behind this, people in our labs, Adam and Tagyu, who have been working on the analysis, and all of you for your attention. Thank you.
And now I will invite Zoe Gottlieb, who will talk about the women with IBD and motherhood, the wisdom study. So the floor is yours.
Sorry, give me just one moment. It's not on this computer. All right. Oh. Okay. Hi, everybody. I'm Zoe Gottlieb. I'm one of the IBD attendings here at Sinai, and I'm going to spend the next 10 minutes or so talking to you about the Women with Inflammatory Bowel Disease and Motherhood study, also called WISDOM, which is the first ever prospective study looking at risk factors for reduced and infertility in women with IBD. These are my disclosures. Notably, this study is funded by the Helmsley Charitable Trust. So a little bit of background. As many of you know, IBD is increasingly prevalent. We have over 1 million women across North America who have diagnoses of IBD, and many of these women are diagnosed during their childbearing years. This leaves a lot of room for us to counsel them about fertility and pregnancy, but we have a huge gap in our knowledge of female fertility in this population. Nearly all of our data are derived from retrospective studies, either questionnaires or large database reviews that really don't capture many of the nuances associated with the disease course and complications related to this disease. And as a result, we really are not able to adequately counsel patients and help them to navigate these really important decisions regarding family planning. And remember that a lot of these decisions start way before they get to the age when they want to bear children. If women are either diagnosed at a young age and carry a lot of chronic inflammation or have surgeries that may affect their fertility based on what we do know from retrospective studies. So trying to understand a little bit the background of fertility and what we do know, we know that age is the #1 risk factor in all women for reduced fertility and infertility. That's completely true across our IBD patients as well. We also know that active disease significantly reduces fertility potential and increases time to pregnancy, and that women with IBD, particularly Crohn's disease, tend to have a lower ovarian reserve, meaning a lower quantity of eggs, particularly during times when their disease is active. The main data that we counsel women with is regarding J-pouch surgery, and that's really the pelvic dissection associated with the creation of the ileal pouch anal anastomosis. And we know that that surgery, both laparoscopic and open, particularly open, but also laparoscopic, significantly reduces fertility, and that's thought to be related to pelvic adhesions impacting the patency of the fallopian tubes. Additionally, outside of these biologic factors, there are psychosocial barriers to fertility in this population. About 17% of women with IBD are voluntarily childless, meaning they choose not to have children deliberately, versus 6% in the general population. And we actually know that when we educate women appropriately about the fears that they have about pregnancy, how their disease is going to impact the pregnancy course, inheritance of IBD, medication safety, that rate of voluntary childlessness goes down. So we have a lot of role as providers also in helping women to understand their pregnancy and fertility journeys. So what is WISDOM? We basically said there's no prospective data that is guiding these decisions. We need to understand a lot of details about the women who are trying to conceive and different risk factors in their IBD histories and how that shapes their fertility journey in order to adequately be able to counsel these patients and refer them in a timely way for fertility help. So women are enrolled in WISDOM if they are 15, I'm sorry, I keep saying 15 when I practice this too, 18 to 45 years old. Who are considering pregnancy in the next 15 months. And basically, those are the only criteria: IBD, 18 to 45, pregnancy in the next 15 months, and residence in the US and Canada at this point. And at the time of enrollment, they are asked to complete a very extensive baseline survey, asking them questions about their medical, reproductive, IBD, surgery, family histories, and partner histories as well. And we complete concurrently a questionnaire on our end with details from their medical record. And then they get a survey every month thereafter, whether or not they're trying to conceive, asking them specific details about their fertility journey as well as their IBD activity. And then they are followed up until week 12 of pregnancy so that we can better understand risk factors for early pregnancy loss in this population. Our early analyses, which I'll talk about in just a second, really look at time to pregnancy in this population because we haven't completed the study and haven't completed enrollment. So we can't say that women have infertility. What we can say is certain groups take longer to become pregnant than others, and how do we understand that? Ultimately, the goal is to understand risk factors for infertility as well as increased time to pregnancy in this population, particularly with respect to IBD surgery, all IBD surgery, not just J-pouch surgery, not just pelvic dissection. This is a collaborative effort where we've engaged over 45 partners across the United States and Canada to help us refer patients and get them involved. We want to have as diverse an IBD population as possible so that our results are as reflective of the true IBD population as possible. So not just groups at our main sites, which are Mount Sinai and University of Minnesota, but also really across the United States and Canada. So as of when I made this talk about a week ago, we had 578 women enrolled across these sites, 390 of whom were actively participating, meaning they were actively trying to become pregnant. Remember, you don't have to be trying at the time of enrollment. You have to want to try within 15 months. So that's people who were actively trying. 157 had become pregnant, and 113 of those had graduated, making it to 12 weeks of pregnancy. So the first data that I'm going to talk about are our data regarding surgery. So these are data we presented at DDW in 2025 and again in 2026 with updated numbers. We looked at whether women who had a history of any IBD surgery, as well as specifically pelvic surgery, had increased time to pregnancy compared to those without. And after adjusting for particular confounders that we know affect fertility, such as age, active disease within 3 months of becoming pregnant, as well as parity of greater than or equal to 1, because women who have gotten pregnant before are more likely to get pregnant again. We found that a history of any surgery, that includes both pelvic and non-pelvic surgeries, significantly increased time to pregnancy. What does that mean? It means that any woman who's had an IBD surgery, and perhaps the non-pelvic surgeries reflect a longer history of active inflammation or a more complex disease course. Those are details we need to better understand as this registry grows over time. But we know that any surgical history is going to significantly impact time to pregnancy. So we need to counsel women early on that. We also looked at patient-reported outcomes. We presented this year as well, looking at both IBD-related sexual function as well as promised physical and mental health and how that affected both time to pregnancy and ability to become pregnant. And what we found was that better sexual function and better promise scores, meaning patients were overall having better, obviously, sexual health and also were healthier and better mental health, those patients were significantly more likely to become pregnant. Pregnancy and the ability to become pregnant is not just about the physical barriers that we think of so often and the disease pathogenesis. It's about a lot of the mental health and physical health components as well that go into the overall picture. And we need to focus on those just like we focus on the biological components of trying to become pregnant. Lastly, we've looked at advanced therapy exposure. A lot of patients, particularly who don't receive care at large IBD centers where they get a ton of IBD pregnancy education, as well as providers in the community who are less familiar with IBD and pregnancy, very much worry about patients taking biologics and small molecules prior to becoming pregnant and during pregnancy. We have a lot of data from Piano, which for those of you who don't know is a very large prospective cohort looking at pregnancy and medication exposure. But what we don't know is how those medications affect fertility. We always tell patients that they don't, but do we have any data to that effect? Now we do. We looked at patients who were exposed to advanced therapy within 3 months of becoming pregnant, and we found that there was no significant increased time to pregnancy in those patients versus those who were not exposed to advanced therapy. So again, we know active disease is a big risk factor for reduced fertility as well as adverse pregnancy outcomes. Here's more data to support. Please continue your medications throughout your pregnancy journey. That includes the pre-pregnancy component. So how do we put this together? We know that now there are some groups that are higher risk, patients who have had a history of surgery. Those are patients who shouldn't necessarily be waiting the advised 12 months of timed unprotected intercourse to be referred for fertility help. We know that patients who have poor sexual health or poor overall health and mental health at baseline are more likely to have trouble conceiving. And so we really need to work on those pieces, engaging mental health practitioners, as well as pelvic floor PT, perhaps Urogyne. And last, we know that we can counsel patients that their therapies are safe and that they really need to prioritize deep remission through continuing therapy rather than interrupting their therapy for the sake of becoming pregnant or having a healthy pregnancy, which we know is really not the safe way to become pregnant. Ultimately, the goal here is to translate all of our findings into a risk calculator. So a patient can come up to us and say, you know, I'm trying to become pregnant. We can look at the different factors of their history and we can put together their overall risk for having difficulty becoming pregnant or even having infertility. And we can refer them immediately to a reproductive endocrinologist instead of having them wait and try fruitlessly for months, which has an enormous emotional and mental burden on our patients and also, you know, increases their risk of reduced fertility going forward because they're getting older as they go. Right now, we're also looking, our sort of next steps, we're analyzing the success of utilization of IVF and IUI in this population. And we're also going to look at risk factors for early pregnancy loss. And I'm just going a little quick because I want to stay within my time. So overall, what did I tell you? Please refer your patients is the biggest thing. We need to have more information. I always tell my patients, I know that surveys are kind of challenging and it's annoying to repeat things month after month, but this is how I'm going to counsel the you who comes to me in 2 years and says that they want to get pregnant. And I know that you would really benefit from that information. And almost all of our patients are really excited to help because they just want to help basically enhance the way that we can take care of patients like them. This is the QR code if you want to take a picture. You can also go directly to our study website, which is www.wisdomibdstudy.com. Patients can enroll directly there and complete an e-consent. So they don't have to even talk to anybody. They can just do a variety of clicks and they're enrolled in the study. Also, please feel free to reach out to us directly at wisdom@mssm.edu. Thank you.
Thank you for the great talk. And now I'd like to introduce Akshita Gupta, who will talk about 3D MRI modeling improves patient understanding and decision-making in perineal fistulizing Crohn's disease, a prospective pilot study.
Good afternoon, everyone, and thank you for being here today. I'm Akshita Gupta. I'm one of the graduating fellows here at Mount Sinai. And today I'll be talking about the role of 3D MRI modeling in perineal fistulizing Crohn's disease. I have no disclosures. So as we know, perineal Crohn's disease is a severe phenotype of Crohn's disease that's characterized by fistulizing lesions with or without abscesses. It is estimated that approximately 1 in 5 patients with Crohn's disease will develop perianal disease within the first 10 years of diagnosis. Out of these patients, approximately 2/3 of them will go on to need some form of perianal surgery, with a smaller fraction even requiring major abdominal surgery. Perianal fistulas add to the burden of disease and lead to poor outcomes. There have been long-term studies which have shown that these patients have impaired quality of life due to multiple hospitalizations, the burden of symptoms, recurrent surgeries, and so on. In addition to the burden of this disease clinically, what else is challenging is that perianal fistulizing Crohn's disease has a highly complex 3-dimensional anatomy with fistula tracts, branches, abscesses, internal openings, etc. While the gold standard for diagnosing and preoperative planning for these conditions is a 2-dimensional MRI. This leads to a lot of challenges for the patients as well as for the providers to fully comprehend the disease severity and its extent. What's the result? This leads to the patients not being able to fully visualize or understand their disease and symptoms. They are not really able to link how the symptoms correlate to the anatomy of the fistulas, and they lack confidence in discussing their condition with either their doctors or their friends and family. Ultimately, all this leads to an impaired shared decision-making and surgical planning. One potential solution that has emerged is a novel tool from Motiland called Virtual Exam Under Anesthesia, or VEUA. This is a tool that generates an interactive 3-dimensional reconstruction from the standard pelvic MRI for a patient. It therefore offers a clearer representation of the fistula tracts, the sphincters, abscesses, internal openings, etc. It also gives us a volumetric measurement of the fistulas and the abscesses and gives us its spatial orientation with respect to the pelvic structures. So in theory, it seems like this model could be helpful in improving patient understanding, in improving communication with the patients, as well as in explaining the treatment options to the patients. Therefore, we undertook this pilot study to evaluate whether a 3D MRI modeling would be helpful in improving patient understanding of their perianal fistulizing Crohn's disease and if it influences surgical decision-making. So we implemented this pilot study at our perianal clinic with Dr. Sinyu Wang and Dr. Sergey Kaitov. When a patient undergoes a pelvic MRI and they are potentially planned for an exam under anesthesia, we would use this MRI and have our radiologists generate a 3D model using the VEUA software. We developed questionnaires for the patients with a pre-model and a post-model review questionnaire to understand how well they are able to understand their perianal disease. We also developed a questionnaire for the surgeon to assess the model accuracy and if it was helpful from a surgical planning perspective. We converted their responses into Likert scale scores from 1 to 5 for the purpose of analysis. So before I go on to the results, I just want to show you a few videos of what this model looks like, what are its features, and how it can be used. So you can see that it is a completely interactive model that you can rotate 360 degrees. You can remove each of the individual components, and you can add back the components as well. So the way I explained it to patients was completely removing everything and then slowly showing them what the internal sphincter looks like, what the external sphincter looks like, what these levator muscles are, and then how a fistula correlates to these structures. Over here, this patient has 2 simple fistulas, and then you rotate it, and you can see at the bottom right corner, the small box also gives you a spatial orientation as to what's anterior, what's posterior, right, left, top and bottom, and so on. Another feature of this model is that you can correlate the planes to the 2D MRI on the left-hand side. So as you scroll down, you can see the plane that's cutting across the 3D model is correlating to the MRI. And you can see the red and green fistulas that have been marked out by the radiologist on that MRI. Finally, one thing I want to show is if you look at the bottom right again, there's a volume column that shows there that basically tells you the volume of the fistulas individually, and you can click on each fistula and see the individual measurements as well. So similarly, this is another model for a patient, which is showing a complex branching fistula as well as an abscess. Same features over here, completely interactive. You can see that it looks very different. So if a patient looks at this versus the previous model, they'll be able to see that this is a much more complex fistula, has a lot of branches. The one thing that this model right now doesn't let us do is it doesn't let us label something as an abscess. You still have to label it as a fistula. That's why the red blob you see there was labeled as a fistula instead of an abscess. But again, you can see how the abscess is correlating in terms of orientation to the fistula as well. And then the volume button I was talking about, if you click on it, it'll give you specific measurements for the fistulas. And then finally, one other feature which was very helpful is the supralevator extension that you can visualize very clearly on this model. So this model here shows 2 extrasphincteric fistulas with a branch extending towards the sphincters. And then once you rotate it towards the top, you can clearly see that the fistulas are extending beyond the levator muscles. And this has especially been helpful from a surgical perspective. So moving on to our results, since this was a pilot, right now we have only enrolled 5 patients so far and active enrollment is going on. But in talking to these patients, they had positive responses about the model. So the patients found a 27% increase in their understanding of their perianal disease, with the mean understanding score going up from 3.4 to 4.3 out of 5. There was also a 31% increase in their understanding of how the symptoms correlate to the anatomy of the fistula. And there was a 50% increase in their confidence in communicating about their condition with their doctors as well as friends and family. Similarly, 100% of the patients actually found it to be moderately to extremely helpful, and all of them reported that they would recommend this model to other patients. 3 out of the 5 patients that I interviewed had never actually seen any form of 2-dimensional or 3-dimensional image of their fistula, not like a drawing or a photograph or an MRI. And in terms of qualitative feedback, they felt that the 3D model improved the spatial clarity as well as enhanced visualization compared to a regular 2-dimensional MRI. In terms of our surgical outcomes, the surgeon rated this 3D model as mostly to completely accurate in 80% of the cases. In 2 of the cases, the model also revealed an unexpected branch or extension, as well as improved precise tract localization. And in 1 case, it did prompt a contralateral surgical intervention when the surgeon reviewed the model prior to the exam under anesthesia.
So overall, the most useful element from a surgical perspective was an improved visualization of the upward extension and levator plate penetration, while the depiction of cetons remained suboptimal and was the major limitation from a surgical perspective. Overall, the surgeon did feel that the model improved the patient understanding, and they expressed some interest in adopting it for perianal fistulizing Crohn's disease in their clinic. So to conclude, we found that 3D MRI modeling leads to an improvement in patient disease understanding and their confidence in communication. All the patients did find the model to be helpful and recommended it, and these models were accurate and enhanced the delineation of preoperative fistula anatomy. So we find that 3D imaging could in fact improve the shared decision-making and support their potential integration into patient education. Since this was just pilot data from 5 patients right now, and we are still enrolling, the main goal of my talk here was to introduce you all to these 3D models, and further large-scale studies are going to be needed to understand their true utility. And in terms of the future, there could be further studies that would explain its role in terms of monitoring the disease progression, as well as understanding how we can monitor the impact of treatment with these models. Thank you for your time and attention.
So we'll remain in the field of fistulizing Crohn's disease with Isha Butada. We'll talk about characterizing clinical features and disease course of patients with simple and complex fistulae in perianal fistulizing Crohn's disease.
All right, so hi everyone. My name is Isha Butada. I'm one of the internal medicine residents here at Mount Sinai, and today I'll be presenting a project that I'm working on with Dr. Sinyu Wang that is characterizing the disease course of patients with simple fistulae and perianal fistulizing Crohn's disease. So like Akshita mentioned, approximately 20% of patients with Crohn's disease develop perianal fistulae within the first 10 years of diagnosis. While fistulae can develop in any location in the GI tract, the most common location is perianal, and the presence of perianal fistulae in Crohn's tends to denote an aggressive phenotype. When perianal disease is the first manifestation of Crohn's disease, severe disease is likely, and there may be rapid progression from inflammatory manifestations to stricturing or penetrating complications. The age at onset of Crohn's influences the development of perianal disease, with younger patients at the greatest risk. And despite improvements in medical and surgical management, perianal fistulizing Crohn's disease remains notoriously difficult to treat. The refractory nature of the disease calls for significant improvements in our understanding of its disease course to help guide our management. So perianal fistulae have been traditionally categorized anatomically as simple or complex, as defined by the AGA. A simple fistula is superficial, intersphincteric, or low transsphincteric with only one opening, and it's neither associated with an abscess nor connected to an adjacent structure. It's never associated with an anorectal stricture or rectovaginal fistula. On the other hand, a complex fistula sits higher. It could be high intersphincteric or high transsphincteric. It could be extrasphincteric or suprasphincteric, and it may have multiple external openings or be associated with a perianal abscess, rectovaginal fistula, or anorectal stricture. One of the reasons that the classification of simple and complex fistulae is interesting is because it does affect clinical practice and management. This is based off of guidance shared by Crohn's and Colitis Canada in a review article in Nature, and it shows that accurately classifying a perianal fistula is the first step in managing these patients, with approach to treatment further differing based on symptomatology, presentation, and initial treatment response. A newer classification for perianal fistulae is the top class classification, which categorizes perianal disease into 4 main groups based on symptomatology and the immediate goal of therapy, which is ultimately designed to guide clinical decision-making. And class 1 describes asymptomatic or mild disease, in which the goal is just to optimize Crohn's therapy. Class 2 describes chronic or symptomatic fistulae and is subcategorized by increasing severity based on whether the goal is definitive repair or long-term symptom management. Class 3 describes severe disease with an exhausted perineum, complex active disease, or failure to respond to medical therapies. And at this stage, the focus shifts towards surgical symptom control in the form of a proctectomy. And then class 4 describes post-proctectomy perineal sinuses or wounds, the management of which includes debridement and optimization of IBD therapy. What we don't know is if anatomy matters here. Much of the literature so far outside of this classification has focused on complex fistulae, and studies have shown that the majority of patients with complex fistulae have chronic symptomatic disease, suggesting possible stage 2 or beyond. But what we don't know is what simple fistulae look like over time. Do they remain as class 1 and class 2A, or do they progress to advanced disease when we're considering symptoms and treatment goals? And that kind of brings us to our study. Because current management standards are different for simple and complex fistulae, we're curious about, 1, the true proportion of patients with perianal fistulizing Crohn's that present with simple fistulae, and then 2, if there's a difference in the disease courses of simple and complex fistulae, especially as the disease course of simple fistulae remains incompletely defined. So we conducted a single center retrospective study at Mount Sinai, where we looked at 190 Crohn's patients who were diagnosed with the perianal fistula between 2005 and 2025. 90 of these patients had an index MRI within 1 year of perianal fistula diagnosis, and this was used to classify their fistula as complex or simple as per the AGA criteria. We then collected demographics and clinical data by retrospective chart review, and then we used univariate models for analysis to compare the patients with simple and complex fistulae. The first thing we looked at was the demographics of these patients. And interestingly, 43% of these patients had simple fistulae, which is a larger proportion than has been previously estimated in literature. Current studies show a high proportion of complex fistulae in Crohn's, maybe about 70%, which has been previously thought to reflect the transmural inflammatory nature of the disease. We didn't see any significant difference in the age at Crohn's diagnosis, the age at perianal fistula diagnosis, tobacco use status, sex, or ethnicity between simple and complex fistula patients. The next thing we looked at was tract anatomy and Montreal classification with patients with simple fistulae. And what we saw was that tract anatomy differed significantly between simple and complex fistulae, which makes sense given that the anatomy influences the definition of these classifications. And then another interesting finding was that penetrating or B3 disease behavior at Crohn's diagnosis was associated with the development of complex fistulae, although this will require further validation with a larger sample size. And then there was no difference between disease location at Crohn's diagnosis and the development of simple versus complex fistulae. What we also found was that patients with complex fistulae were more likely to undergo an exam under anesthesia, but there was no statistically significant difference in the number of ED visits or fecal diversions or proctectomies that they underwent. And then similar percentages were initiated on a anti-TNF therapy prior to identification of fistula, but a larger percentage of patients with complex fistulae underwent a switch from an anti-TNF therapy to a biologic during their disease course, although this was not statistically significant. We also tried to look at healing to see if there was a difference in time to remission between the two groups. And remission was defined clinically as 1, not having no abscess, 2, having no drainage. And if a ceton was present, then minimal spotting was accepted as remission. And then 3, no exudate on gentle finger palpation. And while it appeared that patients with simple fistulae were more likely to achieve remission at 10 years than patients with complex, that difference was actually not statistically significant. So what we saw with the study was that, well, the study characterized a PFCT cohort that had a very large proportion of anatomically simple fistulae. And if simple fistulae are truly such a large percentage of fistulae in Crohn's disease, then they're severely undercategorized or undercharacterized. And we kind of need to better understand their natural history. Simple fistulae were associated with fewer exams under anesthesia than complex fistulae, but what we saw was that there was no significant difference in remission in probability at 10 years after diagnosis of the fistula, which kind of begs the question, should we be treating simple and complex fistulae similarly from the onset? Some limitations of the study are right now, its sample size, and then it is retrospective and all done at a single center. And right now we haven't mapped disease course to any validated staging models, but that leaves a lot of room for growth. And we're currently doing completing a multi-center review with WashU and the University of Ottawa that'll have over 1,000 patients. And we hope to map disease classification or disease severity with the top class classification and utilize a standard composite metric to measure complications. Thank you.
Unfortunately, we'll have to shorten the discussion, but we'll do take some questions, very short. So I invite the speakers.
I have one question for Jose. Very interesting data, but originally I was thinking the other way around, meaning that the change in the microbiome is driving the calprotectin instead of calprotectin driving the microbiome. No, don't you think it makes more sense?
Yeah, so we've actually, I didn't show the data, but we've actually got it both ways. Is it calprotectin selecting for certain strains persisting, or is it the persistence of certain strains resulting in higher levels of inflammation? So it's kind of like an egg and chicken problem, but we can, at this moment we can't tell which direction is it, but it's a good point, yeah.
I also have a question for Akshita. This was very interesting, this 3D modeling. So you really well showed that it improved patient understanding, but does that improve physician understanding and the surgeon understanding? And could that be embarked during surgery, for example?
Thank you for the question. Yeah, so we basically focused this study on the patient perspective in terms of the understanding. From a surgical perspective, the main thing we were looking for is when the surgeon reviews the model before the patient is undergoing an exam under anesthesia, if it's changing their decision or if it's changing anything they're doing surgically. And within the small sample size that we have so far, it did actually show a few perspectives that were important, specifically, like I mentioned, the extension beyond the levator muscles, which our surgeon pointed out was very, very helpful, and that they were usually not able to see from the two-dimensional MRIs. So I think going forward, especially at centers which are not big IBD centers, I think this could be more helpful, could also bridge a communication gap between the radiologist and the surgeon as well as the IBD providers.
I have one question for Isha. Did you look at the endoscopic activity comparing simple and complex, especially the inflammation in the rectum? Because I believe this is a driver of maybe more complex disease.
Yeah, that's a great question. And thank you for the question. Right now, we haven't looked at endoscopic findings yet, but that's hopefully next steps.
Okay, great. So it's miraculous, we're on time. Okay, so we'll have a lunch from 12:50 to 1:30. So please come back at 1:30 time so that we'll restart with Rafa. Thank you so much. Thank you so much. Okay, so we will restart the afternoon just on time. And it's my great pleasure to introduce Rafa. Rafa is an assistant professor at the Immunology Center in Georgia, in Augusta, which is not only known for golf, but also for science. And Rafa is from Brazil, actually. So good luck for the next World Cup, as we discussed yesterday. And he's actually from Sinai because he was working in Sergio Lira lab. When was that, Rafa, again?
2013.
2013. And then he developed this passion for mucosal immunology. Then he went to one of our good friends as well, to Gwen Randolph lab in WashU, where he began studying IBD. He received an IBD Innovation Research Fellowship, and later he earned the prestigious Crohn's and Colitis Foundation Career Development Award, just to start his independent research. And Rafa will be talking today about something which is very close to our interest and our heart, I will say, which is lymphatics shaping gut immunity. Please, Rafa, thank you again for coming.
Thank you so much, Fred. So today is a very wholesome moment for me. So it's very special for me to be back here at Mount Sinai. And I'll be introducing and talking to you about this passion that I developed from going from mucosal immunology to vascular biology, studying the role of lymphatic vessels in chronic inflammation of the intestine. So I have just one disclosure that we developed some reagents for tissue clearing imaging that you see in my talk. So this is a picture from the view from the 12th floor of this building in 2013. And this was the last time I gave a talk here at Mount Sinai, when I was finishing one part of a project at Dr. Sergio Leo's lab. So I want to thank them for giving me the opportunity that allowed my career to grow so much. So I have a lot of great memories and things that I took over my career that came from here. So one was mucosal immunology, and the other one is appreciation for imaging. So if you know Sergio, you know that he loves pictures and imaging. So I learned a lot from him in that sense, and that took kind of over my career. I became a microscopist, and that launched my career, going from static images to live images. So I want to just highlight to you that trying to control mucosal barrier immune responses is very complicated, but is essential for our homeostasis. So in every barrier, but especially in the intestine, you have a conjunction of epithelium, innate and adaptive immunity that needs to happen. And you have those cells that would sense foreigner antigens and bacteria, for example, and you need some cells to go from the site of a potential infection all the way to the central nervous system of the immune system, the lymph node, to generate a proper adaptive immune response, and then to come back using the vascular circulation to return to the tissue, right? So all those cells, all those steps are very important. But the thing that glues them all together is this vessel bed called the lymphatic system. So you have them whenever you get an antigen. In order to reach that lymph node, you need to take this highway, this active changing highway that would lead you to the lymph node. And then and that lymph node will allow the cells to go back to circulation based on that biology. So I see the lymphatic system as a watershed. It's like a structure, anatomy that our body has, but it has some controls. It has some biology that can prevent and improve the drainage and movement of those cells. So we know for a very long time that the lymphatics are altered in Crohn's disease. So very early descriptions of the disease already were mentioned about this lymphectasia, this highly inflamed and swollen lymphatics. They were calling it as a lymphangitis of the gut wall in the beginning. And Dr. Colombell and colleagues tried to bring back that idea for a long time, trying to highlight that there is this granuloma-like structure associated to the lymphatics. And they highlighted, and these are just earlier work, that there is an expansion of the lymphatic network in the regions of chronic inflammation and also associated that. So inspired on that
my mentor, Grant Randolph at Washington University, she did her first studies outside cardiovascular disease to looking at mesenteric fat, and they found these tertiary lymphoid organs that were associated to the lymphatic vasculature, and they were particularly positioned to these large lymphatic vessels that are connecting the intestine to the draining lymph node. So I was basically hired as the first postdoctoral fellow to not work in cardiovascular disease in her laboratory, but to work in IBD. And our hypothesis at that time is that if you had this de novo form lymphoid structure, that will prevent the normal homeostatic function of lymphatics, so leukocyte trafficking, molecular transit, and potentially immune tolerance could be impacted. So, and at that time, the lab obtained the TNF delta E model that Edelman lab mentioned. I had the opportunity to see those mice, not directly working on them, but see those mice when I was in Dr. Lear's lab. And this is, again, a model that overproduces TNF cytokine. It developed this spontaneous ileitis. And it's a beautiful model because it possesses this transmural infiltration. And we obtained this model from the Cleveland DDRCC from Fabio Cominelli and Teresa Pissarro. So what I did is that to try to ask the relevance of this tertiary lymphoid organs and lymphatics in this model, animal model, we crossed this mouse to a lymphatic reporter. So in this mouse, all the lymphatic endothelial cells are express fluorescent green protein. And when you look at their mesenteries on the left, you see a normal control mouse. And in the region of the ileum that is draining the ileum, you form these large lymphoid organs. Those are B-cell rich. You have lymphoangiogenesis. And to get the story short, we discovered that the chronic inflammation basically changes and remodel the endothelium exactly where there is this lymphatic valve forming. And so, and these V-shaped white conjunctions there are leaflets of the vessel that can control how much is draining from the tissue. And the chronic inflammation, the exposure to TNF, basically induces that vessel that is usually never proliferates and is actually very hard to induce proliferation to start generating new vessels. And those end up forming this large structure. And what we did further is that we decided to test the functionality of the lymphatics in this condition. So when you have I developed a way to have a functional view of the lymphatics. So we injected less than 1 microliter of a tracer dye in the Peyer's patch of the mouse. And then you can visualize the dye just going from in this case, ileum, all the way to the drain lymph node. So this is this is on a control scenario, not the Crohn's like mouse. So in the control scenario, we can visualize and you can see the drainage and it slowly flows all the way to the drain lymph node. However, in the IBD condition where you have these structures that are formed due to the chronic inflammation and remodel of the lymphatics, you have the formation of these structures forming kind of like a cuff. And in this case, instead of going to the MLN on the left, it goes backwards. So it creates this infinity loop where you don't really see drainage of some material that is in the intestine going to the lymph node. And then what I don't have much time to show you today is that we saw that migration of immune cells is impaired, especially dendritic cells, and especially the ones that are inducing tolerogenic responses. So from that study, we learned that like homeostasis of the intestine requires the lymphatic vasculature to go all the way to the drain lymph node and to expand towards the systemic circulation. However, during chronic inflammation, there is a remodeling and a stimulation of the chemokine milieu that promotes the dedifferentiation and proliferation of this endothelium that forms this tertiary lymphoid organs. And then you either get backflow or you get spillage of this bacterial-rich cargo coming from the intestine. They should be usually filtered by the lymph node, but they aren't. And the prevention of these APCs of continually promoting and releasing food dye antigens or bacterial-derived antigens to the lymph node prevents the generation of tolerogenic responses. And we end up having a mechanistic work in this paper as well, where we show that TNF itself acts on this lymphatic endothelium. And when that happens, the key transcription factor that is necessary for that valve to exist in the first place and withstand the pressure that it senses all the time is downregulated, and the genes that are important for the valve are lost, and that's why that valve start proliferating. So that was our earlier work. So, but having that thought that the milieu and the inflammation, the cytokines can directly impact the vascular endothelium, we started to think about how and what's going on in UC instead of Crohn's disease, to see if there's any similarity or comparison that we can draw, or why it isn't. So when we start looking at what is there in the literature, we know that in the small intestine, you have villi, and each villi has a specialized lymphatic vessel called the lacteal that help us absorb especially lipids in the duodenum, and potentially with new data absorbing also secondary bile acids in the terminal ileum. But in the large intestine, we couldn't find a lot of data showing what was the role of the lymphatic vasculature beyond the normal drainage patterns. So there was a beautiful work recently published from a few groups, also here from New York, that show that maybe the lymphatics in the colon, they could be releasing molecules that are necessary for the stemness of the epithelium. And those are very interesting concepts that the endothelium could be releasing molecules that will be interacting with other cells around, instead of being just a pipe that is leading and moving things out of the interstitium. So, but we wanted to see, like, if the cells are just releasing factors to the environment, then they might not be doing their job at drainage, that they're doing all the tissue. So we decided to study that. So when we look at the mouse colon, this is a representative picture of a mouse colon, you see that there is this V-shaped formations over there, and you can see that those are, when you see in cross-section in histology, those are invaginations of the epithelium wall. And those are also present they are large in the proximal and they're shorter in the distal, but they're present throughout. We see that in humans, you also have these invaginations, and we couldn't find a specific name for it. In humans, it's plica semilunaris, but in the mouse, it doesn't have a name, so I'm calling them colon folds. So we decided to see if that structure could also have any association with the drainage pattern. What I did in the past, and something that we developed, we use different chemistry to try not to bend the light and make things transparent, so we can use just normal confocal and visualize tissues in 3D. So these are some of the image that you saw here in the left is a lymphatic reporter in green and blood vessels in red, and this is kind of the middle of that cross-section tube, and you have one of those colon folds, those invaginations, and you can see that you have a lot of lymphatics on them. And there are two layers of lymphatics, one that is in the muscle layers on the bottom, and one that is in the subepithelium. But in these folds, they kind of like congregate, they create that sandwich, that space. And that space also have some protrusions that are found only there and not on the other parts. And if you look at the larger area, you can see that there's like lymphoid aggregates that are forming around these folds. And you see where those folds happen, you have an enhanced and more concentration of these lymphatic vessels. These are still images, and those have valves and everything. So we decided to use the same approach of visualizing the lymphatic vessels using a specific tracer to see what will happen in the large intestine, in the colon of the mouse. So usually the pattern that happened in the small intestine is like that. You get a grid pattern that forms. When we injected in the large intestine, we got these like diagonal lines that are going to show up here. And we got this perivascular vasculature when we did this injection. And those diagonal lines actually pair perfectly with those column folds. So you have accumulation of the dye that was injected exactly underneath those structures. So it seems that the anatomy of the colon of the mouse is done in a way that you don't have a lot of lymphatics everywhere. They're congregating on that, and the tissue basically puts everything towards that bottom in order for them to come out. Of course, because I'm basically putting a needle through a very thin layer, someone might say that that might not be physiological, and this is just an artifact of pressure or anything. So in the Randolph lab, they develop a system where to try to track lipid particles. So Dr. Randolph used to work with atherosclerosis and trying to see HDL going around tissues. So they developed this system where you can basically label HDL particle with a photoconvertible protein. And so then you provide with a viral vector. So if you do that in the mouse and you transduce the liver of the mouse, the liver starts producing this fluorescently green HDL particles. And then you can use light to convert the green to red, and the green starts being green and start being red. So you actually have two signals. And if that's what happens with the liver of the mouse, the liver is green, and then if you shine a light on it, it becomes red. So that's a way that we can visualize this HDL, these lipid particles that are going everywhere. And what we realize is that they actually go to all tissues. So you can use that as another molecule that is just inside the tissue, and you can see it coming out. So in order to do that in the intestine, we develop a special probe that we could use to deliver very controlled intensity of light along a cylindrical rod. So I call this a mini lightsaber because it really looks like one. So when you turn on the laser, it becomes this rod. So we can introduce this rod in the mouse. This is when we open the mouse, just show you, but we can also just do with the mouse without any surgery. And then you can define the region that you want to convert, and then you can study that. So this is on a mouse that express the same protein, but in all of its cells. So it's a KIKGR mouse. And that's the whole intestine of the mouse where we put that probe there. We could just convert just a section of the colon in this case, and you have like it was green and we're not red, and it starts being green, becomes red. So we can have a spatially controlled labeling of those particles, and we can check where did they go. So what we did is that we transduced the mouse with this fluorescently green expressing HDL particle virus. So everything that you see here in green is this HDL just flowing everywhere. And then this is before conversion, this is a zoom in. So when you use that light, you basically convert only that part of the intestine. And then this is kind of hard to see, probably easier to see over that, but you can see the red signal coming from only the region going all the way to the lymph node again. So you can visualize in vivo in real time without any injection, the drainage, but you can also maybe appreciate that the signal in red starts collecting and forming those same diagonal patterns. So it seems that even without the perturbation of the injection, in the colon, you have this reservoir where all the particles converge into a site and before they leave. And that's very different than any other tissue. They have lymphatics everywhere and things just enter the network right away. So in summary, for this part is that the colon lymphatics are not just uniformly distributed. They are forming these units, these hubs that congregate all the tissue drainage, and that is supported by the lymphatics. So in a previous publication from Dr. Mehandra and Colombel, that shows the UC margin, you can clearly see that demarcation of disease, known disease region, and you can appreciate that on the left, the part that is known disease, you have those folds, and the part with the disease, you basically lost its folds. So if you do a histology on that spot, you basically see that there used to be a fold there where you have a lot of structural stroma underneath, and after that, you just have a lot of inflammation and loss of structure there. So we think that maybe this fold units that congregate and form there might be something that helps the tissue to drain in a specific pattern that is completely lost when you have this inflammation, because in this case, you still have some epithelium there, but everything underneath is just gone. So in order to try to see that in the mouse model, we use just the classical DSS colitis model to see. So of course, if you give these dextrin sulfate salts, you degrade the epithelium, and that makes the mouse sick. You have loss of weight, and the column gets shorter. And if you look at the distal intestine, you have this edema forming. So you have the structure of the fold, again, it's like getting disrupted. If we measure the layers, you see that the submucosa is huge. If you stain for lymphatic vessels, of course, the lymphatic vessels are more numerous and dilated because of the edema. But if you just forget about the disease and you just remember of the concept that I'm trying to pitch, which is this structure that is just under that fold, and you try to measure that, and you see that that structure is now disrupted because of this distension of the inflammation. So something, all of that infiltrate, all of the inflammatory milieu is just creating a disruption on the hub, and now the lymphatics are not acting the same way as before. So the way that the lymphatic drainage can respond to an inflammatory site when it is needed the most, it can do two things. It can either increase its permeability, so you just open the doors of your dam, or you just increase the number of outputs that can do that, right? I don't have time to show you today, but when the literature knows that this permeability is controlled by VEGFR2, which is a receptor that binds to VEGF-A, and that basically shuts or opens the space between the endothelium and allows cells or molecular cargo to go in. So we tested that, and we saw no differences. And the way that the lymphatics usually proliferate is via this autotyrosine kinase receptor, VEGFR3, which promotes transcription factors that would induce proliferation. So what we did in this test is that we provided a soluble version of that receptor expressed by a virus, and that soluble version is going to basically uptake all the ligands of the receptor and rendering the system without the capacity to induce lymphoangiogenesis. So if we do that and we provide DSS, the mice get very, very sick. If they don't expand their network of exit, they get very, very sick. Their colon get even shorter, and 75% of the mice die with that amount of DSS. So showing that this plasticity is essential to withstand that challenge. So in summary, with in acute inflammation, there is a disruption of this fold, and you need the VEGFR3 lymphoangiogenesis to try to withstand that disruption, to try to accommodate for that. So lastly, what we did some lymphatic endothelial cell, macrophage and fibroblast single cell. And when we look at only the lymphatics here, because we don't have much time to go through this, is that we find 4 populations of this cell type. But most interesting is that there are 2 populations that are kind of unique for this influence of the inflammation. So these cells are sensing the inflammation milieu and are actually producing proteins and producing a reaction to it. So if we see, of course, TNF might be very important. So if you can look at a signature for TNF gene score and interferon gamma gene score, so they're clearly responding to the inflammation that is driving over there. And this is an expected sanity check kind of marker. Of course, when you have inflammation, vessels tend to express ICAM1. But then, for example, cavillin-1, which is important for that permeability, is severely downregulated, which will explain all of the edema that is formed. And to try to keep things in time, because I know that was very pressing. What we see is that, of course, in the mice that are undergoing colitis, you get this acute activated type of lymphatic endothelial cell that is completely changing its biology in response. They're proliferating, but they're also reacting to the environment in a way. So in the sense, what I want you to take from this talk is that these vessels are critical for our mucosal immunity, but they're not just passive. They're not just there to drain tissue and everything. They can really respond and react to the inflammation milieu. There is this concept we're trying to push is that specifically for the colon, where you have these large invaginations, there is a hub there that is formed in order to draw the interstitial fluid and cells prior to the entrance of the lymphatic vasculature. And I don't have time to show you today is that we found specifically macrophages that are just sitting around those vessels, and they can do a secondary barrier function there. So that's what the question that we're asking. How are these endothelial cells responding to environmental, immunological, and physiological cues to try to see and tackle their function in chronic diseases? And with that, I would like to thank Jim-Fred for the invitation and Surab for all the help during the start of my career, and again for Sergio from the very start of my career, and for my lab, several collaborators, and for our funders. Thank you.
Thank you so much. We have time for some questions. I have one quick question. This is fascinating, but how does that account for what is my obsession, which is this demarcation that you have shown in UC, you know? In the surgical specimen, when we scope, you know, it's inflamed, and then 1 centimeter above, it's not inflamed. Yes. So how to make sense? Is this false?
Yeah. So I want to try to gain more access to human samples to try to tap into that question. But what we think is that because this works as a network and not so you have in the mouse, we basically see a whole section of the intestine gets a disease and another part gets kind of a spare because of the efficiency of this folds to happen. So the distal and the proximal colon of the mouse have very different impacts of the microbiome together with the DSS. So I think that because the efficiency of the folds to really push things out and then they don't accumulate all those inflammatory media. So I think that if in the human, in my hypothesis that that's the same case, it works in a network effect. And then if you impact all that network, you're going to impact a region. And then that if the other region is not part of the same network, that will be the hypothesis that will explain that.
Okay, so
Rafa, thanks for presenting this beautiful work. To your knowledge, are there any data on, let's say, lymphatic changes during mucosal inflammation and other primary lymphatic disorders, including disorders of peripheral lymph flow?
Yeah, so there are disorders like protein-losing enteropathy and something else that I'm blanking on my name, that has some inflammation, and those are kind of defects on the lymphatic network. I think that the primary lymphatic, like the biggest lymphatic defects usually are, we don't survive. So people that have basically smaller lymphatic defects are the ones that have primarily lymphedema, and those are usually on the in limbs or external portions. But I think that those are kind of like mild, or sometimes they are like mosaic alterations. I don't know exactly how that is in the gut. I don't know if we have a mosaic thing or someone that described that. But we know that if you just look for developmental effects, there's a huge impact. If you mutate a gene on a mouse, there's a huge impact on the intestine. So there is a possibility that maybe some of the people that develop IBD might have this, and some genes are the same. But I think that needs to be way further studied. It's not really explored. Thank you. You're going to have to ask the guys who came.
I think it's out. Yeah, they already did. All right. Hello, everyone. Welcome to session 5, microbiome. For our first talk, we'll have Garrett Schmidt talking about identifying drivers of therapeutic bacterial strains transmission. Here we go.
All right. Okay, cool. Hello, everybody. Thank you for sticking around after lunch. And yeah, I'm going to talk to you about some preliminary data that we have, and that is part of my thesis project as well. So as many of you know, there are several products currently on the market and FDA approved in the treatment of the microbiome, and specifically in the RCDI space. So for one, we have Rebiota, which is an enema-based FMT, and then we have Voust by Seres, which is an oral dose FMT. There are others that are currently in phase trials, which are, for example, by Vedanta, which is a consortium of oral strains. But however, they have all shown great progress and in the treatment of RCDI and reconstituting the microbiome of the recipients. However, that has not been the case in other intestinal diseases. And a large problem with when we're looking at these studies and trying to figure out why that is the case is that a lot of these trials are using many different donors, and specifically, even for example, like unique donor recipient cohorts. So often when we're trying to strain track, there's a lack of granularity, and we're only really able to really look at a species level. However, what we do know from previous data, as you can kind of see here, like it's not super clear, but you get the idea, is that a higher engraftment of donor strains is usually linked to treatment success and outcome in the context of RCDI. What we have access to, which is a really cool cohort that we have collected over the last from our collaborator, Dina Kao at the University of Alberta, is that they have done a bunch of FMT studies over the last decade in the context of several clinical indications, such as obesity, RCDI, severe fulminant CDI, Crohn's, and then also different FMT formulations. And the unique thing about this cohort is that they've used the same donor cohort consistently across these studies. So we're able to really look at how strains behave differently in these different contexts. The way we're doing the strain tracking right now in our pipeline is that we have stool samples from both the donors and the recipients. So we have a genomic sequencing, and then we are culturing and isolating those bacteria out of the donor samples, getting the genomes, and also getting MAGs from both our metagenomic samples from both cohorts, so that we have a combined pool of bacterial genomes that we can then track using our lab's own strain tracking platform algorithm, which is called Strainer. And right off the bat, which was very cool to see, is that we were able to show the same thing that shown been previously in literature, that in our cohort, in our RCDI cohort, that we're recipients received FMT via colonoscopy, we're seeing the same thing, that if strains engraft successfully, that is then also linked to treatment outcome in terms of reconstituting the microbiome and then getting rid of the C. diff specifically. So in the other cohort that we want to look at here is the Crohn's cohort. And I think that's probably the interesting part more for this audience, is that there is the trial was performed in Canada over a couple of years during COVID, and then it was ended. But in here, recipients with mild to moderate Crohn's disease received an FMT first via colonoscopy and then oral doses weekly for 7 weeks after, continuously. The trial itself was negative in terms that the FMT group was not able to show any endoscopic remission or response, but they were able to see clinical remission and response, which was, I mean, yes, not significant in the placebo group and FMT group, but in the FMT group that showed clinical response, they saw that the similarity of the microbiome in those FMT recipients was more similar towards the donors in comparison to those FMT recipients who did not show clinical remission. And what we were able to look at, see already, also with like a very limited data set currently, is that even though those patients and recipients failed to show endoscopic remission, there was significant engraftment in terms of the same donor strains. And that's specifically, of course, very interesting if we're looking at those same strains that are engrafting very, very well in the RCDI group and then showing treatment success. Even though they're engrafting here in the Crohn's group, they're not. It doesn't lead to clinical success. So now we can also already look at a couple of other cohorts here, and there seem to be some trends in terms of the route of administration as well as the pre-treatment defining the engraftment success and proportion of the strains engrafting. So on the left here, we have the RCDI colonoscopy group. So you can see here, everything's engrafting pretty well. Then to the right of that, we have an RCDI group which received FMT via lyophilized oral capsules, which was also a successful trial. But as you can see here, the engraftment success is much more varied. And then we have our Crohn's group, which is negative, but then high engraftment. And then we have a severe and fulminant CDI group, which received FMT via repeated colonoscopy. And here you can also already see that here the clinical background seems to be having a huge impact on engraftment success. Like it's much more varied and the range is much higher. And then last but not least, there's also an obesity group here, which we have in which patients received FMT via oral capsules. And as you can also see here, is the engraftment success is much more limited in comparison to the other cohorts. But if we're looking at actual strains, like this is very, again, kind of preliminary, but we can already see that seem to be two different groups of strains and how they behave differently based on the clinical context. So we have a group here of universal colonizers, where I call them like that because they seem to be doing pretty well in terms of engrafting in RCDI as well as in Crohn's. And then we have poor colonizers, which seem to be doing pretty well in the RCDI context, but not as well when we're looking at the Crohn's. All right, so that kind of brings me already to the end. So what we're able to sort of already show with this preliminary data is that within RCDI, the engraftment success of these same donor strings is linked to treatment success, but also that the route of the administration of the FMT as well as the pretreatment of the cohort seem to actually have an impact on the engraftment success of individual strains. And of course, what we want to see more in the future is really just get more data from our collaborators, specific, like whatever they find in the freezer, they're going to send to us, hopefully. And we want to analyze that, of course. So we're going to include more donors, more recipients, and then really see which strains are the ones that are consistently engrafting across all of these cohorts. And then more importantly, and which are the ones that are not doing well in specific cohorts, and characterize those strains, as you can imagine. All right, so much.
All right, we're like perfectly on time. Our second speaker is Jared Wheeler, talking about characterizing gut microbiota-specific T cells in peripheral inflammatory disease.
I can find it. Cool. All right. So this is my talk on defining the specificity and malleability of microbiota reactive T cells in inflammatory disease. So to start, I'm going to be referring to IMIDs, which are immune-mediated inflammatory diseases. And these include IBD and rheumatoid arthritis or inflammatory arthritis. And one thing I just want to point out is that there's a lot of extraintestinal manifestations of this inflammation, and people with IBD are 5.8 times more likely to develop a form of arthritis. So I want to kind of dive into this and what might be causing that. And some characteristics of IBD and these IMIDs are dysbiosis sometimes. This includes decreases in microbiota density as well as decreases in alpha diversity. And there's also cytokine dysregulation and changes in the effector and regulatory T cell subsets within these individuals. So here we can see that people with IBD have lower amounts of alpha diversity. We can also see over here that people with inflammatory disease or rheumatoid arthritis in this case also have this decrease in alpha diversity. So there's a similar pattern that we're seeing. And not only that, but we see that in people with inflammatory arthritis, we see increases in the IL-17 within the blood and also the stool and other inflammatory markers. So now we're seeing this situation where we're having this change in the gut microbiome of these people with these altered microbiomes with IMIDs, and we want to know what might be causing that. And one thing that our lab has done to investigate this is we have taken the microbiomes of people with different IMIDs. So here we can see inflammatory arthritis and then ulcerative colitis. My mouse is not there. And so when we put these microbiomes into these SKG mice, which are mice that are able to develop arthritis when they're given an innate immune adjuvant, it's an immune-dependent inflammation, and they develop arthritis as well as ileitis and colitis. And here we can see that the mice that received these IMID microbiomes or IMID-associated microbiomes result in worse severity of colitis as well as arthritis compared to healthy individuals. So we know there's something about these microbiomes that are altered that is resulting in this increase in disease severity in these mice, and then we don't know exactly what is resulting in this or what the mechanism is of the T cells that might be resulting in this phenotype. So this gets to my hypothesis, which is that altered microbiota in individuals with inflammatory disease shape the specificity and functional state of microbe-specific T cells. So to go about studying this, I worked on developing and optimizing an AIM assay, which is an activation-induced marker assay. I'm using a well-defined patient here that we can see all the microbes that we're looking at here. And the ones that I'm highlighting are the ones that I was monocolonizing mice with. So I would monocolonize the mice with these different microbes. Here, they're just B6, like homeostatic mice. And then after 3 weeks, I would take out the mesenteric lymph node, isolate CD4 T cells, and then plate them over dendritic cells that were previously primed the day before with the same lysates. So this way we're able to kind of like create a matrix sort of where we're able to see what the T cell reactions are to each different lysates when they're primed with different things within the mice. And then our readout with this is going to be spectral flow cytometry. And so we developed this assay so that we're able to do downstream things that are more scalable, such as single cell TCR sequencing, and to not rely on things like ELISpots. So after optimizing this, we end up with data that looks similar to this. And so here I'm just going to show Th17 at first. Each box is a different monocolonization. So first we have like R novice on the left, monocolonization, and then each one of the different boxes within that, the bars, is the response, the AIM response or AIM frequency of the Th17 cells to each one of the lysates. And then we have no lysate all the way on the end within each one of these monocolonizations. And then the red arrows are pointing to the response to the cognate lysate that the T cells were coming from, like within that mouse. So for instance, in the E. coli one that we see, like in the middle, with that arrow, we see that there's a strong Th17 response to E. coli in the E. coli monocolonized mice. So another way to look at this is in a matrix form, and we can see with the strong diagonal of these red boxes that there's a strong response to the cognate lysate when the mice are primed with something. So basically, we're seeing that the T cells are most responsive in this very expanded T cell subset of Th17 cells to the microbe that the T cells were primed with in the mouse. And because we're doing this with spectral flow cytometry, we're able to not just look at Th17 or IL-17, we're also looking at total CD4 T cells. And these ROR gamma T negative and positive Tregs, so these circulating and then also induced Treg populations. So we're seeing the specificity, but it also is dependent on the microbe. There might be some cross-reactivity, and it also depends on the different T cell subset. But we can take this one step further and not just look at a homeostatic mouse, but again, look into an inflammatory mouse model. And so here we're doing the same exact thing, but in the SKG mice, where the mice are able to develop arthritis and colitis. And so here we have the mice monocolonized with each of the same 4 microbes from the same donor. They're all different phyla. And we can see that with the E. coli monocolonization, they develop more severe joint swelling. So there's more severe inflammation in these mice that have the E. coli bacteria. And this just means that there might be microbe-specific inflammation occurring. But then looking into this, we can see that also within the MLN, which is like the gut draining lymph node, versus the BLN, which is the brachial lymph node, or the joint draining lymph nodes of these ankle inflamed mice, we see there's also an accumulation of Th17 cells within the joints of these inflamed mice that have E. coli. So E. coli could be linked to just an increase in this Th17 expansion within the swollen joints. And not only that, but then the top part, just looking at the E. coli monocolonization, we can see with the arrows that there's an accumulation of these AIM frequencies within the joints. So seeing a lot of E. coli responsive T cells within the brachial lymph node of these very inflamed mice that are monocolonized with E. coli. And then to compare it to the Biovatus mice, which are less inflamed with the disease severity, we're seeing less of this accumulation of microspecific T cells to Biovatus within the joints. So now we're seeing this accumulation of possibly effector T cells within the inflamed joints of mice that have maybe more immunogenic bacteria. And now we want to find what the link between individuals with these IMIDs and their altered microbiota are to their T cells and what the functional state of their T cells might be in circulation. So ultimately, with this assay, this will enable us to track microspecific T cells across tissues. We also want to do this not just in Crohn's disease, but in everything else. This week, I have a long assay starting tomorrow with arthritis donors. So we're going to be looking at this with more microbes. We know that certain microbes might be driving inflammation and effector T cell expansion, both within the gut and joint draining lymph nodes. And with this assay and doing sorting, we're going to be able to sort out these cells that are reactive to the different microbes and then track shared TCRs and look into what these microbes might be doing to the T cell specifically. I just want to thank my lab and the mice, everyone.
All right, our next speaker is Kushal Saha. I want to give you a special thanks for breaking up the session and not being all from one laboratory. Speaking about harnessing the IGF-1 pathway to promote healing in Crohn's disease. Thank you.
Good afternoon, everyone. It's been a long day. So let's talk about some tissue healing. So the premise of this study, or the work that I'm doing, is based on this work that was done by a member of our lab called Daniela, where we showed that patients who are refractory to Crohn's disease, if we do autologous stem cell transfer, they become responsive to treatments again. And why this is important is because despite medical advances, about 30% of CD patients will remain refractory. So autologous stem cell transplantation poses a new avenue of therapeutics. The other thing, but the problem is we still don't know how this is happening. A key finding that we observed was that when we do SCT or stem cell transplant, there was an increase in macrophages that produce IGF-1. And this is further showed here. So after SCT, 6 months post SCT, there is a increase in macrophage population that is shown here, and they were also enriched in IGF-1. This is unpublished data. We did spatial transcriptomics using Xenium, and again, here we can see that there is increase of IGF-1 signal, which is shown here in red in post-SCT patients. So moving on, we wanted to see if IGF administration can improve the outcome of CD by promoting tissue healing. So what is IGF-1? IGF-1 is a hormone that is produced by the pituitary in response to GnRH, and then it gets IGF-1 is produced in response to growth hormone, which is produced from the pituitary. It goes to the liver, and then it produces IGF-1, which is then translocated systemically. Additionally, it's important to also note that this is a whole systemic approach, but also IGF-1 can also be produced in peripheral tissues individually, where they do their own micro niches. Therapeutically, has IGF-1 been used? Yes, it has been. IGF-1 is used to treat IGF-1 deficiency in Laron syndrome, and where it is delivered subcutaneously. But the problem with it is that this is systemic administration and can cause a lot of adverse effects, including hypoglycemia, tachycardia, and lipohypertrophy. So there is a need to develop a site-targeted and tunable IGF-1 delivery system. This is where we try to develop this. This is a bacterial system where IGF-1 gene was cloned into the E. coli K12 bacteria, and it could be induced in response to IPTG. We saw that this bacteria actually produces soluble IGF-1, and additionally, this was bioactive. It means it can bind the receptor for IGF-1, which was done by luciferase assay. So we then wanted to set up an in vivo experimentation as whether it can be used therapeutically, for which mice were gavaged with this bacteria after 7 days of antibiotic treatment, followed by 2 weeks of allowing the mice to be colonized in the presence of IPTG and ampicillin, which is a selector for this bacteria. And what we observed was, when we did immunoprofiling of the colonic immune cells, we see with unsupervised clustering, we see an increase in myeloid cell population, which is shown here. And again, with supervised clustering, that is supervised gating, we do see an increase in the myeloid population, indicating that this IGF-1 in the colon of this mice is causing a change in the immune landscape. Moving on, doing citrus analysis, we also found, in addition to myeloid subpopulation, we also found an interesting that ILC3s were also increased in these mice colons. Furthermore, in a very recent DSS model, in which I want to say we use a very high percentage of DSS, which is 4% here, we saw that the weight decrease of mice was thwarted in the IGF treated group compared to EV. Additionally, it's important to note that majority of the EV, all but one of the EV mice died except the IGFs. It does seem like there is a protective role, but this needs to be fine tweaked a little bit more. Moving on, we also wanted to show whether IGF-1 has an effect on HSC differentiation. And indeed, we actually see that even in CD34 and CD34 negative and CD34 positive cells, if we treat them with IGF-1, there is a shift of these cells that it promotes into a myeloid markers and promoting it to myeloid cell differentiation. So with these, what we can conclude is E. coli we can use as a target to target IGF-1 in a tunable way in the intestine specifically. In vivo, IGF-1 expression increased myeloid cells in the tissue intestines. IGF-1 protected from the severe and high dose of external sodium sulfate. With this, we have a lot of work to do on this project. One of the major one is optimizing what timing IGF-1 is most optimal, to whether it's to add it before, during, or after inflammation. What is the mechanism of action of this? And finally, developing additional targetable therapeutics, which is not only bacteria, but we are also looking into other avenues, including lipid nanoparticles and hydrogels. And also the efficacy of IGF-1, we also want to see whether it can be used in combination with other therapeutics that are commonly used in IBD. So with this, I would like to thank everyone in my lab and also thank you for your attention.
All right, my friends, we're moving very quickly here. The next speaker is Marco Mergen, talking about analysis of the fistula microbiome in perianal fistulizing Crohn's disease.
Okay, thank you to the organizers for allowing me to come and speak today. And as Jay mentioned today, I want to talk about this ongoing project that we have where we are working on characterizing the microbiome in patients with perianal fistulizing Crohn's disease. And as you've heard before, this is one of the most severe manifestations of Crohn's disease that affects about 20% of patients who have CD. And we don't really have a great understanding of why this is occurring, or really the mechanism behind, how these fistulas are forming. And there's usually about, there's several different types of fistulas that, can manifest in these patients. And it's thought that one of the main contributing factors is sort of this epithelial defect that is occurring in this subset of patients, that leads to the development of these fistulas and further complications that, have become really difficult to treat. And although, we don't really have a great sense of why this is occurring, we were really interested personally in identifying if there was a potential role for the microbiome in the context of this disease, specifically because, at least in some patients, we have found that there were some improvements with the use of antibiotics and treatments with this sort of regimen. And we were really interested in this because, the potential interface between, the microbiome and to the proximity of these fistulas, we thought there could be something really interesting occurring here. And there could be one of these, combinatorial factors that lead to the progression and the formation of these fistulas. And in order to do this, we decided to sample a few different sites from these patients, and this was done in collaboration with Sinyu, who was nice enough to do a lot of this clinical work for us and give us this really nice data set. And what we wanted to do was sample these different sites. And within these patients, what we did was we sampled the internal opening of the fistula along with the external opening, and also doing these rectal swabs and skin swabs, which you can see at the bottom, roughly to illustrate where we're obtaining these samples from. And we would do these swabs, and there's a cohort of about 225 patients, and we were fortunate enough to have actually multiple time points for some of these patients, so we could track them over time to track the development of the microbiome. And when we did this, we used 16S sequencing to get a sense of what the microbiome is looking like in these 4 different regions. And we began by just taking a global view of the microbial composition between these 4 different sample types, specifically, again, the external opening, internal opening, the rectal swab, and the skin swab in these patients. And what we found was that really they seem to be quite similar in terms of the composition. There's maybe some differences based on, these PCA plots, but in general, it does seem that like the external opening and the internal opening are more similar to each other than maybe the rectal swab and the skin swab. But overall, there's not really any huge differences that are driving the global composition of the microbiome in these patients. And we went on to further take a look into what the diversity looked like of the microbiome in these patients. And what we found wasn't necessarily too surprising. We found that the diversity seemed to be similar across all 4 of these sample sites, with the exception of the skin swabs, where we maybe expected less diversity due to the naturally occurring less diversity in the skin microbiome. And what we wanted to do is sort of take a further look into this and identify specifically how these genera and the species that we find within the sequencing is actually changing. And we found that potentially one of the reasons that we see this reduced diversity, at least in the skin swabs, was likely due to the more prevalent populations of like Corynebacterium, for example, within the skin microbiome of these patients and and people in general. However, again, there wasn't really anything crazy popping out to us about the differences between the external opening and the internal opening of the fistulas. However, what was really interesting to me was when we moved further down into taking a look at the species level to identify specifically what are the most abundant species in these swabs, and kind of how that ends up, how the microbiome is shaped at the species level within these different sample sites. And what we found was pretty interesting in that some of these species are more common than others, like B. vulgaris, or P. vulgaris now is something that is really commonly found in the microbiome. But interestingly, there's some of these other species like this Feingoldea magna, which is here in the green, that we found in all of these different sample sites at a really high relative abundance, which is something that was really interesting to us because previous literature would suggest that this is a species that's commonly found in different microbiomes associated with wound healing, and something that you would see in those sort of clinical situations. And what was nice about this data set was that we were actually able to, because we had multiple time points, we were able to get a sense of what the microbiome looks like in between, different visits from patients. And for some reason, my dots have disappeared on this PCOA plot, but just pretend like it looks really compelling. But what I wanted to show here, and what I wanted to emphasize, was that we do see differences between time points in these patients in these different regions, like the external opening, internal opening, and skin swab. And it seems to be more prevalent in the patients with PFCD rather than some of the other ones, which have some of these other diseases, or patients who have just the fistulas and no IBD. And what we were able to do is kind of get a sense of, we took out these patients who had the largest changes, and we were able to take a look at, which of these species are actually changing the most between, time point 1 and 2. And here we start to see some of those same bacteria again pop up, like the Pivogatus and the Feingoldea magno, which we were previously interested in. Kind of cool to see that some of these same bacteria are actually changing at different time points, and it could be something of interest to us. And moving on with that, we were able to get a sense of, taking these different time points. And what was nice about this cohort was that we had information on the patients which actually improved during the duration of their follow-ups and their visits, and those who had the symptoms that were not improving or even worsening. And what we were able to do from here is take those patients who improve and the ones who don't, and compare the differences in things like their microbial diversity, as well as taking a look at just different changes in the abundances of some of these species of interest for us. And here we can see that, although not significant, it does seem that there does seem to be a little bit of a slight difference between those who've improved and not improved in terms of Shannon diversity. And when we take a look at some of the changes in the species abundance, we can see some of our more abundant species changing, albeit very slightly in these patients in terms of the relative abundance. But what was really more interesting to me was trying to use these different time points to get a sense of if we can predict which patients are actually going to improve based on just the microbiome alone, and those who have improved symptoms or the ones that have worsened or not. If we can sort of get a sense of who will be changing at the next visit and in which direction based on how their microbiome is, based on the composition of their microbiome. And that's what we were able to start doing here, where we try and get a sense of the predictive value in terms of the improvement of these symptoms in these patients. And what we can see here is that some of the species highlighted in red were some of the ones that we saw previously. These seem to have most of the predictive value, at least at time point 1. We can kind of sense of, we can use these different species to get a sense and predict who's going to actually get worse, or who's actually going to get better symptoms at the next visit. So that was kind of something really interesting that we were hoping to keep going in the direction on, and try and get a sense of what sort of predictive value these species and this microbiome analysis can have in terms of improvement in symptoms and et cetera. So what we're seeing is these, albeit in some cases modest, changes in the microbiome within these patients, but we think it's really important to start to characterize just how the microbiome looks like in these fistula samples, and to see if we can find any sort of value from there. And what we're looking to do next is actually not just characterize the fistulas, but also begin to try and culture some of these samples and get a sense of what that looks like, and how try and characterize these bacteria and see what kind of influences on the immune system they might have in the future. We're also looking at diving deeper into this longitudinal data. So I only showed the data based on patients who have improved symptoms and those who haven't. But we're also looking to characterize, the effects of therapy over time, and get a sense of how these different therapeutics are actually, or if they are even changing the composition of the microbiome. And beyond that, like I mentioned, we are interested in sort of assessing the all of these host populations and identifying different, immune cell reactions that we think could be interesting down the line. And with that, I just want to thank everybody in my lab, and a big thank you to Sinyu for obviously helping us with this giant experiment. So yeah, thank you.
All right, so our final speaker for the session will be newly minted Dr. Jeremy Fisher. He's just coming back from the first vacation he had in many, many months. He was like really pushing to get to his PhD defense. And John Fred was like, I saw his title, I was like, hey, can this guy come? So here's a special encore, abridged version of his defense. And then he's gonna, I'm sorry to let y'all know, but he's going to the world of the MDs next. So he's an MD PhD about to go back. I think you're officially in medical school today. So thanks for skipping out on whatever y'all do in the clinic to come here and speak to us. Oh, and his title is not microbiome related, but we snuck him into the session. T cell clonal groups are broadly dispersed in colon, phenotypically plastic, and altered in ulcerative colitis. Thank you, Jeremy.
Thank you for that kind introduction. I am taking a day of vacation to be here, but I'm happy to do it. So yeah, once again, my name is Jeremy Fisher. I'm an MD PhD student here at Mount Sinai, and today I'll be talking about T cell clonal distribution in the human colon in health and in IBD. So TCR repertoires reveal the scope of antigens that will activate an immune response, including those that come from the microbiota, pathogens, and the self. The absolute size of human TCR repertoires is on the order of hundreds of millions of unique T cell receptors, each representing a clonal group of naive or memory T cells. Ulcerative colitis pathophysiology involves alterations to T cell proportions and behavior, which has led to the development of effective therapeutics targeting cytokines and trafficking molecules. The goals of this project were to define the extent of TCR repertoire sharing across different sites of the colon at homeostasis and during active ulcerative colitis. To this end, we performed single-cell TCR and RNA sequencing on colon biopsies from 8 healthy and 6 ulcerative colitis donors, sampling 3 sites per donor. With this approach, we were able to define the paired alpha-beta TCR nucleotide sequence and phenotype for each T cell. First, we sought to define T cell clonal spread across the healthy colon to determine whether antigen sensing differs by region and which features are associated with ubiquitous clonal groups. We profiled healthy donors using 2 single-cell TCR technologies, Parse Biosciences and 10x Genomics. We compared repertoire overlap across colon sites by Moricida index, which accounts for the percentage of shared TCRs, as well as the similarity of clonal expansion across sites. Here, each point represents a comparison between 2 sites of the colon. Hopefully that will show up in future slides. But yeah, so higher values are indicating more similar repertoire structures. Across both of these methods, we found a high similarity across sites, which was not significantly correlated with anatomic distance. So we can plot out the distance between 2 sites based on averages from surgical texts. And what we see is that as we compare sites of the colon that are farther apart, we don't see a difference in overall TCR receptor overlap. So taken together, this suggests that at a high level, T cell clonal groups are highly shared across the colon rather than regionalized. Next, we examine differences in clonal spread by phenotype. To better capture the spread of smaller repertoire fractions, we calculated the evenness of cells from each clonal group across colon sites by Shannon entropy and took a weighted average by phenotype to generate pairwise dispersion index. Here, each point represents a comparison between 2 sites from the same donor separated by transcriptionally determined phenotype and grouped by CD4 or CD8 status. We found that CD8 clonal groups were shared significantly more across the colon than CD4 clonal groups. In addition, we found that CD4 T cells made up a greater proportion of clonal groups that were restricted to one site, suggesting that they're less ubiquitous across the colon than CD8 groups. Within the CD4 compartment, we saw a range of clonal spread. Th17 clonal groups showed the highest dispersion across sites, while Tregs were the least dispersed. This suggests that Treg clonal groups are the least ubiquitous across the gut, potentially being more regionalized or sporadic than effector phenotypes. When we shift from clonal dispersion across sites to evenness across phenotype groups, we see similar differences between phenotypes. Here, each point represents 1 donor per phenotype, with higher values indicating T cells of that phenotype have higher crossover with other phenotypes linked by the same T cell receptor. As before, we observed the highest mixing of Th17 clones with other phenotypes, while Tregs had fewer clonal relatives in other phenotypes. When we directly compare these 2 characteristics, we saw a strong correlation between site-site spread and intraclonal phenotype diversity. This suggests that CD4 clonal groups that are the most ubiquitous in the gut are also the most phenotypically diverse. The heat map on the right here is showing expanded TCR clonotypes as vertical stripes, with each color representing cells of different phenotypes and presence across different facets, indicating presence at different sites of the colon. What we can see is that Tregs, or the TCR clonotypes that contain at least one Treg, have a lower tendency to share with other phenotypes, whereas Th17 has a broader range of sharing. In addition, Tregs tend to be detected at multiple sites less frequently than Th17 groups. Next, we sought to compare these findings in the healthy colon to ulcerative colitis patients with active disease to determine whether inflammation alters global TCR repertoire sharing and whether distant inflamed sites show greater expansion of shared clones. All ulcerative colitis donors had inflammation in the distal colon. 3 had a cecal patch with uninflamed colon in between, and 3 had no inflammation in the proximal colon. This allowed us to make comparisons of clonal spread specific to inflamed and non-inflamed colon in ulcerative colitis. Comparing healthy and UC donors processed by the 10x single-cell pipeline, we found that Tregs and CD8 T effector memory populations were specifically increased in inflamed sites, while CD8 tissue-resident memory populations were decreased. We next measured the phenotype crossover within clonal groups within each site of the colon, and we found that inflammation decreased, on average, the intra-clone phenotype diversity. So while we expected to see a greater crossover due to documented phenotypic plasticity of T cells in IBD, it appears that local environmental cues in the inflamed colon tend towards a narrowing of phenotypes for clonally related T cells. Finally, we compared the site-site repertoire overlap between different sites of the healthy and active ulcerative colitis colon. We found that the whole repertoire sharing was not different in between groups, but that differences appeared in specific subsets. In particular, CD8 T effector memory clonal groups showed increased sharing, while CD8 T resident memory groups had reduced sharing during active UC. There we go. Next, we separated UC comparisons by whether they included 2 inflamed sites, 2 uninflamed sites, or a heterogeneous combination of inflamed and non-inflamed. Again, differences did not appear at a broad level, but were restricted to subsets. And we found that Tregs tended to show a greater amount of clonal spread, specifically across inflamed sites, while CD8 tissue-resident memory populations trended towards a lower spread that was specific across inflamed sites. In contrast, CD8 T effector memory populations in active ulcerative colitis had the greatest sharing across uninflamed sites, suggesting that repertoire remodeling of this compartment is strongest outside of inflamed areas. Taken together, these findings suggest that UC inflammation locally expands or recruits antigen-directed Treg responses, locally disrupts homeostatic CD8 TRM antigen specificity, and globally increases clonal spread of CD8 T effector memory cells. Sorry about that. It's taking a second to load. But we're getting to the end. Okay, there we go. So in conclusion, we found that the healthy colon is characterized by broad repertoire sharing independent of anatomic distance. We found greater clonal spread in CD8 and Th17 clonal groups, which were associated with higher intraclone phenotype diversity as well. We found that active UC drove an increase in Treg and CD8 T effector memory population with opposing patterns of clonal dispersion. UC patient CD8 T effector memory populations showed the greatest increase in clonal spread across non-inflamed sites, suggesting global colon repertoire remodeling. In contrast, Treg clonal sharing trended higher between inflamed sites, suggesting local antigen-directed immunosuppressive responses. And that is the end of my talk. So I'd briefly like to acknowledge everyone who made this work possible, especially Jay and Sarab for recruiting and biopsying all the patients included. And finally, I'd like to thank you all for your attention.
All right, as the moderator, I will now receive questions from the audience. To the people's here. Go ahead.
Hi, I have a question for Jared. So you pointed out the importance of the microbiota and the T cell in arthritis and IBD. Do you think that could also be important in the context of other extraintestinal manifestations?
Definitely, I do think that'd be great to look into. Right now, we're just using SKG mice, and they also get like ileitis and other things. So I do want to look also at these other tissues. For now, I'm just looking at like just the VLN or like the joint lymph nodes and the mesenteric lymph node. But yeah, I mean, we also have someone else looking at like MS, I think, in our lab. Other things like that. So yeah, all these IMIDs have like altered microbiomes, so we want to look into it.
Thank you.
My first question is for Jared as well. So what does that mean as far as therapeutic implications? So should we start to target the microbiome when we have this extraintestinal manifestation?
So I think something we want to do with this is like obviously we want to look into humans, and what we can do is look in the peripheral blood and also like in the synovium, like the joints of people with arthritis. So we're like actively trying to start talking to like rheumatologists and like get these different samples. But we can do the same AIM assay type thing and look at like microreactive T cells within their joints and see if they have like two R novis or this one E. coli that is like more immunogenic. And then also in the future, if we did like live biotherapeutics, where I'm also doing this project with like permeability or not permeability, perturbations. So trying to like add new microbes and see if we can like reduce the inflammation possibly by adding like a healthy donor's microbes. And yeah, so it'd be great if we can kind of balance it out.
Yeah, very interesting. And I have one question for Jeremy. I'm not sure I fully understand. How does your data account for the secant patch? You know, because this is something. So do you find similarity between the rectum and the secant patch? This is what maybe I missed that or I didn't understand.
Yeah, so we didn't notice any differences in like phenotype composition or repertoire diversity or anything like that compared when we specifically looked at the cecal patch versus the rectum or the left colon in terms of inflammation. And when we compare that to the healthy colon, it doesn't seem like there's a huge difference in repertoire structure, whether you're all the way at the cecum or all the way at the rectum, and that inflammation status is more important than the anatomic location. Does that answer your question?
Yeah. Thank you so much.
I had two questions, one for Marco. It was interesting to see the predictive, the potential predictive that you have with the monocolonization experiments you did. You said that there was a moderate potential effect of good bacteria that could be selected. Was this across IBD? Because you mentioned there were fistulas with non-IBD and IBD. Was this across like all of them? Or do you compartmentalize and look at if maybe some better strains are enriched in non-IBD patients?
Yeah, so in terms of the predictive analysis, that was exclusively for the patients with the perianal Crohn's disease. So we had most of our longitudinal data from there, and because we were studying like the different sites of the fistula, that was exclusively, those patients who had fistulas, and mainly that was, PFCD patients. But we have not yet looked at like looking at patients who just have IBD or who have like a fistula and like, no IBD or something like that. We have not had the chance to look at that yet. And I think this data set is a little bit underpowered for something like that.
Okay. And then the other question was for Jeremy. Have you looked at, since you get biopsies at the epithelium or any type of remodeling that you get in the segments where you have a remodeling of the regulatory T cells?
Sorry, could you repeat that again?
You said that you get biopsies from the tissues of the patients that you look at the different segments. Do you look at other compartments such as the epithelium and see if there's any type of remodeling?
No, so all of our analysis is done on the lamina propria. We have the epithelial fractions and RNA later, but we didn't do any analysis on those fractions. But it's an interesting question, especially given the amount of overlap that has been seen in human samples between the epithelium and lamina propria. There is a lot of crossover, and especially the TRM compartments would likely to be shifted in that during inflammation in that compartment, but our current study wasn't able to address that.
Thank you. I have two questions. The first is for Jared. So for those strains derived from patients who use for mice correlation, what's your like selection criteria to pick them?
So the reason why I picked those, we had a paper previously published, and they did these like similar like LA spot type AIM assay things, and they were not very scalable. And so then we wanted to pick a bunch of different microbes that were very like phylogenetically different. We did 4 different phyla, and there were some of them were a little bit more like immunogenic, like they had more of an IL-17 response than some other ones. So we kind of just wanted like a diverse amount of like microbes. So we have these 4 at first, and I'm going to be doing exactly this. So this one has been well defined, doing this one for a while in different mice. But I'm actually like this week going to be doing exactly the same thing, but with other microbiomes from other individuals. So we want to see other phyla also and other things. So
Basically, it's not determined by the abundance.
I think, yeah, we also want to look at the abundance and see maybe it is because of like a certain microbe is more abundant, but maybe it's like R novice is more associated with an increase in the arthritis potentially, and maybe it's that. But yeah, so we want to test a bunch of different things.
My second question is for Crucial. So for the E. coli strain you use for expressing IGF-1, did you use the strain like just from laboratory one, or like you used one like isolated from clinical samples? And after mice coronization, have you like determined the coronization level, and have you checked the genetic stability of it?
No, I think this is a normal lab grown one, K12 that we use. This is not like isolated from any patient. But we are still doing a lot of works, like very in like nascent stage at this point of time. So there's a lot to do.
Okay, thank you. We can discuss later.
Okay, thank you so much. So this is the end of the session. So we will have a break, and we will meet again at 3:10, so we can start in advance. I want to take this opportunity because Marcus is leaving, is going back to Germany. I think we should thank him a lot because Marcus came just for this IBD retreat. I think this is much appreciated. Thank you so much, Marcus.
As everyone gets settled, I just want to remind everyone to stay to the very end for the important ending remarks and the prize for those of who are eligible, but also most importantly for the Chapman lecture that will be given by our own Brian Ongaro. So without further ado, I will invite Maya Kael to come up to speak about fecal microbial transplant for the treatment of chronic pouchitis.
And thank you, Liz Cohen, for staying for my time. So this is actually a joint talk with Monica Fisher, who will be speaking right after. Oh, thank you. So this is actually a joint talk with Monica Fisher, who from Jeremiah Fate's lab, who will be speaking right after this. I'll be presenting the clinical preliminary results, and Monica will talk to you about the science stuff. So let me get started. The title of the talk is Fecal Microbiota Transplant for the Management of Chronic Pouchitis. And just very quickly, we're going to describe the rationale, feasibility, and the preliminary clinical signals for FMT as a therapeutic strategy for chronic pouchitis. And so as we all know, especially at Mount Sinai, despite all of these amazing medical breakthroughs that we've had, there is still a therapeutic ceiling for our therapies, and about 10 to 15% of patients with ulcerative colitis will require surgery within 10 years of diagnosis. And as it stands now, the staged approach to surgery is the most commonly performed. This is a 3-stage approach. The first stage is a subtotal colectomy. The second stage is the pouch construction, removal of the rectum, and then a proximal diverting ileostomy. And then the third stage is restoration of GI continuity. And this is a great surgery because it affords patients an alternative to a permanent endoileostomy, which is what they would otherwise be offered for medically refractory ulcerative colitis. Now, the pouch is made in inherently from terminal ileum. And in its new role as a fecal reservoir, it takes time to adapt. And part of this adaptive process is actually colonic metaplasia. This is a really nice study that was done from a University of Chicago group where biopsies were taken from the pouch body and separately from the pre-pouch ileum. And what they saw in the pouch body was that there was essentially new kinds of enterocytes or enterocytes that adopted new roles that developed in the pouch body itself as the pouch took on this role storing stool. Remember, previously to this, the small bowel, the terminal ileum, was not really a place where stool was stored. Stool would just pass by very quickly. There was more absorptive capacity than storage capacity. But now in its new role as the pouch, it takes on new roles. And so what was seen here, they found two distinct clusters of absorptive and secretory epithelial cells within the pouch body, but not the pre-pouch ileum. And in these new clusters, they expressed subsets of colonic-specific genes, including CCAM and CA2. And this really suggested that the pouch in its new role was undergoing colonic metaplasia. Further downstream analysis from the study showed that a lot of these new absorptive and colonic-like enterocytes actually had inflammatory programs. And so not only was the pouch undergoing metaplasia, but this metaplasia was inherently predisposing it to inflammation. And that's something that we see very commonly in patients with a pouch. We know that acute pouchitis occurs in up to 80% of patients with ulcerative colitis, and about 60% of patients will have at least one recurrence, but 20% go on to have chronic pouchitis. And chronic pouchitis, as it stands now, seems to be a spectrum of clinical disease, but this is how it stands in 2026. As we get better at mechanistically defining these different phenotypes, we might see that it's not really as much as a spectrum as it is clinically defined. Now, we know that in our management of pouchitis, it seems to be very much a microbially driven process, and this goes hand in hand with the partial colonic metaplasia data that was presented. A number of studies, not just this, have shown over the years that pouch microbiome is intrinsically less dense and less diverse than the microbiome of patients with ulcerative colitis with an intact colon, and compared also to the microbiome of general population or healthy controls. And this feeds into the idea that pouchitis, the pathogenesis is not only that colonic metaplasia, but also significantly a microbial process as well. A lot of how we manage acute pouchitis and chronic pouchitis is based in this idea of manipulating the microbiome. The first line management for acute pouchitis still is antibiotics. And in patients who continue to relapse and have progression of disease, we either continue them at the low dose of antibiotics or consider escalating them to biologic therapy. And there's really been only one robust randomized controlled trial for this group of patients. This was the EARNEST study that looked specifically at vedolizumab in patients with antibiotic-dependent and antibiotic-refractory pouchitis. It included 102 patients, half of whom were randomized to vedolizumab and half of whom were randomized to placebo. And you can see there was a significant difference in favor of vedolizumab over placebo in achieving remission and response rates, both clinical and endoscopic. But what isn't as well advertised is in this study, one of, again, the only randomized controlled trial, a significant proportion of patients continue to need antibiotics. And in fact, in the vedolizumab arm, 59% of patients needed antibiotics during their maintenance phase, and 37% of patients in the placebo arm needed antibiotics in their maintenance phase. So clearly, even when we're targeting the underlying immune-mediated component of pouchitis, there's still an underlying microbial process that isn't being targeted, and patients continue to need antibiotics for clinical remission. Now, given that dysbiosis is implicated in pathogenesis of pouchitis and the robust response that our patients have to antibiotics, many groups have theorized that potentially FMT could be a good option. Unfortunately, a number of studies have been done, and you can see here there's been mixed results, largely all negative and largely not efficacious, partly due to poor donor stool engraftment. And so this led to the idea of if the donor stool isn't engrafting, maybe it's the wrong donor. And so with that in mind, a collaboration between myself, Jeremiah Faith, and Ira Greenspan came to fruition where we designed a single center open label pilot study of FMT using donor stool from patients with a durably healthy pouch and transplanting it to patients with chronic pouchitis. The study aims were to explore the safety of transplantation of a healthy donor pouch stool to patients with chronic pouchitis, to determine the clinical efficacy of healthy to inflamed pouch FMT at week 8 via the Pouchitis Disease Activity Index, and to understand the engraftment of healthy pouch donor microbiota in these patients. And so this study was funded by the Crohn's and Colitis Foundation Litwin and the Kenneth Rainin Innovator Award. And essentially this is the timeline of the study. The study actually was two parts. First, we had to find the perfect donor, and we had to beg them for their stool and pay them a lot of money for their stool. And then we had to find the patients to transplant this donor stool to. And so it has been quite a labor of love over the last 3 years. The first was and it happened during COVID, which meant the patient the donor had to get screened or COVID swabbed every 2 weeks. So that was fun. So it starts with screening. You can see the donor underwent extensive screening. And then once we had our collection of stool, we started to screen recipients. The first 2 visits are clinical screening and then pouchoscopy screening. They get enrolled at baseline, they get stool collection. Then the protocol is essentially 2 enemas 1 week apart. So we deliver the enema in the IBD center via enema, and then they come in 1 week later for their second dose. All the visits after that are just safety assessments that are required by the FDA, and then they come in at week 8 for a pouchoscopy. So far, we've enrolled 10 patients, 6 of whom have completed the 8 weeks, and that's the preliminary data that I'll present to you now. And so essentially, everybody gets a clinical pouchitis disease activity index at baseline, and then we redo it 1 week after their first FMT, 4 weeks after 1 week after their second FMT, 4 weeks after their second FMT, and then 8 weeks after their second FMT. And presented a little bit more cleanly here, you can see that of the 6 patients that have completed all 8 weeks, there's an immediate initial drop in their clinical pouchitis disease activity index. And I'll just take a step back and tell you that clinical pouchitis disease activity index is focused on 4 things: frequency, urgency, fever, which is a weird aspect, but it is what it is, and pain. And so you can see up front, almost everybody had a very dramatic drop in their pouchitis disease activity index in their first week after FMT. 4 weeks after FMT, some patients sustain that response, but you see about half of patients start to increase. Their pouchitis disease activity index starts to increase again. And then once they're at 4 weeks, that response is sustained to 8 weeks after FMT. Now, similarly, when we look at their endoscopic response, we see that the majority of patients start with pretty high endoscopic scores outside of patient 3, but almost everybody drops in part from baseline to 8 weeks after their second FMT. And this is actually patient number 4, where they had a very large ulcer in addition to other ulcers in their pouch body, which completely resolved by week 8. Now, many of these patients were on baseline stable biologic therapy, but because they continued to have symptoms and continued to need antibiotics, were eligible for enrollment in the study. Along the time that we were actually doing this study, a case series came out from Denmark, which essentially was a similar approach, where patients with chronic pouchitis received FMT from a donor with a healthy pouch. This was a super intense protocol where patients received a daily enema for 14 days and then an every other day enema for 14 days. And this is probably why there's only 3 patients in the study. But at 30 days, all patients achieved clinical remission with reduced endoscopic inflammation. So similar early signal in terms of clinical disease activity. But over the long term, that clinical activity was not maintained. And in fact, when they looked at patients 6 and 12 months out, all that clinical benefit that they had retained up front was gone. There was limited microbial convergence that was observed between the recipients and the donor, and there was only 1 patient, albeit it was only 3 total, who clustered closely with the donor FMT. So our next steps are actually to continue recruitment. So our goal is 16 patients, and for you to listen to Monica's talk. Thank you so much.
You're perfectly timed. So I don't really need to introduce because Dr. Kayal already did, but Monica Chaudhry developing oral live biotherapeutics to restore the microbiome after antibiotic use for pouchitis.
Hi, so I will be presenting developing oral live biotherapeutics to restore the microbiota after antibiotic use in pouchitis. So as Dr. Maya already mentioned about the outcomes of FMT trial, which is basically the concept that we are using the engraftment status from the FMT recipients, and then we are trying to develop them into a live biotherapeutic product. So I would start with the concept of the previous
development of LVP product, which was developed for the treatment of RCDI. And this trial basically started with initial fecal microbiota transplantation, where a single FMT donor was used to treat multiple RCDI patients. And the outcomes of this trial were very promising in order to achieve long-term remission in RCDI patients. But despite the fact that FMT is very successful in treating the RCDI patients, and as in the case of pouchitis, but there are some limitations that I would like to highlight. And in order to define why there is a need of LBPs. So the basic limitations includes, as Dr. Maya just discussed about, extensive screening of the donors and a challenge of scaling up the fecal microbiota transplantation into available product. And despite this extensive screening, there is a risk of transmitting serious adverse events from the donor to the recipients. And if we particularly talk about the pouchitis patients, so the screening of the normal pouch donor with the durable healthy pouch is very rare, and getting enough stool material from these donors for treating pouch patients is another challenge. So coming back to the example of developing this LBP pipeline, Dr. Lucas, he worked on this particular, developing this MTC01 for RCDI. And he took the stool samples from the same donor, which was used for transmitting FMT to multiple RCDI patients. And then he cultured the stool samples and analyze the data in order to screen which strains are getting well engrafted into the recipients and the strains which are achieving the long-term remission. And then he removed any multi-drug resistant microbes, and then he identified 15 strains which he cultured in GMP anaerobic chamber and developed into a liquid formulation, MTC01, which was which was transferred through colonoscopy for treating RCDI patients. In continuation with this product, so due to colonoscopic delivery, it was very difficult to recruit patients for this clinical trial. So I started to develop this liquid formulation into an oral formulation and also tried to enhance the manufacturing, the overall drug development. So I successfully transferred this liquid formulation into an oral formulation and minimized the time frame for developing this product from 8 weeks to 2 weeks. And currently, we are working on IND, and hopefully after submitting the IND, we may start this clinical trial. So coming back to the pouchitis, so the exact cause of pouchitis is still it's not well known, but as Dr. Maya just discussed, that the microbiota dysbiosis in the pouch patients is a cause, is presumable, or is the major cause. So with the first incident of pouchitis, whenever it occurs, it's basically acute inflammation, which gets cured in response to antibiotics. But after the first incident, almost 60% of the patients may have recurrent incidences of inflammation, and where the repetitively antibiotics are given to these patients. And with this repetitive antibiotic use, this leads to microbiota dysbiosis, where the commensal microbes, the diversity of commensal microbes get reduced, and there is more abundance of pathogenic or multi-drug resistant microbes. And this is a published study from Dubinsky et al. So they have analyzed pouch samples for almost 6 months, and they compare the microbiota diversity in comparison to active antibiotic treatment versus the time lapse up to 6 months after stopping the antibiotic. So here you can see the microbiota there is a significant variations in the microbiota diversity between the active antibiotic use versus stopping the antibiotic for up to 6 months. So considering the fact, these all facts, basically, they suggest that microbiota variations are important and they are getting lost. So considering this fact, we are proposing to design a live biotherapeutic product. So we are using 3 different cohorts. The first one is we are interested in analyzing the pouchitis progression, where the active use of antibiotics is being used in the pouchitis patients. So we'll identify which microbes are basically get lost with antibiotic use. The second thing that we are interested to identify the microbes which are sustained in durable healthy pouches. So we have set of cohorts like with a stable healthy pouch. And the third thing that we are analyzing is the FMT data. So from the FMT trial, which strains are getting engrafted into the recipients, and that leads to the relief from the pouchitis symptoms. So we have set up, we are using Dr. Maya's patient cohort, and we have set of the data that we are analyzing with metagenomics. And for healthy pouch, we are also culturing the microbes. So continuing with the first pouchitis cohort, which is to analyze which microbes are getting lost with active antibiotic use. So this data is basically showing that, is it visible? Okay. So this graph is analyzing this on left-hand side. This is comparing the pouchitis phenotype with active antibiotic use in comparison to normal pouch. And on right hand side, this is Crohn's disease like pouchitis comparing with the normal pouch. So here you can see 2 of the species, Blauschia and Fecalimonas, they are significantly reduced in all pouchitis phenotypes. Whereas the other species like Bacteroides, Doria, Furcella, Roseburia, they are significantly reduced only in the pouchitis phenotypes with the active antibiotic use. So this is an example for Bacteroides. So on right-hand side, you can see this is the comparison for the Bacteroides abundance between the normal pouch and CDLPI, where they are present in almost in most of the samples in comparison to the other samples. Similar thing was observed for Doria. Here you can see similar presence in CDLPI and NPI. So here I want to highlight, we are particularly interested in selecting the microbes which are getting reduced with active antibiotic use. So coming to the next thing, that is which microbes are stable in the durable healthy pouches. So here, this is showing the data for 7 normal pouch patients. So, these patients have durable healthy pouch for at least 1 year of interval. So we are particularly interested in identifying the strains which are present in multiple normal pouch and at least present in at least 1 normal pouch patient and durable for at least 1 year. So based on this, we are interested to select these microbes from different phyla. And in order to define these microbes as LBP, we have set a target that will avoid incorporating any facultative anaerobes or potential opportunistic pathogens. Now continuing with the data for the FMT trial. So this is basically, so far as Dr. Maya just said that we have treated almost 10 patients. But here I'm showing the data for the metagenomics data analyzed for the 4 patients up to 1 week. And we have a target to identify or analyze the data for up to 8 weeks, which is completed for recipient 1 and recipient 2. So based on this, on left-hand side, these are the strains stable in donor D2, which are identified at different time intervals. And on right-hand side, the status of this engraftment in the recipient. So baseline is the day before receiving the FMT. So these are the straight in the blue, it's showing the engraftment. So here you can see like these strains, they engrafted well in the recipients. So our aim is to select these strains based on this. And so this is preliminary data and analyzed for up to 4 recipients. So we have a target to analyze at least 10 patients, and then we'll select the strains based on this data. So overall, like as I mentioned, for designing an LBP, we are considering 3 different cohorts. And after identifying the strains lost with antibiotic use, stable in the normal pouch, and well engrafted from the FMT trial. And after designing, the next step is to manufacturing. So based on our previous experience, we have set up this setup for a GMP anaerobic chamber for the production, and we also have a setup to develop this into an oral formulation. So overall, in the conclusions, I just want to say that after designing and manufacturing, we're gonna test our hypothesis. Does restoring the microbiota would really prevent the pouchitis relapse? So with this, thank you all.
Okay, next up, we have Rob Hurton presenting on wearable-derived digital biomarkers to predict disease activity and therapeutic response in IBD.
Thank you. Hi, everyone. Thanks for the introduction, Alexandra, and I appreciate the opportunity to speak today. So I changed the title just a little bit to bringing wearable monitoring to the bedside in inflammatory bowel disease. And sort of this is a little bit high level, going over some of the work we've been doing and what our areas of interest have been to sort of say, where do we want to go, and hopefully how can we get there in the space? So whenever you're, I guess, doing anything, you should say, like, where do I want to get to? And if I could say, like, where do we want to be in maybe 5 years, I think it's maybe in this area where you could imagine your hypothetical patient at that point waking up in the morning, they take their smartphone off their nightstand, they check it, it tells them how likely they are to flare. Overnight, their wearable metrics are being analyzed, providing them and their physicians with insight into whether a flare might be on the horizon. And this is where I think our goal, hopefully, is of being in the near future. Why would we have this goal? Well, one of the issues we have in IBD is that it's continuous. It's nonstop disease, but every way that we assess it is not. It's an episodic assessment that gives us this sort of cross-sectional insight into how the disease is doing, which means we're missing most of IBD when we're trying to monitor it. So how can we do better? Well, we need some way to be able to understand how the disease is doing between these episodic assessments that we're otherwise utilizing. And there's a lot of precedence for this. In fact, there are many diseases that use this type of remote monitoring to better manage their conditions, like diabetes, for example, with continuous glucose monitoring, blood pressure monitoring, cardiac monitoring. And in fact, at Mount Sinai, there are thousands of patients who are being monitored with RPM, or remote patient monitoring, to help improve various disease states. I think the best evidence for really where we can learn from is from other diseases like diabetes. And this is really, as we've seen, the proliferation of continuous glucose monitoring has really been shown well in this disease. And in fact, there were early studies that showed if you checked your sugar 1.5 times per day, you could significantly improve your hemoglobin A1C. And if you increased the number of times you were checking your sugar, of course, across the day, you would further improve your hemoglobin A1C. And this really led the way then to continuous monitoring, which is being done now. And in fact, many people even buy CGMs, continuous monitors, to kind of track their own glucose control over time. And this methods have shown actually significant improvements in all-cause mortality, hospitalizations, cardiovascular events, and really has become the gold standard for how diabetes is being monitored. So how can we think about this in conditions like IBD, where we have patients who are diagnosed, they're started on medicines, and we're spending months sometimes waiting to see if they're responding to the medicine, and then monitoring them to see who the 20 or 30% will get worse each year. And then after, say, the 75% of patients with Crohn's disease who need surgery, who will have recurrence of their disease and when will it occur? And then, of course, in other aspects of life, like in pregnancy monitoring, where we're looking to see how people are doing. So what's the evidence sort of supporting some of this? And this is some of the work that we've been very interested in doing and in trying to grow in the next couple of years. And we've shown, for example, that we can see utilizing wearables like Apple Watches, Fitbits, Oura Rings, or other types of research grade devices, small but significant differences in things like heart rate, resting heart rate, and steps, which could differentiate if you have a flare or not. Furthermore, when we look at autonomic function, like your heart rate variability, which is really an insight into your parasympathetic and sympathetic nervous system tone, and we look at it over 24 hours from the wearable devices, we find that it follows this really nice circadian pattern, as you can see on the left side of the diagram, that allows us to differentiate who with IBD has underlying inflammation or not. And in our patients that meet clinical criteria for flares of their disease, we could further differentiate if they have underlying inflammation. Really importantly, though, there's predictive ability. And we've published and shown, for example, as you can see in the left diagram, over the 45 days before you develop inflammation, significant changes in your sleep patterns, which we can pick up from wearable devices. Decreases in REM, deep sleep, increases in light sleep that give us an idea that something's going on in the body. We presented at DDW this year some of our early data from an ongoing study where we're able to identify responders and non-responders to biologics from metrics like sleep that's changing in this fashion, circadian patterns of autonomic function, as I just mentioned, or heart rate measures. So it's giving us insights into which of our patients starting these biologics actually are getting better on them or not. And importantly, we've developed deep learning algorithms, which we had presented also at DDW about a year ago, which show that on the individual level, we can predict who is going to flare, so get an elevated CRP or develop symptoms around 8 weeks before this occurs. And we're just finishing validating an external cohort, these algorithms, which show pretty decent AUCs for that predictive ability over time. Additionally, we've been very interested to say beyond just using these kind of metrics from optical sensing devices, like the devices we all use, we've been interested in looking at sweat, for example, and showing that, in fact, we can measure important analytes in the disease, like CRP, IL-6, TNF-alpha, nearly continually in the sweat, giving us insights into what's going on in the body without having to have blood tests or go to a lab or interact in some way with the healthcare system. So what does this really mean? Well, if we think about where we are today, it's a very reactive system. Largely, we have no way of predicting which of our patients are going to get worse with the disease, who's going to flare, or really who's going to respond to treatment. It's a lot of a wait and see sort of assessments with intermittent labs, endoscopies, clinic visits to try to understand who might get worse. And often we're waiting until people get sick with flares or not responding to the medicine to interact and intervene. With wearables, as we've shown with a lot of our studies, though, it gives us potentially insights that could give us a head start that something physiologically is going on in the body that might hopefully be able to be then leveraged to sort of mitigate those future flares. Or that's at least where we want to be in the future, where we can have this personalized treatment or intervention when we identify someone at high risk of flare to get ahead of it and improve it. Well, how do we get there? Well, we need to do a lot more work. At least we have some signs at least that these metrics could potentially then identify and predict flares, but this needs to be validated. We need to understand how to integrate it into workflows so we don't burden our doctors, and we also need to demonstrate improvements in outcomes. And this is where I'm hoping we're going to be going soon, as in the next few, hopefully months, we're going to be starting a study where we're going to be recruiting individuals across 12 IBD centers in the United States, again, using multiple wearable devices and touchless sensors that we're putting in the house that will actually, without even having to interact with the person, be able to measure things like their sleep metrics or their heart rate using radio frequency waves that are emitted. And then we're going to be expanding to post-operative Crohn's, recruiting individuals who have just had surgery for their Crohn's disease to expand in that post-operative setting. Very importantly, in combining this large data set that we're going to be forming, we're going to combine this with the data that we have to generate new and better generalizable algorithms, but also really importantly, build the infrastructure for monitoring so that over the next 2.5 years, actually have a platform to integrate these AI algorithms and pull in patient data to actually start doing this in the real world for our patients. At least that's the hope in the next 3 to 5 years to actually hopefully make this a reality. So it's a little bit of the vision that we have with this space and where we're hoping to take it, and hopefully can transform or improve how we manage our patients, much like we've seen with diabetes, though a lot of work needs to be done, but hopefully with the signals being there, we can get there. So it's a very big effort, all these things, and lots of people to thank, and I appreciate the opportunity to speak. Thank you.
Okay, thank you, Rob. And now we've got Ayana Lewis to speak about the Catharsis trial, combination therapy of resilience intervention with biologics in Crohn's disease.
Thank you all for the opportunity to speak to you a bit about our trial, Catharsis. Okay, so we all know that remission rates in Crohn's disease have plateaued in recent decades, and that we've hit this therapeutic ceiling. And patients continue to report in the clinical setting that stress is a trigger. And so preliminary data from open label trials in our IBD center have demonstrated that behavioral interventions targeting coping and disease self-management are associated with improved emotional and clinical outcomes. However, research on behavioral interventions in Crohn's disease to date have largely been observational or have lacked mechanistic specificity. So our overall objective was to demonstrate the efficacy of combining a biological therapy with a brief behavioral coping strategies intervention and compare it to standard therapy, which is the initiation of biological therapy plus an active control. So I'll take you through our study. So in terms of our study aims, our trial sought to combine, like I mentioned before, the optimal physical healing and improved psychological well-being, and look at the physiological stress response and the gut-brain microbiome access, and as well as coping and disease self-management behavior. So aim 1 looks at a patient outcome that evaluates the efficacy of this combination therapy on global well-being at week 24, as well as psychological well-being, self-efficacy, and distress. Aim 2 is a disease outcome that looks at the efficacy of combo therapy at week 24 in terms of quality of life, symptom severity, and endoscopic response. And our third aim, which is mechanistic, is to look at how this combination therapy positively influences coping through its focus on reduced perceived stress and increased physiological resilience. So in terms of our design, our goal is to enroll a total of 170 patients and stratify them into 2 treatment arms. One, which is the active intervention, which involves IBD coping strategies. Basically, we're teaching people how to fish, right? We're giving them the skills and tools that they need to be able to cope better. And our active control is a support program which involves discussing the disease, talking about the symptoms of the disease and how it impacts the lives of the patients, but not necessarily going into what strategies will help prevent additional symptoms. And our outcomes then look at global well-being, clinical remission, as well as stress reduction and resilience. To go into these 2 interventions a little bit more in depth, the active intervention uses techniques that are targeted at stress reduction, modification of arousal, resilience building, as well as self-management skills. We talk to patients about optimism and social connection. In the active control, there is none of this, but there is supportive listening, emotional validation, disease education, some self-reflection. Both of these treatment programs are done with 7 sessions with our psychologists, Dr. Kiefer and Dr. Loris, over a 12-week period. So far, thanks to our amazing research coordinators, we've assessed a total of 735 patients for eligibility. 188 of those patients were found to be eligible. Of those who are eligible, 110 are currently consented, and we're actively recruiting another 12. And so at present, we have about 100 patients that are randomized. Those who did not opt to do the study were often ineligible because we're past our 2-week eligibility period. They didn't meet active disease criteria. They'd had an IBD-related surgery in the last 6 months, were pouch patients, or not really a true new start. In terms of recruitment, that has been going very well. At 18 months into the study, we're exceeding the expected enrollment. And we have done a few presentations along the way. So at the 1 year point, we wanted to look at the acceptability of our study and the expectations of patients with regards to the likelihood of success, as well as the confidence in recommending the intervention, as well as the logic of the study. And patients really liked the study. We've had very low rates of dropout. So at the 1 year point, we had just 2 patients drop out, so 96% retention. And there was no significant difference between the 2 groups. But there's adequate blinding to the study hypothesis in both groups. And just to kind of give you some qualitative data as well, these are some quotes from our patients who are in the active intervention. They spoke about the importance of taking a moment to breathe, thinking about being more grounded in general and how they can move forward. They also talked about putting the focus on connection with people and also thinking about how the brain-gut interaction can impact their health. So far, after a recent reanalysis, we have been able to look at patients with some 12-week results. We're still very early in terms of our analysis at this point. What we've found so far is that within the 2 groups, there's no significant difference between the study characteristics that we were using at the baseline. Overall, our patients tend to be about 37 years old, are primarily female, 59%, primarily white. About 51% are bio-naive, and 11% have current steroid use. In terms of the biologic agents for new starts, there's a predominance now for anti-IL-23s over TNFs, about 69% to 31%. And then looking at the 2 groups in terms of the 63 who've completed the 12-week surveys, so far, most of the results do not show any significant difference, but we are starting to see some signals. We're still currently blinded to the 2 groups, but in terms of social function score, we're getting p-values showing some differences between the 2 groups, as well as psychological well-being. One thing that was a little bit of a surprise for us in terms of doing this study is we realized, as many of you guys realized, insurance plays a big role in patients starting new medications. But one thing that was surprising to us was how much of a problem it was. So even here in the Mount Sinai Health System, where we provide significant support to patients for starting medications, we have a pharmacist that helps them. 39% of patients experience problems or delays with biologic initiation. And of those 39%, 43% did not feel supported in dealing with the challenge, and 29% did not feel capable of handling the challenges. And generally, we saw a trend towards higher self-efficacy and resilience in those who did feel capable, but this was something that we thought was notable, and we'll be publishing a brief report on this shortly. So in conclusions, a virtual brain-gut intervention is feasible for patients in the induction phase for a new biologic therapy. Patients are interested in behavioral interventions in the context of their inflammatory bowel disease care, and insurance remains a major barrier for patients starting new biologic therapies, even in tertiary referral centers. It's Team Catharsis. Thank you all.
Okay, last but not least for this session, we have Nikit Kathiri, who's talking about the pros and cons of B-cell targeting therapy in IBD.
Apologies, I think there's been a missing file here.
Oh, it's not in this folder. Did you go to this? Yeah.
Hi, folks. My name is Nikith. I am an internal medicine resident at Mount Sinai. And for the last year or so, I have also been a member of the Mahendru Lab. In conjunction with my colleague Somya, who is a bioinformatician in our lab, we've been studying a syndrome called CAR-T enterocolitis. It's an emerging entity that's at the cross sections of B-cell targeting therapies as well as CAR-T therapies. And as Dr. Nurat this morning very eloquently described, these are really emerging therapies that have really significant therapeutic potential. But with emerging therapies, it's really important to be able to understand the potential adverse events, what happens when things don't go exactly as we intended, and what we can do to mitigate those type of symptoms. And that's really the basis of what I'm hoping to convey to you all today. So I'll start with a brief background. These studies have been mentioned very extensively in earlier presentations this morning, so I won't go into excruciating details. But just as a brief refresher, one study that really helped establish B cells and their role in the pathogenesis of IBD was a study from the Mahendru Lab in 2022. A couple of salient points that I'll review are the production of autoreactive autoantibodies related to alpha V beta 6 integrin that was observed in the inflamed ulcerative colitis tissue. And the second thing that's described in the graph over here is that there was an increase in gut homing plasmablasts in the peripheral circulation, specifically in the inflamed tissue related to the quiescent patient as well as the healthy controls. So we've established that B cells have a potential pathogenic role in ulcerative colitis. What Dr. Nurat really expanded on is provided some real practical evidence for the potential therapeutic benefits of targeting B cells. So just as a reminder of what he discussed, this was a case of a 21-year-old patient who was seriously resistant to multiple lines of therapy, 8 lines of therapy specifically, and underwent a CD19 targeting CAR-T therapy. And as you see from the images, there was significant improvement at just 85 days after CAR-T cell therapy. And as he showed months later that this was durable and this was quite significant, indicative of remission. When we're talking about CAR-T therapies, just to briefly review, these are autologous therapies where a patient's own T cells are collected and then introduced to a chimeric antigen receptor, which are then reinfused into the patient. And these have gotten increasingly more complex and refined. The CD19 targeting therapy described in the previous slide is one of the possible therapies, but the one that I'll be describing today that's really involved in the pathogenesis of CAR-T enterocolitis is a BCMA targeting CAR-T therapy, which is more specific for plasma cell markers, which is more specific for plasma cells. To introduce this clinical syndrome, I'll start with a case presentation of a representative patient that we've recruited to our cohort. This is a 74-year-old woman who has a history of multiple myeloma and underwent a BCMA-targeted CAR-T therapy as a 4th line of therapy. This is someone who's quite resistant to therapy. No significant inflammatory bowel history. There was a history of irritable bowel syndrome, but was not known to have a diagnosis of ulcerative colitis or Crohn's disease. She presented about 3 months after her CAR-T infusion with nausea, vomiting, abdominal pain, and multiple loose non-bloody bowel movements daily. These symptoms were so severe that she was required to have hospitalization. On review of her initial laboratory evaluation, there was a couple of things that really stood out to us. One of them was that the levels of immunoglobulin, specifically IgA, were undetectable in her blood, as well as the BCMA, soluble BCMA receptor that was also measured through her blood. Inflammatory markers were elevated, specifically ferritin, CRP, fecal calprotectin, and we couldn't really attribute to any of these presentations to her underlying myeloma, which showed to be in complete remission throughout the course of these GI symptoms that she was having. On infectious workup, nothing was found, no pathogen was isolated on the initial infectious workup. But when we look at our broader cohort, at this point, we've recruited about 10 patients with symptoms of CAR-T enterocolitis. We've noticed that actually 7 out of 10 of them have identified specific pathogens on their initial evaluation for their GI symptoms. So it brings up this idea that infectious pathogens might be a possible trigger to some of these symptoms. And unfortunately, there was only transient improvement with targeted antibiotics or empiric steroids. And that really brings us to looking a little bit further about what's actually going on in these patients. One of the ways we've done that is through endoscopy and histology. There are a couple of characteristic findings. I will say these are heterogeneous, but I will describe a few of them that we've observed in our patient population here. In the duodenum, you see that there's an appearance of this scalloped appearing mucosa, that's edematous. In the terminal ileum, you see this erythematous appearing mucosa. And then in the colon, most prominently, you see this vascular prominence. Now, these things can be heterogeneously noted throughout the small and large bowel that we've observed so far. But one thing that's important to note is that when you compare it to someone with ulcerative colitis, we don't see the frank ulceration, the obvious abnormalities that we do in other types of IBD. And when we look at these patients from a clinical path perspective, there's a couple of things that are observed. One being the absence of plasma cells, which correlates with in the blood, seeing that there's almost no production of IgA. And the second is a concerning increase in the level of apoptosis, apoptotic activity, as evidenced by increased apoptotic bodies in the histology. The reason we care about this syndrome is that it's associated with high morbidity and potential mortality. The patient that I just described to you has unfortunately had persistent symptoms for over a year now. These upper and lower GI symptoms have transiently improved, but not really completely resolved. And unfortunately, we've seen some objective measurements that really concern us. One of them here is the persistent downtrend in weight over the last year. This patient has lost over 30% of her body weight since her CAR T infusion. And that's correlated as well with inflammatory markers. You see, despite some transient improvements in fecal calprotectin, these markers elevated once again and suggest that there's an uncontrolled inflammatory process occurring. So that's from a clinical standpoint. When we delve a little bit deeper and do some immune profiling in these patients, there's a couple of salient points that I want to point out to you all. One of them is that we've confirmed that there's a near complete absence of plasma cells as well as B cells in these patients' intestinal mucosa. We've done that through flow cytometry, single cell transcriptomics. What I'm representing to you here is immunohistochemistry staining for CD20 positive B cells as well as MUM1 positive plasma cells. And we compare it to a normal volunteer who had never received CAR T therapy, who was not having any inflammatory GI conditions. You see in our enterocolitis cohort that there's almost no positive detection of these cells. The second thing I want to point out to you is that it would be incomplete to talk about CAR T therapy without discussing the T cell compartments of these patients' intestinal mucosa. And when we approach this from a single cell transcriptomic perspective, we've subclustered the patients in our cohorts T cells. And one thing that really stands out to us is this presence of cytotoxic T cell cluster. And the real important part of this is that when we compare our enterocolitis cohort to a normal volunteer cohort, which, as a reminder, never received any CAR T therapy, there's a statistically significant increase in the cytotoxic cells. The natural question here is, are these CAR T cells in this cluster of cytotoxic T cells? Meaning that, are we giving these patients a therapy that's directly contributing to direct cytotoxicity in their intestinal mucosa? And the answer, unfortunately, appears to be yes. And we've demonstrated that through single-cell transcriptomics, as well as immunohistochemistry staining. What I've shown you here is a staining of our same patient a few months after CAR T infusion. These orange-brown colored DAB positive staining suggests that these CAR Ts have infiltrated into the intestinal mucosa. And the really concerning part is that even up to a year, multiple years later, we're observing that these CAR T cells are maintaining in the intestinal mucosa after just one infusion, months or years later. So it's truly quite a concerning observation that we've observed so far. When we change how we look at our single cell data and look at it from a pathway perspective rather than a specific cluster perspective, there's a noted increase in the inflammatory pathways noted throughout all of the cell clusters we've observed. One of the things I've demonstrated here is some representative genes from that are associated with the JAK-STAT pathway. And as you can see, compared to our normal volunteer population, this is significant upregulation of these genes. This, while it's concerning, also introduces a possible therapeutic paradigm for us, where if we see this evidence of this upregulation, would we be able to combat it with something like a JAK inhibitor, upadacitinib as an example? And while this data is still under further investigation, we have some early signs that this is actually a viable therapeutic mechanism. So this is data from our same patient, our 74-year-old patient who had undergone upadacitinib therapy. And we see as soon as early as 4 to 6 weeks after therapy that there are early signs of clinical improvement. One, subjectively, she feels better. She has improvement in things like bloating and diarrheal symptoms. But objectively, we see that she's gained over 10 pounds in just 6 weeks since starting a JAK inhibitor. And we also see concordant that there's a decrease in their fecal calprotectin. So I want to emphasize that these are rather small sample sizes, but we have some encouraging data that suggests that we might have some real solutions for the things that we're observing in our patients. So to summarize, CAR T enterocolitis is an inflammatory syndrome occurring after BCMA targeting of CAR T therapy, and it's associated with high morbidity. One point is that there's near complete intestinal plasma cell and B cell depletion, creating a potential permissive environment which can be taken advantage of by infectious pathogens. There is a concerning observation of cytotoxic CAR T cell infiltration, as well as broad inflammatory pathoactivation, which we believe are contributing to the overall syndrome that is presenting. And really the main important point here is that we really need to do our homework on B cell depletion and CAR T therapies in order to be able to safely establish these as long-term, safe, efficacious therapies in an IBD population. So with that, these are multiple acknowledgements. I thank you all for listening.
Now all the speakers should come up for the question and answer session.
Thank you, all the speakers, for these excellent talks. My question is for Nikhil. Very important data. So you presented these data on one patient who had multiple myeloma refractory and underwent CAR T. Are you studying this in other patients with multiple myeloma who've undergone this therapy? And two, are you studying this in the context of CAR T for other indications? Do you think this kind of an enterocolitis would have a similar presentation and a similar phenotype, or it would be different?
It's a great question. There's evidence in CD19 directed CAR T therapies that this enterocolitis syndrome is not actually very well observed. And even when looking at BCMA specific CAR T therapies, we really see it in a specific product as well. So it's not all BCMA targeting therapies. So there is an idea that it is product specific as well. Although it's not entirely, we do see it in the other type of product as well. So it's in the early days and we can't be too sure. And I think that really highlights why we really need to do our research and our homework on all forms of these type of therapies.
I have a question for Maya and Monica. So you were showing how hard it is to find people with a healthy pouch as donor for the fecal transplant. Do you think it would also work with just healthy donor that doesn't have a pouch?
So no, I don't think it would work because I think all the studies that have been done to date have been done with patients who are healthy and don't have a pouch. And because the microbiome is so inherently different from those patients to patients with a pouch, the engraftment has been poor and we're not seeing sustained outcomes. So I think the novelty of our study was that we purposely chose a patient with ulcerative colitis who'd had surgery and had a sustainable, healthy pouch. I think the issue with finding the right donor is that so many of our patients with a healthy pouch just disappear into the wind and they never come back to the IBD center. So I think we just need to do a better job of finding them and having them come in. But we also don't need that many. I think part of what Monica's showing is that if you have a couple of really healthy patients that are sustained over time, then you can be precise about picking microbiota that you need to implement change. You think?
Yes, I think.
I have a question for Maya as well, and actually Monica. Why don't you take the microbiome from patients who have a pouch from not with IBD, meaning from polyposis? Because this could be the healthiest microbiome that you can think about. Because in patients with UC, the microbiome could be changed because of UC, you know, even though it's not inflamed. I don't know, for genetic reason and so on, and there are data about that. So maybe it would be even better to take the microbiome from patients who have a pouch for another non-IBD condition.
Yeah, that's a great point. I think that was actually originally our goal. When we originally envisioned the grant, we put that we would recruit patients with ulcerative colitis in a durably healthy pouch and patients with FAP in a durably healthy pouch. But it was near impossible finding patients with FAP without a pouch who were willing to come in and donate the stool that we needed. Part of it is that these patients don't have the same buy-in that patients with ulcerative colitis have. And so it was purely just an issue of finding those patients. The other thing that I'll draw your attention to is that over the last couple of years, there's been emerging data that patients with FAP actually have higher rates of pouchitis than we previously thought. Previously, it was thought to be around 10%, but the most recent data suggests that it could actually be as much as 60% of patients with FAP will get pouchitis. So I agree it would be a great donor. It was just a limitation of who we were able to recruit.
And I have a question for Nikit. At the end of this day, we heard Marcus with a positive impact of CAR-T and so on, and that now we are hearing your talk showing that we need to learn, and this is just the beginning. So how should we conduct studies in patients with IBD? Because what you are showing is a little bit scary, because especially if we can't get rid of these cells. I mean, I don't know. What do you think?
It is. And I think the real important, valuable data point that we don't have is a prospective study of CAR-Ts, specifically from GI indications. And that's something Dr. Nurat mentioned as well. I think it's probably underway, where we're looking at these patients before CAR-T therapy as well. And we're trying to find predictive markers, things that suggest that, and then also be able to get us a deeper understanding about exactly what's going on. Because right now our data is mostly observational and retrospective. And I think that's really the next step to really get a better idea of what's going on.
Ryan?
Yeah, I had a quick question for Rob. So the signatures you're showing are really fascinating, and it seems like they correlate really strongly with inflammation and predicting flares. And I was wondering, because you have a lot of data sets now, can you look at any of these? And I don't know if some of them the doctors were getting any kind of notification already. If you adjusted therapy, you see a signal on the wearable, you adjust therapy, what the outcomes were in those patients? Or, I mean, to me, you need to do like a COM trial with wearables. I think would be fascinating. But I don't know if you already have some observational data that can suggest that gives some rationale for that.
It's a good question. We haven't fed back any of the data to clinicians for feedback on it. It's a logistically more challenging study. It's a higher bar to get even IRB approval for that, because you're altering care with unapproved algorithms. But we haven't done that. And that's the next question, though, because the other thing that I didn't talk about is just because you can do these things and predict these things, does it actually impact care? But early identification of response and non-response, I think, would be the most interesting thing in the therapeutic area. So you're not hanging out for 8 weeks waiting for something to work. But hopefully soon.
Dr. Nade?
Yes, I also have a question for Nikit for the CAR-T. So coming from the opposite point of view of the efficacy of the CAR-T on the myeloma, which is sustained in this patient, usually those CAR-T disappear pretty quickly. So that suggests that there may be a reservoir of antigen-specific cells that somehow see that in the gut and maintain their presence. So have you shown first in that patient that indeed the plasma cell in the periphery is down, but what about in the tissue and any type of association?
Yeah, it's a great idea. We have, in that specific patient that I described, seen that there is a persistence of CAR-T cells in the peripheral blood. Now, when we look at other patients in our cohort, that's not always the case. We actually see that in the majority of these patients, these CAR-Ts are not detectable in the blood, but they are present in the intestinal mucosa. To really, I think, to get to the bottom of it as well, is that we need to do some study of their bone marrow as well to figure out that there's a unifying feature in the blood, a discordant feature in the intestinal mucosa. I think there's a third variable that we're not considering either, which is the bone marrow.
I think that wraps up this session, so we can go on to the break. But remember, everyone, come back. There's one more session after this. Oh, there's no break? Oh. Okay, we're just going on. Okay.
What did we just learn from Catharsis? Deep breath, everyone.
I am delighted to moderate this last section, which is disease pathogenesis part 2. Stay until the end. We have an amazing anchor group, so we're going to pass the baton along to them. First up is Inga Peter. Anti-inflammatory diet during pregnancy with Crohn's disease improves maternal and offspring microbiota composition and intestinal health.
Okay, great. Thank you so much for the invitation. In the next 10 minutes, I'll share with you unpublished data on our dietary intervention trial that was inspired by the fact that having a parent diagnosed with IBD prior to pregnancy is associated with a 6-fold increased risk of IBD in the offspring. And this risk is actually lower if a parent is diagnosed after the pregnancy. And the genetics alone doesn't fully explain this increased risk. And it's been now extensively shown in other diseases that maternal health during early life may significantly affect the development of the immune system and can influence the inflammatory processes later in life. And you can see on the bottom that if there are some factors that promote dysbiosis and they eventually lead to immune-mediated diseases in the purple, but factors such as natural delivery, breastfeeding, they lead to a healthy microbiome and a development of a healthy immune system. So in our prior work, we showed that pregnant mothers with IBD, denoted here in red, have significantly lower bacterial diversity throughout pregnancy compared to non-IBD peers, and it was mostly driven by pro-inflammatory bacteria that was enriched in IBD patients. And it was followed by a similar trend in their babies who had lower bacterial diversity based on 16S sequencing throughout the first couple of months. And it was a similar bacterial composition, mostly pro-inflammatory bacteria, similar to that of their mothers. And importantly, the trends of increased pro-inflammatory bacteria and depleted beneficial bacteria, especially bifidobacteria, persisted over the course of several months. Moreover, babies born to mothers with IBD have consistently had increased fecal calprotectin throughout at least first 3 years of life. So when we, in collaboration with Jeremiah Fay's group and Saurabh's group, we colonized germ-free mice with the stool of pregnant women with and without IBD and their babies. We demonstrated significant switches in their memory B cell compounds if they were colonized with the stool of babies born to mothers with IBD, and we saw it consistently across memory B cells, IgA class switched B cells in both colonic lamina propria and mesenteric lymph nodes. So that inspired a dietary trial to test whether restoring balance between beneficial and harmful bacteria during pregnancy may promote healthy nutrition and healthier bacterial composition in both mothers and babies. So we use IBD-8 or IBD anti-inflammatory diet that was derived from the specific carbohydrate diet and modified with current research on the human microbiome, and especially with the focus on pregnancy. And it involved 2 sites, Mount Sinai and the University of Massachusetts. So the study design included 3 arms. One arm was a Crohn's disease, pregnant women with Crohn's disease who agreed or chose to follow IBD-8 diet, Crohn's disease patients on habitual diet, and then control pregnant women with no diet. The trial started in the 3rd trimester of pregnancy and lasted 10 weeks, and the samples were collected at baseline following the intervention, and then at delivery and first 3 months, 6 months, and 12 months post pregnancy, and also extensive clinical data was collected with each sampling time point. So the maternal outcomes included dietary indices, microbiota diversity, and disease activity. And in the babies, we looked at microbiota diversity during the first year of life and calprotectin levels. So the diet mostly includes 4 major components: prebiotic foods such as oats, legumes, peas, nuts, bananas, etc. Probiotic foods like yogurts, kefir, and etc. Foods that were emphasized, beneficial fatty acids and nutrients, fruit, vegetables, and then foods to be avoided such as ultra-processed foods, sugars, and animal trans fats. So the composition of the cohort, we had close to 100 Crohn's disease patients and 100 healthy controls. Half of the patients chose to follow the diet. The age of the recruitment was in mid-30s. The majorities were white and also of high socioeconomic class. We assessed 4 major dietary indices. The first 2, healthy eating index and IBD-8 score, were estimated beneficial foods, whereas energy adjusted diet inflammatory index and NOVA scoring were measuring foods that were recommended to be avoided. Just a few words about the NOVA classification. Measures the amount of processed food. So NOVA 4 indicates the amount of ultra-processed foods. So what we found was that at baseline, which is here, you see less than 30 weeks, we saw that the majority of indices were the same across the intervention, across the study arms, except for IBD-8 and also the NOVA 4 scores. They were already more positive in women who chose to follow the diet, which actually made our goal to demonstrate the benefit of the diet more difficult, higher bar to meet. And nevertheless, following the diet, you can see that all 4 indices show significant differences with the demonstrating beneficial effect of the IBD diet in both compounds, increased beneficial components and decreased the foods to be avoided. We also demonstrated that the fecal calprotectin levels were lower, significantly lower in women who chose to follow the diet. That was the case at baseline and continued to be the case following the diet. The difference was that at the baseline, they still had a higher fecal calprotectin than controls, but following the diet, they were not significantly different. We also demonstrated that 12 out of 13 cases of flare were resolved in the dietary group, whereas the changes in the flare either being resolved or new flare were not improved in the non-diet group. Also, women who chose to follow the diet were less likely to give birth through C-section and more likely to breastfeed their babies. And also the proportion of participants in the breastfeeding group was much, much higher in the diet group compared to IBD no diet group. We show taxa sharing among the groups that before the intervention, the 22 different taxa were shared between the controls and the diet group, and this number was doubled following the diet, and the number of species shared between IBD diet, IBD no diet was substantially reduced. Very quickly, the fecal calprotectin levels at birth significantly correlated with maternal dietary indices. They were reversely correlated with adverse indices and positively correlated with beneficial indices. And also, I want to emphasize the particular bifidobacteria that was enriched in the microbiota of babies of mothers who followed the diet compared to no diet, which in the stool metabolomics data indicated that they were driven by the pathways associated with more active epithelial signaling, more active protein digestion, and better adaptability to environment and the diet. So to conclude, anti-inflammatory diet during pregnancy significantly improved overall dietary quality. IBD-8 was associated with reduced disease flares, lower rate of C-section, and a higher likelihood and longer duration of breastfeeding. IBD-8 also helped normalize gut microbiota composition in both mothers and babies, and especially increase the abundance of beneficial bifidobacteria in the babies. However, that said, the impact of IBD-8 on future IBD risk cannot be determined from these findings. And this, I want to acknowledge my team. So you see the pictures. The study was conceived with the help of Jean-Fred Colombel and Joanna Torres, and conducted by Tagyu Kim and Melissa Picker, Monsi, and there are other people listed here. Thank you so much.
Thank you so much for sharing that very cool data with us, Inga. Excited to introduce a friend, collaborator from dermatology, Ahuva Saisas. She'll speak about metastatic Crohn's disease.
So hello, everybody. Thank you for being here with me this afternoon. And so, as you heard, I'm Ahuva Saisas. My most important disclosure is that I'm a dermatologist. And what we're going to talk about today is metastatic Crohn's disease. But just as a brief introduction, we really think about inflammatory bowel disease as a systemic disease with a broad range of extraintestinal manifestations. Most commonly, this affects the joints, but followed by that, it's the skin. So the skin plays a really important role in the management of our patients. Up to 30% have been estimated to have an extraintestinal manifestation of the skin. And we can break them down into these different categories. Today, we're just going to focus on that specific manifestation subtype, which is metastatic Crohn's disease. But there's a lot of other skin disorders that can affect our patients, impact their day-to-day quality of life, and how we are really treating our patients and how we can optimize their care. While we don't understand what causes these extraintestinal manifestations, there have been different kind of theories and ways of trying to understand these better. So there could be translocation of bacteria, bacterial products, molecular mimicry. There can be dysregulation in metabolites. There can be systemic inflammation. And we're trying to learn more about this. And potentially this could also help us better understand the pathogenesis of Crohn's disease. And when we think about cutaneous Crohn's disease, and sorry that my slides got a little bit misaligned, but classically, you're going to see the same type of histology in the skin that you would see in the gut. So this is classically non-caseating granulomas, but you may not see those true granulomas in the skin. But the idea is that it's mirroring intestinal inflammation, and it can be broken down as contiguous or metastatic. Today, we're focusing on metastatic, so discontinuous from the gut. And about 70% of patients with metastatic Crohn's disease will have known Crohn's disease. Sometimes as dermatologists, we're the ones making the diagnosis of Crohn's disease from a diagnosis of metastatic Crohn's disease. There's a kind of wide variety of how this disease can present. Classically, we say it could be purple, red, nodules or plaques, but really often we're seeing ulcers, edema or swelling. There can be abscesses, fissures. And most commonly, this will present in the genital area. So if you're not looking at the patient's genitals, this could be missed. It tends to be also very often in the intertriginous areas, and that can be in the groin or in the axilla. But also commonly, we're seeing it in the oral area, in the face, or a facial Crohn's disease, but it really can occur anywhere. And often it's actually independent of luminal activity. Sometimes it will follow the disease course, but often it's independent. There was a recent Delphi consensus that really established diagnostic criteria. So I wanted to touch on this first. It included dermatologists, gastroenterologists, dermatopathologists, colorectal surgeons, so really everybody who would be managing these patients. And what's important to point out here is that you actually don't need histology to make a diagnosis. And something that I would urge people who are, managing people with Crohn's disease, whether you're the GI or another clinician, is to look out for these major criteria. Because by having just one major criteria, one minor criteria, and one of the minor criteria is having a diagnosis of IBD, you can make a diagnosis clinically of metastatic Crohn's disease. So those major features are going to be genital swelling, knife-like ulcers in the genital, inguinal, or intertriginous skin, and these lymphodematous changes of the genital skin. And the lymphodematous changes that's basically so much edema and there's dysfunction in the lymphatics that it creates these almost little like vesicles or little almost blister looking areas. And it's a lot of swelling from the lymphatic dysfunction. And we don't really understand what's causing that. That's something that we're actively trying to investigate. And that may help us learn again more about the pathogenesis of Crohn's disease. But in the meantime, we certainly want to manage this in our patients. We can improve their quality of life. For, the patients you're seeing here, it's really quite severe and striking. But a lot of the times it can be a lot more subtle. So we're going to go through some cases to try and help us kind of hone our skills of how to pick this up. But just to review the minor criteria then for the genital or other, meaning the non-facial lesions, this would be perianal skin tags, which if you're looking in the anal area, you're going to be seeing that very frequently in your Crohn's patients, genital fissuring, non-healing genital ulcers, and you would want to make sure that it's HSV negative, that there's no infectious etiology. But a biopsy suggestive of metastatic Crohn's disease would also be one of those criteria, but again, not necessary, and then a history of IBD. And then the other subtype of metastatic Crohn's disease, and this is what we consider to be oral Crohn's disease that's not contiguous. And so sometimes there's a little bit of a debate of is this metastatic or is this contiguous? But this would be just having a known diagnosis of Crohn's disease and then linear ulcers of the mouth, granulomatous cheilitis, which is a type of lip swelling that's really pretty persistent and fixed and typically is going to have granulomas on a biopsy, piostomatitis vegetans, sublingual soft tissue swelling, and these large oral aphthous ulcers. So we're going to take a look at some cases. This was a 24-year-old with Crohn's disease that was well controlled in vitalizumab. She had a history of HS or PG-like lesions that left some scarring, which now in retrospect was likely actually metastatic Crohn's disease because it can present very similarly. But you can see that she had some small areas of ulceration on the oral mucosa. She had this sort of faint but persistent erythematous plaque on the cutaneous lower lip. And if you look at her face, you can see that there's some significant swelling of the lower lip. When I first met her, I was asking, have you ever had any lip filler? Sometimes we see this kind of unintentionally in patients that might have had too much lip filler done. And you can see a little bit of swelling in the skin as well. And on a biopsy, it did confirm that she had cutaneous Crohn's. So we were able to add on another systemic therapy to address that. This is a 23-year-old who has Crohn's disease, spondyloarthropathy, and EOE. And she was on upadacitinib 30 milligrams, was relatively well controlled from the gut activity side, but you can see those deep linear ulcerations in the mouth, and you can see some pretty significant edema again in the lower face. And so what we were able to do for her was actually introduce the 45 milligrams for reinduction, and that was able to resolve her symptoms. And this is a 13-year-old with Crohn's disease that was inadequately controlled with the subtherapeutic level of adalimumab, again, that deep linear ulceration. And you can see some pretty significant edema on the right lower face compared to the left. And this was a newer patient, so I don't have our outcomes just yet. And this is a patient where it can be a little bit more subtle. And then again, I apologize, we have a lot of genital photos here because of the where this disease tends to present. So if you look at the photo up here on, I guess it'll be on your left, it is a lot more subtle. And she had said, well, you know what, sometimes it can get a little bit more red, a little bit more swollen. And you can see that on one side, so right there on her left, it's a little bit more swollen looking there, but it's somewhat subtle. So you might not pick it up. But then when she came back about a month later, you can see now that that left side has a lot more redness and a lot more swelling. And this is still, more of a subtle finding where you might miss out on it. And if you look up close, there actually are some of those little like vesicles is what we call it, but those little kind of bumps or kind of cobblestoney appearance. So sometimes it can even look like HPV or warts, but that's actually from the lymphatics being dilated. And then this is a 32-year-old male who had perianal fistulizing Crohn's disease. He was on risankizumab. His GI disease was not perfectly controlled, but that really wasn't the issue for him. It was this very significant scrotal edema that was very bothersome for him. And here's another patient that I saw who was actually off systemic therapy because he had been treated surgically outside of the country. But what he had come in for was this very significant penile edema, which was very impactful on his quality of life. So I don't think anyone would miss that this is something of significance. But the point is to really kind of recognize that range of how it can present. And then this is a case of a patient who came to see me who had been treated with multiple vulvar surgeries by a surgical oncologist on the West Coast. And we had talked about how she hadn't had a workup, but we checked a fecal calprotectin, which was elevated. The biopsy showed those dilated lymphatics. And then when we did her endoscopy, we did see that she had Crohn's disease. So sometimes, again, we're the dermatologist making the diagnosis. But I think there needs to be increased awareness among dermatologists, GIs, everybody treating these patients. So when we think about the management of metastatic Crohn's disease, we can do topical steroids and other anti-inflammatory topicals, intralesional steroids. Sometimes I'll treat with cryosurgery, and that's something that we can do periodically, and it does give some good temporary improvement. Metronidazole has been reported in the literature, but to be honest, not the most effective, but really we're adding systemic therapies that are used for IBD, and that's even if the IBD is well controlled from a luminal perspective, but we can get better patient control. And this was an interesting patient that we saw that had very significant lymphatic changes. Again, you can see that almost looks wart-like on the vulva. And we were able to manage her with hepatocytinib. But what was so significant about this case was that she wanted to, get pregnant. And basically she was not able to because of the extent of disease. So by adding on an extra systemic therapy, we were able to control her vulvar disease to the point that she was able to conceive and just delivered a healthy baby girl. So very impactful for our patients. And then I wanted to touch on the importance of differentiating perianal Crohn's disease and hidradenitis suppurativa. This is something that I see very often in my practice. So for those of you who are not familiar with HS, this can present very similarly to Crohn's. There's tunnels under the skin, which you can see here. You're having a tunnel where there's this tract that's forming from the skin. It's not connecting like it does in Crohn's disease where you're connecting to the gut. Although sometimes we can see fistulas, it's less common. So in HS, we tend to see comedones and tunnels. However, in Crohn's disease, there's true fistulas, there's those knife-like fissures, the anal skin tags, more significant genital edema and abscesses to help you try and differentiate. And this is a case of a patient that I saw recently who has very severe hidradenitis, but when I was examining him, he was not responding to his current systemic therapy. We see very significant genital edema and then anal skin tag. So we wanted to have him have more of a thorough workup because we don't want to miss Crohn's disease. So then I just wanted to highlight that we have an IBD dermatology clinic, and it's run by myself and Dr. Spencer, where we see patients together. It can be a second opinion. It can be just to kind of optimize the care of their skin disease, but we see a range of conditions and we're happy to help with anyone that needs it. So thank you, everybody. And I just wanted to, again, highlight the importance of looking at the skin and thinking about how metastatic Crohn's disease may be a window into us better understanding Crohn's. Thank you.
Thank you, Ahuva. Next up, looking forward to Alexandra Livanos's talk on anti-alpha V beta 6 autoantibodies, defining a distinct molecular endotype in colonic Crohn's disease.
Thank you.
See if I can.
Okay, great. So today I'm going to tell you a little bit about integrin alpha V beta 6 antibodies and how they define a distinct molecular endotype in chronic Crohn's disease. And so first, as a brief outline, I'll provide some background about how biomarkers, specifically antibodies, can be used for understanding disease mechanisms and guiding eventually therapeutic selection. And then specifically on our data about how anti-integrin alpha V beta 6 antibodies define a clinically and biologically distinct endotype. And so just as a framework of thinking, really what we're trying to understand is mechanisms that transfer normal, healthy intestinal tissue to disease tissue, and what are the defining molecular features here in this preclinical phase, and then also what are the molecular underpinnings for why we have heterogeneous disease trajectories. And to me, both of these could be related to different biomarkers and antibodies. And so really the question it brings us to is, can we use biomarkers to identify disease mechanisms and enable biologically informed therapeutic selection to improve patient outcomes? And so an example of this comes from the literature of anti-IL-10 antibodies. And so what was presented in this paper in the New England Journal of Medicine in 2024 was that there is identification of IL-10 antibodies that neutralized IL-10 that are shown by this red line here. And interestingly, it phenocopies inborn IL-10 variants. And then they successfully treated this patient with a B-cell targeting therapy, rituximab. And you can see that the antibodies were high levels before the treatment, and then it went away. And similarly, the patient improved with the treatment. So really the idea is, can we apply this framework to other disease-associated antibodies, including anti-alpha V beta 6 antibodies? And importantly, IL-10 antibodies are only present in about 2 to 3% of patients, while alpha V beta 6 antibodies have been identified in a much higher percent. In ulcerative colitis, it ranges around 60 to 90%, and in chronic Crohn's disease, it's around 40 to 50%. So what is integrin alpha V beta 6? Well, Matthias already introduced some of the key features here. And the idea is that antibodies either block this function or recruit different inflammatory cells, resulting in intestinal inflammation. And really, I just want to highlight this paper here about the importance of this pathway. And this is a study from Alexia Muse's group where they identified variants in the integrin alpha V that were associated with patients with colitis as well as other manifestations. And these variants resulted in a functional deficiency in the integrin alpha V and dysregulation of the TGF-beta signaling pathway and resulted in colitis. So really the question is, do these antibodies identify a mechanistically and clinically relevant subgroup of colonic IBD? I'm not going to show the clinical data here because that's been reviewed previously, but really just to remind you again that these antibodies are present in patients with colonic IBD, either ulcerative colitis or colonic Crohn's disease, and we saw them present before the diagnosis. So this is a framework of how I'm thinking about this is we have how we studied this, we have antibody positive patients and antibody negative patients, and those patients within each group can be divided into those that have active inflammation and those that have inactive inflammation, and then you have healthy controls. And to study this, we used various different methodologies, including bulk RNA sequencing, single-cell transcriptomics, spatial transcriptomics, flow cytometry, and eventually in future directions, we're going to be using intestinal organoids. So really one of the first questions was, and this goes back to a concept that colonic IBD or the colonic tissue is different than ileal tissue. And we asked, is the integrin expression different in these two tissues? And this is using bulk RNA sequencing from the MSCCR cohort. And what you can see is very clearly that both subunits of this integrin heterodimer are more highly expressed in the colon compared to the ileum. And then we looked on single cell sequencing using 3 healthy controls where we had matched terminal ileum and colon to define the epithelial subtypes that express the integrin itself. And what you could see is that the integrin expression seems to be mostly isolated to certain types of epithelial cells. So cluster 7, which is our goblet cells, also showed here. Cluster 11, which is the best for enterocytes, a little bit in the tough cells. And then cluster 8, which is the absorptive enterocytes that were more coming from the colon. And this is in contrast to cluster 4, where you see very little expression of this integrin, which is the more small intestinal absorptive enterocytes. So this just showed that the colon and ileum, again, are not the same, which was already known, but that the integrin expression itself is differing between these tissues, which may in part explain some of the colonic predominance of these antibodies targeting this integrin. Next, we wanted to ask the question is, what are the transcriptomic differences between those that have antibodies versus those that do not? Here we use Crohn's disease inflamed tissue, so they're all inflamed tissue, and we looked at colonic CD where we have 47% positivity. So we had a pretty good matching of patients who have antibody and those that don't. Importantly, the SES-CDs for these two groups were similar. So not all of these differences can be explained by inflammatory or endoscopic inflammation alone. And what we found is that their pathways involved or different between these two groups involved three major groups: epithelial cell signaling. One of the pathways is O-linked glycosylation of mucins and a lot of the mucin genes themselves. There's epithelial signaling with bacteria, which is highlighted by this red square. We have TGF-beta signaling, which again goes back to the fact that this integrin is an important activator of TGF-beta. And then we see pathways in the immune signaling. I'm just going to show very few of these more deeply because of time constraints, but really just to point out in the epithelial inflammatory signaling, I want to point out the genes DUX2 and DUXA2, which I'll get back to further later, which are microbial sensors, as well as CXCL8, which is an important neutrophil chemoattractant, which goes along with the neutrophil degranulation pathway that we're also seeing increased. And just pointing out that OSM is also increased in these patients, which is a known association with resistance to TNF therapy and ulcerative colitis. To dig in a little bit more deeper in this data, we performed single-cell spatial transcriptomics using the COSMIC panel with Dr. Paramir Delai. We had 5 patients that were antibody positive and 4 patients that were antibody negative. One of the unique parts of this platform is that you have protein markers as well as transcript probes. And so you can divide the tissue very nicely into epithelial compartment, which is marked by pan-CK, and then immune or lamina propria by CD45. And then here I'm just showing by red dots the integrin expression, which you can see nicely in the epithelium. And then you can also see that it forms these different clusters that seem to be associated with CD68 myeloid cells. And we'll get to that further. I'm just going to show you one slide or 2 slides on this data for the purpose of time, but essentially you can have we had slides coming from antibody positive patients and antibody negative patients, and then you can divide cells into integrin negative cells or integrin positive cells. And what I want to show here is that the gene expression in an integrin positive cell from an antibody positive patient first is different than an integrin negative cell. But more importantly is that it's also different than an integrin positive cell coming from an antibody negative patient. And similar genes come up here as came with our bulk RNA sequencing, DUX2 being one of the major ones, which is shown here, but also genes related to goblet cell function and goblet cells like tryptophan factors. And what this really suggests is that the transcriptional profile in a integrin cell, expressing cell, which is a target of these antibodies, is being altered in people who have these autoantibodies. Really, without providing direct experimental evidence, provides suggestion that these antibodies are binding to these cells and inducing a new transcriptional profile. We next performed co-localization analysis with these integrin positive epithelium, and what we saw was in the antibody positive patients, we see co-localization with 3 major cell types: neutrophils, NK cells, and macrophages. And if you remember, these are the 3 key cell types that have Fc receptors that allow them to bind to IgG antibodies and induce different inflammatory signaling, phagocytosis, and cytotoxicity, providing a potential mechanism by which these antibodies may be mediating damage to integrin positive epithelium. I'm not going to go into this details because Matthias already presented some of this, but looking specifically in this cohort, which is Crohn's disease, inflamed tissue, again, we find on flow cytometry providing further validation that we have an increased neutrophils infiltrating this tissue and specifically an increase in the CD177 activated neutrophils going along with our spatial transcriptomics and our bulk RNA sequencing. One last feature that we looked at was crypt abscess, which is a pathogenic finding that's suggestive of neutrophil-mediated epithelial or crypt damage, and we had it scored by one of our pathologists. We had 44 patients here, 267 slides that we quantified crypt abscesses, and we also quantified the Nancy histologic index. And what we found is that the number of crypt abscess was higher in patients that had antibodies versus those that didn't. And if we looked at it as at odds, someone who has antibodies is 6.8 times more likely to have a crypt abscess versus those that are antibody negative. And this relationship remained true and significant when we adjusted for Nancy histologic index, suggesting that this is not only activity, but actually showing maybe a distinct pathway that is present in antibody-mediated disease. So this is a little schematic that I've put together of a proposed model of what's going on. That the integrin itself is expressed on intestinal epithelial cells, which is shown here, as well as goblet cells. It may be resulting in a dysregulation in goblet cell biology. This is to be determined, and potentially increasing bacterial epithelial contact, driving some of these inflammatory signals. This is sort of left in light gray because we still need to determine this, but we do see this increase in DUX2 expression and CXCL8, which is likely leading to neutrophil recruitment and potentially degranulation. Then on the neutrophil side, they can be binding the antibody bound to the epithelial cells via the Fc receptor and further result in tissue damage and remodeling. And finally, the antibody may perturb TGF-beta signaling, phenocopying partially the integrin alpha V deficiency that's seen as a variant associated with colitis. So with that, I'll just conclude that these antibodies define a biologically distinct IBD endotype with potential implications for therapeutic targeting. Future work will define the direct pathogenic mechanisms of anti-alpha V beta 6 mediated disease and evaluate therapeutic targeted strategies in this molecular distinct patient subtype. And really just going into how our current clinical anatomic based classification of IBD is insufficient. So this is really moving towards a more mechanistic based molecular classification. So with that, I'll thank everyone in the Mahandro lab and Sora Mahandro, Matthias, who helped with some of the flow cytometry data, and Jean-Fred for all the support and all of the funding. Thank you.
Thank you, Ali. Last but not least, Ryan Ungaro, the Chapman Lecture. Who, for those of you who didn't know, Dr. Chapman, Mark Chapman, he was a giant. And
keep going.
Giant in many respects, like literally tall and big football player type, but also a giant in our clinic with his patients and teaching fellows. I think we all have stories to tell about Mark, and also a giant in his note writing because he wrote in all caps.
That is true. And we've got a couple pictures of Mark. It's a real honor to be giving the Mark Chapman lecture. I think he was a partner for many years with Dan Present, who was a giant in our field, pioneering 6MP, early infliximab studies, et cetera, et cetera. Mark was at the forefront of advancing IBD care in his own way. I think he was beloved by all of us. He was a gregarious character. He was a cantankerous character, and I mean that in a fondest way. And encyclopedic knowledge of everything in GI, from GI physiology to IBD, et cetera. If you want some other stories about Mark Chapman, I'm happy to tell you them offline afterwards. And we love and miss him. And he was always the life of the party, as you can see, with his middle picture there, holding his martini glasses. So with that, I know I'm the last thing standing between you and going home. So I'd like to thank the invitation for giving a talk in Mark's honor. And so I'm going to be talking about IBD prediction and prevention. The future is here. I was talking with Sarah before that when I hear this type of title, I think of the movie Back to the Future and Doc Brown. And I really want to make a slide. I would think of Doc Brown as John Fred, if you know the movie. And he's like, it's, look, we got to go back to the past, like with lymphatics, and now we're going to the future with IBD prevention. So this is meant to be a bit of a higher level, overview talk of all the work that, I've been fortunate to be involved with and many here in the audience. I'd like to jump in right away and talk about why do we need IBD prevention and prediction and prevention. I don't think this is something that, is a mystery to this audience, that IBD is a chronic disease that has a huge burden on people, strikes them in the prime of their youth. Typically, multiple therapies and talks about this just fail to achieve remission effectively for many of our patients. And this is a disease that's rising in incidence across the world, rising in children across the world. It's been shown by many studies, including some by Monsi and others here. And prevalence is rising, and likely more than 1% by the year 2030. So this is a huge burden, and we have to figure out ways to get ahead of it. And we know now from years of research that IBD begins years before diagnosis. And this is a classic obligatory slide to show in any IBD prediction prevention talk from Joanna Torres, where we have patients with genetic predisposition, accumulation of environmental factors years before someone's diagnosed. And there are likely phases from 2 to 6 years before someone's diagnosed where you can detect subclinical inflammation or other changes in biomarkers before someone even has their first symptom of abdominal pain, diarrhea, blood in the stool, etc. So we know that this is something that's brewing. So we may have a window to actually intercede and delay the onset or prevent the onset of IBD. And we've had multiple different studies, prospective studies, retrospective studies that have highlighted multiple biomarkers and alterations years before people are diagnosed with IBD. I think some of the seminal ones here are the GEM cohort of first-degree relatives in Canada, the RTP, Road to Prevention cohort here at Mount Sinai, meconium, which you heard a lovely talk about already from Inga. Retrospective, multiple cohorts, predicts in Denmark, you already heard about. The predicts Department of Defense Serum Repository, which we're fortunate to have a partnership with the Department of Defense and led here, started by Jean Fred, which is military recruits in the United States with samples collected serially over time. And we've learned a lot from all of these studies where multiple proteomics, autoantibodies, metabolomic changes, exposomic changes, glycomics, multiple different biomarkers that are perturbed years before diagnosis. And so what are some of the general things that we've learned from these biomarker studies over the years in the preclinical phase? And this is a nice review actually from Nick Powell in Gut. And things that are common themes based on the biomarkers that are popping up: disordered chemotaxis of various cell types from trafficking to the gut, dysregulated immune interactions, interferon-driven chemotaxis, monocyte, phagocyte lymphocyte dysregulation. Many autoantibodies have been identified as well. You heard a talk just now by Ali and earlier anti-GM-CSF talk by Sasha, which is also present preclinical in Crohn's disease. Extracellular matrix remodeling and tissue dysregulation has also been identified based on these studies. And also what we've noticed as well are increases in certain exposures, pesticides, toxins, years before someone's diagnosed. There's a wealth of pathways that have been identified now using these preclinical cohorts. And so our understanding of what's going on years before someone's diagnosed has been increasing substantially. And another thing to highlight here is that these studies have also confirmed for us, I think, things that we've already, suspected and we see in our day-to-day practice about the heterogeneity of disease, that we see specific endotypes of disease even years before someone's diagnosed, distinct biomarker profiles that are associated with distinct disease types at diagnosis. So ASCA and GM-CSF positivity associated with ileal and complicated Crohn's disease, and anti-V alpha beta 6 antibodies with colonic IBD. So we've learned a lot about IBD, and that's in a quick snapshot. All these biomarker studies I would take a long time to try to really give a synopsis about. But based on this, are we ready for IBD prediction and prevention? Is this something that we can realize in the near term? And I think this was a review that we did with a talented visiting research fellow from Portugal, Sergio Bronze, where we identified kind of 4 key steps that we need to be working on to get IBD prediction and prevention ready for prime time. The first is looking at these biomarkers to try to understand, can we actually use them to predict who is at high risk for developing IBD? The second is then understanding if people who are at risk for IBD, does this even matter to them? Is this something that they are interested in? And what are their preferences related to this? Third would then be setting up the infrastructure to be able to identify people, screen them, and intervene potentially. And then last is then disease prevention trials. So I'm going to give an overview of these 4 things, and I think we've actually made a lot of advances in each of these areas. And I don't think anything is we're nearing this era now, I think, of prediction and prevention, and it's going to come, I think, sooner than we think. So first, validation and integration of biomarkers to predict the onset of IBD. And I'm a big baseball fan, and so just to quote Yogi Berra, it's tough to make predictions, especially about the future. And so this is something that I think is a very tall order when you think about trying to prediction in anything, certainly prediction of onset of disease. But we do have a roadmap with type 1 diabetes. And type 1 diabetes is really, they've redefined their disease into different stages where you have pre-stage 1, stage 1, stage 2. And what we think of as type 1 diabetes is really stage 3, where someone's actually diagnosed and needs insulin and has symptoms from type 1 diabetes. And what they've been able to do over years of research is show that autoantibodies are present years before someone's diagnosed, and they can identify certain sets of autoantibodies being present as associated with a risk of progression, 50% progression to type 1 diabetes within 5 years. And then once you have dysglycemia, so you have some early changes in your glycemic index and your glucose tolerance, these people are at risk, 75% risk within 2 years. And this has led to formal screening, multiple clinics throughout the United States and internationally. And now actually they have an FDA-approved therapy for prevention of type 1 diabetes called teplizumab. And so this is the roadmap we want to follow in terms of predicting who's going to develop IBD and trying to get tools that can be as accurate as what they have in type 1 diabetes. We may not be able to get there perfectly, but if we can get close to this, I think this is doable. But as I said, prediction is difficult, and this is some work from the Predict group, Alex Sazrov's from Denmark. And I think something that we have to keep in mind in all these studies, we typically are looking on the left here at case control studies where you have a balance of cases and controls, where it's a 50-50 balance. And AUC alone is not the only factor that determines how well a prediction tool is going to work. You need to think about what is disease prevalence in your population you're looking at, because that's going to inform your positive predictive value. So if you have a positive test, how likely is it it's a true positive? And as you go into the general population and first degree relatives, the general population, you actually have a really low positive disease prevalence, which even with an AUC of 0.9, you have a very low true positive rate. And most true positives, most positive tests might be false positives. But if you go into higher prevalence populations like first degree relatives, those numbers increase. And you can get a positive predictive value now into 12+%, which is decent, but still not great. And so effective prediction is going to require looking at an enriched population, so likely first degree relatives, and then you applying these tools that we know for biomarkers, honing these biomarker tools, and then identifying at-risk patients and looking at this right tail of the at-risk population. So you want to identify people at risk, but then look at the highest risk individuals within that overall enriched risk of people. And so here is a modeling exercise done by the Predict group where you can see if you look at the highest percentile risk populations within first degree relatives, you can enrich for 15, 20+% rates of positive predictive value. And this also comes into play when you're thinking about a prevention trial where the percentage of risk, if you identify people who are in the top 10% risk, top 1% risk, that you need to then use that to combine that with your intervention efficacy to inform your sample size for a prevention trial. So for example, if you have an 100% efficacy therapy, something that can completely block the onset of IBD. If you have a lower risk prevalence group, you still need to get 135 patients into your trial. So you need to take into account your prevalence of the disease, the predictive capacity of your tool and the efficacy of the intervention in order to have an effective prevention trial. So how close are we to developing tools for disease prevention and prediction? And so this is from the GEM cohort. This is, I think, familiar to many people here. This is a first-degree relative cohort from Canada, patients with Crohn's disease, and they have stool collected from years before diagnosis, and they looked at their calprotectin, microbiome score, and intestinal permeability to generate a integrative risk score for who is most likely to develop Crohn's disease over time. And you can see they had a good C index or AUC of 0.8 in both a North American testing cohort and in a external validation cohort in Israel. And I think the most important concept here is that they then looked at this right tail of that risk group. So they looked at the top quartile. And when they looked at the top quartile, they can enrich then for people who are 5 to 10 times more likely to develop Crohn's disease. And so I think our tools for screening people for being at risk for Crohn's disease, for closer monitoring and potential interventions, we need to take this into account where we're looking at that higher risk group within the at-risk population. So this right tail, top third, top fourth quartile. And that was a stool-based test that I just showed you. And something we've been working on with Pollock, who you heard from earlier, and Francesca Petralia, is a blood-based version of this. Can we use a blood risk, blood proteomics, blood biomarkers, because it'd be more easily scalable, easier to do in the clinic, potentially than stool. We can discuss that later, Jeremiah, if that's true or not. And is using the Predicts cohort, we developed a tool that's 10 biomarkers, 10 proteins that is associated with developing Crohn's within the next 2 years. And we looked at the shorter time frame because we think this is where you want the tool to be enriched to potentially offer an intervention to someone and to enroll them in a prevention trial where you have events enriched for a short-term intervention. And so here you can see that AUC of 0.87 in Predicts, and that fourth quartile of risk, you have an incidence of 60%. And this is within the Predicts cohort, that military cohort. And actually, we then applied this risk score in 2 external cohorts. One, the UK Biobank, which is an average risk population. And we saw, again, that fourth quartile perform similarly with a 60% incidence. And then also the GEM cohort, which is first-degree relative cohort. And again, 60% incidence. So this is something we think we're moving closer to having a prediction tool that may be able to be used to enrich for clinical trials to look at disease prevention. So if we do come up with a perfect tool for, or a better tool for IBD prediction, what do patients with IBD think? And this was a US-based survey through the Crohn's Colitis Foundation that they partnered with a number of people here and others around the country to ask patients and also first-degree relatives and parents of children at risk of IBD, what would they be willing to do? And the vast majority of them are willing to take a test. So over 90% would be willing to take a test and know their risk. Preferably a saliva or a blood test, and then stool is also there as well. And then they were asked about what types of interventions would they want. And the top things, not surprisingly, are lifestyle modifications, physical exercise, diet, probiotics. People were, to some degree, willing to consider doing medications like oral immunosuppressives, even subcutaneous IV immunosuppressives. But I think something to take into account here as well is that this is in more of a hypothetical situation where they're not presented directly with their own risk. So I think some of these preferences for what people will be willing to do may change if they have their own personal risk profile in front of them. But generally, when you look at surveys from the United States, and also before this was a survey in Europe, people are interested in this. Family members of people with IBD are interested in this idea, willing to take a test to understand their risk and potentially do a prevention intervention. Next, we need to think about setting up the infrastructure to screen and test individuals who are at high risk for IBD. And to do this, we recently launched at Mount Sinai just a few months ago. We think it's the world's first IBD prevention clinic. And this is really, under the guidance of Marla and Jean-Fred and Lizzie Spencer, who I don't think unfortunately was not here today, has really been critical in pushing this. And essentially, this is something that we're offering for first-degree relatives of patients with IBD. Patients come in, they meet with our coordinator, Elizabeth, who's here, I believe, who's done a great job organizing all of this, where they are enrolled in a parallel research registry. They undergo screening with
clinical symptoms by the red flags for IBD. So certain clinical symptoms that would raise a flag that you should be tested for IBD, you should be undergoing a workup. They get a calprotectin and they get an intestinal ultrasound. Then they also review with us general things that we have seen are associated with decreased and increased risk of IBD. Generally things that are healthy overall, Mediterranean diet, limiting smoke exposure, limiting exposure to certain pesticides, et cetera. And then we feed back the results to them, and then their follow-up is determined based on the results. So if they had a elevated level of calpro, they come back sooner. If everything's normal, they come back in 2 years. And so as I mentioned, we just started recently, so we're still early days. We have about 14 people who have come so far. I think a couple of interesting things to mention here is that it's primarily kids, mostly siblings, parents bringing in siblings of children with IBD, or the mom or dad has IBD and they're bringing in their kids. We do have a handful of teenagers, but it's still early days, and it's also because of internal referrals. And the majority, though, you can see are Ashkenazi Jewish, relatively, well off. And interestingly, a majority of them also are enrolled in other research studies. So I think it's giving us some clue here that, okay, looking to people who are their family members are already engaged in research, approaching them about potentially coming and engaging in this in the prevention clinic. We actually had 2 people who had abnormal findings. One person who had persistently elevated calprotectin, and after a lot of urging is now getting a capsule endoscopy, which I believe is happening this week. And then a second person who had a very mild increase in blood flow to the ileum, which was suggestive of some potentially mild inflammation, similarly also going for a capsule endoscopy as well. So we think, that we're going to need this type of infrastructure to be able to enroll patients, monitor them, and ultimately do disease prevention trials. And so lastly, I'd like to just end on what do we have so far about disease prevention trials in IBD. You heard about one of them already, the MELODY trial, and just some considerations. So first, who is the natural population to go after? I think it makes sense, first-degree relatives. We know that statistical modeling I was showing you before, you want to enrich your population, the prevalence, pre-test prevalence, to increase the performance of your testing. And also, importantly, I think first-degree relatives, they see the impact of the disease. They know the impact of the disease, so they're likely going to be more engaged and willing to do the testing and potential interventions. What should be the intervention? I think at this point, it's take your pick. Of any multiple things that have been associated with disease onset in IBD. Could it be a dietary, microbiome-based approach, glycan supplementation, something that can enhance the tight junction, the barrier function, potentially vaccination against certain types of bacteria or viruses associated with onset of IBD, or immunotherapy. And I think the type of intervention will likely depend on what stage pre-diagnosis you are. And this was something that came out of the PROMISE Consortium, where you think about the general population and population at elevated risk being first-degree relatives. And if you have no biomarkers of risk, you may be years away from diagnosis. And in that situation, this is where maybe approaches around lifestyle modification, altering your environment, this may be more attractive if you're not in the near term developing IBD. Whereas patients who are closer to diagnosis, and we would argue probably 2 to 3 years within diagnosis, and maybe even having what we would consider silent Crohn's, that they're at risk for developing full-blown Crohn's, and they have some abnormal ultrasound findings, abnormal video capsule findings. These are the patients where you may be more inclined to offer them a drug or other therapeutic intervention to try to decrease the risk of advancing to overt Crohn's disease. So there's a number of ongoing trials. I'll highlight 2 of them right now. You already heard about the MELODY trial, and the first one to highlight is the PIONEER trial. And this was just presented at ECHO recently. It was done in Israel. They took first-degree relatives from the GEM cohort, and they looked at their fecal calprotectin. And patients who had an elevated fecal calprotectin above 70, they repeated it, and if they were still elevated, they then did a pill camera to rule out patients with more overt Crohn's disease. And if they didn't have overt Crohn's disease, then they randomized them into a crossover study where you had
half patients getting habitual diet, like a nice American style diet, and the other half getting this tasty and healthy diet, which is generally a Mediterranean style diet, healthy diet, et cetera. And then they would cross over. And they use some statistical modeling as well to estimate how much of an impact the diet had. And the primary outcome in this case was not disease onset, but was changes in fecal calprotectin as a surrogate marker, because other studies have shown that elevated calprotectin is associated with future risk of IBD. And here, this is just to show you that they screened over 300 subjects. Roughly 20% of them, 25% of them had an elevated calprotectin that was persistently elevated. And of those, they saw about 9 of this, the 42, actually 20% had what they considered pre-symptomatic Crohn's disease, and the rest were offered randomization into this trial. And just to point out here, this is showing that the groups, the randomization is a relatively small trial, about 30 people, habitual diet versus tasty diet, well balanced. And actually, a majority of them did have what was considered non-specific mucosal changes. So this is essentially some erythema, et cetera, that may be signs of some early mucosal inflammation. And what they saw was that the people who were randomized to the tasty and healthy diet did have a decrease in their calprotectin, which then went back up when they went back to a habitual diet, westernized diet, whereas the calprotectin stayed relatively constant in those who first had habitual diet and then decreased when they went to this tasty and healthy diet. And they calculated it was about a 37% reduction in calprotectin if you had this tasty and healthy diet versus habitual diet. So I think very intriguing, very interesting. I think this is something that, whether this is going to translate to decreased future Crohn's disease risk and the durability of these changes is something that is still left for question. And just to end, the next, most ambitious thing ongoing right now is the Intercept Consortium. This is a large European Commission, European Union sponsored study that is looking to recruit 10,000 first-degree relatives across Europe, then screening these patients with serum biomarkers based on data from the PROMISE Consortium I already mentioned before, as well as within European cohorts, and then identifying the highest risk patients and randomizing them into a clinical trial with vedolizumab or placebo. So these are patients that have elevated risk score based on blood biomarkers, plus have 2 calprotectin elevations in a row. And they will get either sub-Q vedo or placebo and followed for 2 years with the hard outcome of time to Crohn's disease development. So this is the most ambitious trial ongoing right now that we obviously eagerly await to see the results of this for potential prevention intervention. So the vision right now is we were going to have a population to monitor, likely first-degree relatives at first, but maybe we're on the cusp of also potentially in more general population identifying patients based on polygenic risk scores, et cetera, maybe multiple immune-mediated disease prediction models, doing some sort of screening test like a blood biomarker. If you're low risk, continue as is. But if you're higher risk, depending on your risk, if you're more distant risk, maybe a less intensive intervention, lifestyle modifications, et cetera. If you're near-term risk, going into a prevention trial. So with that, I'd just like to acknowledge all the people involved in all the research I showed, the Predicts Consortium, Intercept, and PROMISE, and thank you for your attention.
We have a few minutes for questions if our awesome presenters could come back up. Thank you so much, guys. Ryan, come back. So it was nice to end on some hope for our friends, and maybe those meconium study patients will one day get real prevention, and the foundational work from Ali, and also this huge reminder to look at people's skin. I'm always reminding people to look at people's butts, but we'll add entire skin to that from Ahuva's talk. Questions?
Yes, thank you for the talks. I have a question for Ryan. So how many newly diagnosed patients are actually first-degree relatives? Like how many do we lose in this at-risk population if you define them as specifically?
So that's the thing, is that first-degree relatives are at risk, but the risk, and this is actually something in the prevention clinic that's in our script for it, is that the majority of people who are first-degree relatives will not develop IBD. The majority of people, when they're diagnosed, actually have no family history, but you have about a 5 to 10% risk depending on number of family members, et cetera. It goes up if you have multiplex families, and even higher if you're a monozygotic twin of someone with IBD. So it is an enriched population, but it's still the majority of those people who are first degree relatives are still not going to develop IBD.
My question is more the other way around, though. Like, who is like from the people that are diagnosed, who has relatives?
The majority don't. I think it's probably 70% or more that if you're newly diagnosed do not have any kind of family history. Yeah, it's good. I always think of it the other way around, but that's a good question. Yeah.
Just speak loudly.
Yeah.
Come.
And as far as this antibody, do you think there is any future in suppressing the antibody like FcRn therapy, you know, which is used, for instance, in other diseases like myasthenia and so on?
Yeah, I definitely think it's possible. I think we need to understand more about the antibody and if it has a direct pathogenic impact, which is sort of our next steps to be able to determine that. I also think another part is that all patients with antibody may not be the same. And the antibody level may be an important feature, but also looking at the functionality of the antibody may be another feature. So we may need to determine those factors before determining who may respond better or not so well to a direct antibody-mediated targeted therapeutic. So a lot to be done, but potentially, yes.
Inga, I wanted to ask you, there are data on microbiome disarrangements in other IMIDs, and I was wondering if there are studies, pregnancy studies for other immune-mediated diseases that we can draw from for these and compare to from the meconium and
for the diet. So there
Melody,
are multiple studies that demonstrate the link between the maternal health and the baby's diagnosis. But these are all mostly early onset diseases such as asthma, food allergies. So you can, observe them early on. For like IBD, this is the first study, and now we have Mommy and Me from led by Sunak in China, and so on and so forth. I'm not aware of a dietary intervention studies, the type that we conducted, that were during this exact time period when the immune system is primed. So when the dietary studies are usually are as good as you can follow the diet. Once you stop following the diet, the results usually show that everything goes back to where it used to be before the diet. Here, we're doing it during this critical time window that can have sustained effect. So my answer is, to the best of my knowledge, I'm not aware of other diseases and other studies.
But potentially applicable. Ahuva, metastatic Crohn's disease, is it underdiagnosed?
Definitely. And part of it is that we're not looking for it. I think it's also underreported. Even when we are seeing it, we may kind of just escalate therapy, may not get them referred to dermatology. So that's why it's important to recognize and talk about it.
One last question for you too. I was wondering how much of the integrin expression was accounted for by the goblet cells, that like very significant little group up there, 7 or whatever that was.
Yes. I didn't look at like how much is goblet cells versus enterocytes, but those were the two majority cells that were expressing it. I think it's hard the proportion within each cell type is still low. So most of the goblet cells were not expressing the integrin at high levels, nor the enterocytes. But this is also our single cell data, and this data set that I showed was all from healthy controls. And an important feature of the integrin is that it's low expression in health and then increases with inflammation or injury or other stressors, including cancer. And so potentially this will change in settings of inflammation. So really to be determined.
I have one question for Hani. Your top signal was glycosylation. right? So how do you interpret that? Is it because in your summary you are thinking that it's secondary to the, but could it be actually primary?
I still think it's probably secondary because what we're seeing is it's glycosylation of mucins, and specifically it's the glycosyl transferases in goblet cells we don't know it's specifically in goblet cells because it's both, but it's the genes that are mostly from goblet cells, these glycosyl transferases. And those were increased with expression. So whether it's a primary or secondary event, I can't say, but I suspect because it went along with some of the other data that was specifically to the goblet cells that this is a secondary event.
And my last question is for Ryan. Given the modeling by Alex, it means that we need a very highly predictive tool with basically a C-score of 75% at least. So maybe we are approaching that, but we need intervention which is highly effective.
Yeah.
So that means that, do you think there is any future in diet or microbiome therapy? It should be
a loaded question,
right? No, but
I think, well, I mean, yeah, no, I think for near term, for sure, I think thinking about a intervention that's at least 50% reducing the risk, 75% really, because you see the sample sizes balloon. You know, if something is decreasing the risk by 25, which a lot of the, diet modeling from, if you look at Nurses Health Study, things like that, it's like 25, 30% reduction in risk of IBD. So, but it doesn't mean you shouldn't do it in some way. I think it's people want to have something they feel like they can control directly. So I don't think it's wrong to advise on these things, but I do think if you're in the short term, higher risk group, likely more of a pharmaceutical, maybe a microbiome based, something that's going to be 50+% effective at decreasing risk. Otherwise, you're going to have just untenable sample sizes.
If we had more time, I was actually along the same lines. How do you choose that intervention? Because what prevents might not be the thing that treats per se, or is the best treat.
That's true. We have a whole bunch of trials we have to do, Sinyu.
Okay, great. Okay, so it's time to conclude. Thank you so much for staying until the end. So we need, as always, we have prizes that you can frame. Beautiful prize. So the first prize is a picture with me. The second is a picture with Soram. And the third is a picture with Ryan. No, actually, for the price, you will need to go to Erica because you will be able to buy something very nice at the Mount Sinai shop, like a T-shirt or a sweatshirt or something like that. So the first prize is for Jeremy. I hope he's still in the audience. Jeremy Fisher. Yes. Audience. The second prize is for Ryder. Ouais. And the third is for liquid. Liquid? So please come for the picture.
Oscar, maybe somebody can take a picture.
It's honorifique.
No, thank you very much. Thank you for staying and thank you for a great day.
Thank you.